चालेल ते डिसेबल केला होता. चेक चेक हॅलो हॅलो चेक चेक टेस्ट हॅलो हॅलो चेक टेस्ट चेक टेस्ट हॅलो चालेल ते डिसेबल केला होता. चेक चेक
check,
हॅलो
check,
हॅलो
test,
चेक चेक टेस्ट हॅलो हॅलो चेक टेस्ट चेक टेस्ट हॅलो
check,
चेक हॅलो चेक चालेल ते डिसेबल केला होता. चेक चेक
check,
हॅलो
check,
हॅलो
test,
चेक चेक टेस्ट हॅलो हॅलो चेक टेस्ट चेक टेस्ट हॅलो चेक चेक हॅलो चेक चालेल ते डिसेबल केला होता. चेक चेक
check,
हॅलो
check,
हॅलो
test,
चेक चेक टेस्ट हॅलो हॅलो चेक टेस्ट चेक टेस्ट हॅलो चेक चेक हॅलो चेक चालेल ते डिसेबल केला होता. चेक चेक
check,
हॅलो
check,
हॅलो
test,
चेक चेक टेस्ट हॅलो हॅलो चेक टेस्ट चेक टेस्ट हॅलो चेक चेक हॅलो चेक चालेल ते डिसेबल केला होता. चेक चेक
check,
हॅलो
check,
हॅलो
test,
चेक चेक टेस्ट हॅलो हॅलो चेक टेस्ट चेक टेस्ट हॅलो चेक चेक हॅलो चेक चालेल ते डिसेबल केला होता. चेक चेक
check,
हॅलो
check,
हॅलो
test,
चेक चेक टेस्ट हॅलो हॅलो चेक टेस्ट चेक टेस्ट हॅलो चेक चेक हॅलो चेक चालेल ते डिसेबल केला होता. चेक चेक
check,
हॅलो
check,
हॅलो
test,
चेक चेक टेस्ट हॅलो हॅलो चेक टेस्ट चेक टेस्ट हॅलो चेक चेक हॅलो चेक चालेल ते डिसेबल केला होता. चेक चेक
check,
हॅलो
check,
हॅलो
test,
चेक चेक टेस्ट हॅलो हॅलो चेक टेस्ट चेक टेस्ट हॅलो चेक चेक हॅलो चेक चालेल ते डिसेबल केला होता. चेक चेक
check,
हॅलो
check,
हॅलो
test,
चेक चेक टेस्ट हॅलो हॅलो चेक टेस्ट check, test, hello, check, check, hello, check, disable करो था, check, check, hello, check, hello, check, check, test, hello, hello, check, test, check, test, hello, check, check, hello, check, disable करो था, check, check, hello, check, hello, check, check, test, hello, hello, check, test, check, test, hello, check, check, hello, check, disable करो था, check, check, hello, check, hello, check, check, test, hello, hello, check, test, check, test, hello, check, check, hello, check, disable करो था, check, check, hello, check, hello, check, check, test, hello, hello, check, test, check, test, hello, check, check, hello, check, disable करो था, check, check, hello, check, hello, check, check, test, hello, hello, check, test, check, test, hello, check, check, hello, check, disable करो था, check, check, hello, check, hello, check, check, test, hello, hello, check, test, check, test, hello, check, check, hello, check, disable करो था, check, check, hello, check, hello, check, check, test, hello, hello, check, test, check, test, hello, check, check, hello, check, check, test,
Hello, check, 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 check. Hello, check, 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 check. Hello, check, 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 check. Hello, check, 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 check. Hello, check, 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 check. Hello, check, check. Hello, check, 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 check. Hello, check, 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 check. Hello, check, 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 check. Hello, check, check. Hello, check, 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 check. Hello, check, 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 check. Hello, check, 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 check. Hello, check, check. Hello, check, 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 check. Hello, check, 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 check. Hello, check, 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 check. Hello, check, check. Hello, check, 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 check. Hello, check, 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 check. Hello, check, 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 check. Hello, check, check. Hello, check, 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 check. Hello, check, 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 check. Hello, check, 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 check. Hello, check, check. Hello, check, 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 check. Hello, check, 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 check. Good morning everybody and very warm welcome for this single gate meeting. Linear EUS, EL-EUS, everything about EL-EUS. You all know there are a lot of things that have happened in the last 15 years or so in the US, and most people are moving towards EL-EUS and interventions and everything goes. Good morning everybody and very warm welcome. Moving towards linear as single gate meeting. With that EL-EUS, our EUS have a single linear about EL-EUS. Everything about EL-EUS, a lot of things that have happened in the last 9 years or so in the US, and most people are moving towards EL-EUS. So, interventions and what we learned in the last good morning everybody and very welcome program about exercising as single gate meeting. And that EL-EUS, our EUS have a single linear about EL-EUS. Everything about EL-EUS, a lot of things that have happened in the last 9 years or so in the US, most people are moving towards and what we learned in the last good morning everybody and very welcome program about exercising as single gate meeting. And that EL-EUS, our EUS have a single linear about EL-EUS. Everything about EL-EUS, a lot of things that have happened in the last 9 years or so in the US, most people are moving towards and what we learned in the last good morning everybody and very welcome program about exercising as single gate meeting. And that EL-EUS, our EUS have a single linear about EL-EUS. Everything about EL-EUS, a lot of things that have happened in the last 9 years or so in the US, most people are moving towards and what we learned in the last good morning everybody and very welcome program about exercising as single gate meeting. And that EL-EUS, our EUS have a single linear about EL-EUS. Everything about EL-EUS, a lot of things that have happened in the last 9 years or so in the US, most people are moving towards and what we learned in the last good morning everybody and very welcome program about exercising as single gate meeting. And that EL-EUS, our EUS have a single linear about EL-EUS. Everything about EL-EUS, a lot of things that have happened in the last 9 years or so in the US, most people are moving towards and what we learned in the last good morning everybody and very welcome program about exercising as single gate meeting. And that EL-EUS, our EUS have a single linear about EL-EUS. Everything about EL-EUS, a lot of things that have happened in the last 9 years or so in the US, most people are moving towards and what we learned in the last good morning everybody and very welcome program about exercising as single gate meeting. And that EL-EUS, our EUS have a single linear about EL-EUS. Everything about EL-EUS, a lot of things that have happened in the last 9 years or so in the US, most people are moving towards and what we learned in the last good morning everybody and very welcome program about exercising as single gate meeting. And that EL-EUS, our EUS have a single linear about EL-EUS. Everything about EL-EUS, a lot of things that have happened in the last 9 years or so in the US, most people are moving towards
With EUS, what we can see is the areas which are marked in black, area 2, 4, right, left, area 8, and area 7 here. These are the areas which marked with red we usually see with an EBUS. That also we will be coming soon. So, in mediastinum, when examining the area around the distal esophagus, this is the area 8 which we start our examination from. This is the starting point, and the point is the aorta, which appears on endosonography as a linear anechoic structure. Anechoic is it's completely black that essentially fills the whole field of view. So we start our examination of the mediastinum at the G junction. Then what we do is rotate the echo endoscope purposefully 180 degrees, keeping the aorta in view, just rotate it 180 degrees clockwise fashion to return to a neutral position again to the aorta, and then rotate 180 degrees in counterclockwise direction. So we just keep the aorta in view and rotate the scope and gradually withdraw the scope. This is done initially and then repeated, withdrawing every 1 to 2 centimeters. Small gradual withdrawal of 1 to 2 centimeters with a torque of 180 degrees on either side. The important thing is effective torquing of the linear echoendoscope is a fundamental skill that is required to perform a linear EUS competently. So how do you know that whether you are torquing your scope well? What you have to see is you have to see the numbers, the distance marks which are there, distance number on the scope shaft. And if you rotate around the axis of the scope, 1-to-1 torquing, the maneuver is being performed correctly. So if you see the mark, rotate again, you see the mark again on the other side, that means your torque is good. So this is something which is very important to do in any linear EUS examination. Two most important areas in linear examination, why are we interested, is to look for lymph nodes, to look for masses, and the two areas which we are interested in is the subcarinal space, that is the area 7 below the carina, and the aortopulmonary window, that is the area 4L and area 5. So the first method to see for the subcarinal space, what we do is begin the examination at the G junction, usually 35 to 40 centimeters, depending on the height of the patient. What we find is first we find the left lobe of the liver, identify the hepatic veins, identify the IVC, then rotate 180 degree. Exactly 180 degree behind this, and we find is the aorta. Once we find the aorta, what we see is, as I told you in the first instance, we have to just keep on torquing and withdraw the scope slowly. And at around 35 centimeters from the incisor, what we come across is a large anechoic structure again, which is the left atrium. This is an important landmark in mediastinal anatomy. Once the left atrium is found, we torque the scope and center the left atrium. We bring the left atrium in the center of the screen, then withdraw and get the left atrium to the left of the screen. Once it is to the left of the screen, a slight tip up, just we do a little tip up, the pulmonary artery will begin on the screen. And the area between the left atrium and the pulmonary artery is the subcarinal space. This is the subcarinal space. Just withdraw, see the left atrium, withdraw, bring the left atrium to the left of the screen. Pulmonary artery will be there to the right, and this area in between is the subcarinal space. This is the first method. Another method is locate the aorta in the middle of the esophagus. Slowly withdraw the scope with the aorta in view until the aorta disappears. This represents the aortic arch. It's the fall off of the aorta. At this point, we rotate, aorta is posterior, we rotate and bring it anterior, the scope, torque clockwise and bring it anterior. We see the tracheal reverberations. And we advance, just when we see the tracheal rings, we advance the scope 1 to 2 centimeters. These rings will disappear. This is the area of the bifurcation. And again, this is the subcarinal space. These are the examples. These are the tracheal rings. This is the carina which you see here. And this is the fall off of the trachea. And just below this, you will see the subcarinal space. Again, these are the cartoons which will be showing you how you exactly see. This is the trachea, this is the carina, and you find the subcarinal space here. This diagram will show you, this is the pulmonary artery, this is a big lymph node, this is the left atrium here, and this is your subcarinal space. Again here, this is an example of a subcarinal space which you see here. One important thing which my radiologist told me when I started doing my EUS, that in mediastinum it is very easy. Any structure which you find which is not a vessel or heart, it is an abnormal structure. So this is something which is very important, because in mediastinum you don't have too many organs to deal with. So it's very difficult to get yourself lost, and very easy to find out any masses or lymph nodes in the mediastinum. Now for the aortopulmonary window, what do we do? It is area 4L and 5 which I described. Underneath the arch of aorta, locate the aorta in the mid-esophagus, withdraw again as I showed you till the aorta disappears. After this, what we do is advance the scope little 1 to 2 centimeters underneath the arch, then 60-degree rotation clockwise and a little tip up will come on the dial. What we will see is a space between the aorta and an anechoic structure on the right side of the screen and the pulmonary artery on the left side of the screen. So this is here. This is the pulmonary trunk. This is the aortic root, pulmonary artery and the aortic trunk. And what you see here, these are the lymph nodes here. These are examples. Above the area of the aortic arch, the left and the right paratracheal area can be examined. So once we see the aortopulmonary area, we can just withdraw the scope, see the paratracheal area by just torquing the scope and withdrawing the scope to see if there are any more lymph nodes in that area, and we can see the area in area 2. The critical area 2, this is the critical area, the paratracheal area, to examine in patients with distal esophageal cancer, because if we find malignant nodes in this area, area 2, it is suggestive of a metastatic disease. This is a small video which I will show. What we see is starting here, you see the aorta. Here is a linear anechoic structure. You see a celiac takeoff here. What we are doing is just examining that area, and then gradually we will be withdrawing. Slowly, as I showed you, just withdraw, keep on torquing the scope, and once you see that, you see an anechoic big structure which is coming here, and that is your left atrium. So once it starts coming in view, again, we just keep on torquing. It's a little right and left torque slowly, and a gradual withdrawal, which will bring you the whole left atrium will be here. You can see the mitral valve here. And still we bring this now to the left of the screen, and we see the pulmonary artery which is coming over here. So essentially, now this is the area which is shown by the marker, which is our subcarinal area. So once you see this, if you are finding any nodes, what we have to do is position the nodes and do an FNA. This is again what I am showing you, the second method. This is the aorta, which I told you in the middle of the screen. We are just withdrawing slowly from the aorta. Once this aorta disappears, we will rotate the scope 180 degrees. And when we rotate the scope 180 degrees, what you see here, this is the aorta, pulmonary artery, and you come down to the AP window here. So these are the two sites which you see in the esophagus, and you will find majority of your pathologies in this place. One simple method, if you want to screen the entire mediastinum for any nodes, which has been told is, it is an alternative method. What we do is identify the aorta at the G junction, then the echoendoscope is torqued not 180 degree, we torque it 360 degree. So start at aorta, come back at aorta, 3 centimeters distal from the G junction, then again withdraw 3 centimeters, again do the whole maneuver 360 degrees. So if there are any structures, any lesions which are left, you can just screen the esophagus by torquing it 360 degrees on all the sides and seeing the entire length of the mediastinum. This is again a small example. We're starting at the G junction, and once we see the aorta, we start torquing 360 degrees. The whole scope rotates, comes back on the aorta. Again we withdraw, the whole scope rotates, come back at the aorta, and we keep on seeing the mediastinal structures. So it is essentially just rotating the structures. For the mediastinum, whenever we examine, we always examine the left adrenal gland. And it is an important landmark because it is important in staging of lung cancer, and it can be identified in more than 95% of the EUS examinations. What we do is locate the aorta, again at the G junction, and advance the scope where the celiac artery takes off. The scope is advanced along the celiac artery, and then slight clockwise torque. A little clockwise torque, you will always come on to the left adrenal gland. It is seen as a structure with a central body and two wings, which is sometimes we call as a seagull sign. This is how a left adrenal gland would look like. If there is a mass, you can do an FNA. These are a few examples of a left adrenal gland. So in mediastinum, EUS is not difficult to learn. Identifying the pathology is easy, as I told you, because it has only heart and vessels and no other solid structures. Precise, fine movements and torque is the key point and the key thing which we have to do in examination of the mediastinal EUS. Thank you so much.
Thank you, Pankaj, for a very succinct presentation. We would like to have a few questions from the audience. Any questions from the audience, please?
Thank you.
Pankaj,
Yeah.
one question.
Yeah.
Yeah.
Okay, yes, Suresh.
Now, what about radial scope? It has any scope, or it is obsolete now?
We have a third lecture, and Dr. Joseph is going to tell you, do we really need? Yeah, I think radial has still a scope. It's not absolutely gone. Probably in strictures of esophagus where there is malignancy, or when you want to see the radial scope is little thicker, it can't go. So probably in those instances when you are dealing with submucosal lesions, probably radial is a better scope to deal with. So, I think Professor Joseph is going to enlighten us on that. Thank you. Yes.
Bangalore.
Yeah.
You showed us the left atrium. Can you please tell us how to identify the other parts of the heart? Any catching points there?
See, the left atrium is the first anterior, it's nearest to the transducer. Just below it you see the mitral, and below it you will see the left ventricle, and just when you withdraw, what you see is the rest of the heart. It's not very possible to see, only you see the aorta coming from the heart and the pulmonary artery. So the two structures which you can see in majority of the cases, the left atrium, the mitral valve and the left ventricle. And then once you withdraw, because the rest will be away from the transducer, it's not very easy always to identify those structures, but you can see the aortic valve and the aorta taking off from the heart in that region. Okay, thank you.
Thank you, Pankaj.
One quick announcement, Ravi, just a minute. I didn't mention about the EBUS program. So we also have a parallel EBUS program today. So I think there may be some pulmonologists who will be coming in, but we've got Dr. Amit Damija from Gangaram who will be coming. We've got a couple of cases for live demo. He'll give a talk. And in the afternoon, 3 to 5, the EBUS program will be on the first floor in one of the meeting rooms over there. So where pulmonologists can interact with Dr. Damija and have some hands-on training on EBUS as well. So that's one thing. And I think Suhas has a couple of other announcements also.
All the faculty who are supposed to leave after the lectures to Dinanath Mangeshkar Hospital should get in touch with the registration counter. And we'll also be announcing the web link for the program as soon as we receive it. Thank you.
From Mediastinal Anatomy, proceed to biliary and pancreatic anatomy. May I invite Dr. Saurabh Gupta from Sydney?
Thanks very much to Dr. Bapai for inviting me up here. It's fantastic that he's running this conference, and it's excellent to see how we're concentrating on linear EUS, which is going to be the dominant form of EUS going forward, both in diagnostic, but more so going forward into therapeutic applications. So I'm doing this talk because Dr. Dhir was unable to make it, and so hopefully I can show you a little bit about the EUS of the biliary tree and the pancreas from the linear echo endoscope. So I think the most important thing we have to learn is our anatomy. Now, I know in India they stress, obviously, learning anatomy quite more than they probably do in the West. And so I have a lot of trouble with my fellows actually training them to learn the actual anatomy before they stick the scope down. They want to put the scope down and see everything without understanding the background of the anatomy of the pancreas, its relationship to other structures. And I think this is the most fundamental thing before we do endoscopic ultrasound, is to know the relationship between the pancreas, the stomach, the duodenum, and then obviously looking at the liver and biliary tree there as well. So if we examine our anatomy, we know that pancreas lies at the junction between the supra and the infracolic compartments of the peritoneum, with the transverse colon sitting anterior to the pancreas. The duodenal bulb is superior to the pancreas, as you can see. Do we have a pointer here? Or we'll just use the mouse? So we can see that the duodenal bulb here sits superior to the pancreas. The duodenal sweep, or the C of the duodenum, the concavity of the duodenum, sits, the head of the pancreas is tucked in amongst the concavity of the duodenum. And then you've got posterior to the pancreas lies the aorta, the IVC, and the common bile duct. And if we look at the uncinate process, and uncinate, it means hook process, that lies posterior to the mesenteric vessels, as you can see here. The hook goes behind the mesenteric vessels here, the superior mesenteric vein and superior mesenteric artery. Then we look at the definitions of what is the neck of the pancreas, what is the body of the pancreas, what is the tail of the pancreas. And that's also important to understand, both to make sure we're doing a proper report for our surgical colleagues and to help them identify exactly where the lesion lies. So the neck of the pancreas is actually defined by its relationship posterior to it, which is the splenoportal confluence, which is very easy to identify with the linear echo endoscope. The body of the pancreas, which is actually a triangular structure in cross-section, extends across the left crus and the kidney. It lies posterior to the stomach, posterior to the lesser sac. And then the tail of the pancreas is lying in the liano-renal ligament and goes all the way into the splenic hilum, as we know. So how do we go about doing EUS of the pancreas? Well, firstly, we advance the scope into the stomach, and just like Pankaj showed, the key landmark there to find if you're doing mediastinal work or if you're doing pancreatic work is the aorta, and you find the descending abdominal aorta. And the easiest thing then to find is the celiac artery takeoff, and it's a very simple structure. It's the first structure that comes off the aorta with the linear echo endoscope from the stomach. And immediately below this arises the superior mesenteric artery. These vessels, if you follow them down, they point, and I'll show you some videos, they point towards the body of the pancreas. From there, once you've identified that, you advance the linear echo endoscope 3 to 4 centimeters, and the actual body of the pancreas comes into view. Once you have the body of the pancreas in view, you need to start rotating, and generally, again, I don't ask my fellows to rotate the scope with their right hand. We don't want to torque the scope with the right hand. We want to use the entire body to use your left hand, which is controlling the dials, to actually rotate your body to help torque the scope both towards the tail of the pancreas and then the other way towards the neck and towards the head of the pancreas. So if you rotate clockwise while slightly pulling back on the scope, if you remember, the pancreas goes more cephalad as we go towards the tail, so it's heading up towards it superiorly. So we need to withdraw the scope as we're rotating clockwise. And then you get the tail of the pancreas over the left kidney and into the splenic hilum. From there, you need to then rotate counterclockwise and slightly advancing the scope, and that will find the body and the neck of the pancreas over the portal confluence. It's really important. Two most important places that lesions can be missed with linear echo endoscope in the pancreas is in the tail of the pancreas if you don't examine all the way to the splenic hilum, and the other spot is in the genu of the pancreas where it dips down. Often lesions can be missed, so it's really important to have the tip of the scope all the way up, so you're straightening out the genu so you don't miss any lesions in the genu of the pancreas. So if we look at EUS with a linear scope from the stomach, we advance our scope and we've identified the abdominal aorta, the celiac artery came off, and the superior mesenteric artery. And the body of the pancreas here comes into view directly under the transducer. The important structures here are the splenic artery and the splenic vein. If you identify those, you know you've got the body of the pancreas. And here I am rotating the scope clockwise and pulling back a little bit, and the splenic hilum comes into view. From there, I then rotate counterclockwise and slightly advance the scope. We've got the left kidney here deep to the pancreas. The body of the pancreas is here in view. Again, we're seeing our vessels, and that's superior mesenteric vein going into the splenoportal confluence. SMV, and this is the portal vein going here. So SMV, splenic vein, portal vein. And we can actually see from the stomach, often you can see the biliary tree as well, deep to the superior mesenteric vein. So now we move the scope through the pylorus into the duodenal bulb. To do that, we keep a slight tip up, and we go into the, we tuck the tip of the scope into the duodenal bulb. The easiest structure from there to identify is the portal vein, and that's your landmark. So in the stomach, looking at the body tail of the pancreas, the landmark is the aorta. And if you're looking at the pancreas from the duodenal bulb, the best landmark is your portal vein, easiest structure to identify. Then from there, it's important to identify the common bile duct, and that will appear between the portal vein and the transducer. With the linear echoendoscope, it doesn't appear as a longitudinal structure, it appears as a rounded structure. And it's a rounded anechoic structure, and deep to that, you'll see another smaller rounded anechoic structure, which is the pancreatic duct. And that's called the cat's eye kind of view. You have the two eyes of the cat staring at you. Once you identify the CBD, then it's important to examine the entire length of the CBD from the hilum of the liver down to the ampulla. So again, it's rotating the scope using the body and using your left arm, not using the right hand to torque the scope. And so clockwise rotation with gentle withdrawal of the scope heads down the CBD towards the ampulla, and conversely, counterclockwise rotation of the scope and slight advancement, very small distances we're talking about, a centimeter here or a centimeter there. So it's very subtle and small in terms of pushing and pulling of the scope, but the counterclockwise movement will head up towards the proximal CBD, common hepatic duct, cystic duct insertion, and the hilum of the liver. So if we look at how we do this, again, so the scope is in, and we've identified the structure, vascular structure here, which you can double check with your Doppler. And we've got portal vein. And then just between the portal vein and the transducer tip, we're seeing this anechoic structure here, which is the CBD. And we saw that there was a small stone in there that we saw from the stomach as well. So I'm just pushing in the scope and rotating counterclockwise, heading up towards the liver, which we can see here. And now we've got good views of the liver, the intrahepatic portal vein segments. Then again, we're following the common bile duct down with a clockwise rotation. Down, we're seeing the pancreatic duct here, and we're seeing our common bile duct appear there. So one thing it's important to know is don't stop the examination there. Too many people will say, I've seen the common bile duct, I've seen the pancreatic duct, I've seen the structures converge, I'm at the ampulla. And that's another area of concern where patients can have lesions at the ampulla or very distal CBD stones, which can be missed if you don't examine properly from the second part of the duodenum. So it's really important to finish the examination. We go into the second part of the duodenum to not only examine the ampulla and the distal ductal structures, but also the uncinate process. So again, we do our usual gastroscopy, paradoxical movement. We rotate right, tip up, and then we pull the scope back, and you'll get paradoxical advancement of the tip of the scope down into distal D2. here is where it's a little tricky because you have to keep the scope torqued a long way clockwise and the tip has to be sharply up to hold yourself in that duodenal, in the second part of the duodenum. Otherwise, you can easily slip back once you're trying to withdraw the scope. As you slowly withdraw, you can identify the ampulla just below the transducer, and then again, your two anechoic structures or your ductal structures will appear from the ampulla heading towards the 5 o'clock direction. They won't go directly down, they'll both head down towards the 5 o'clock as you look. The PD is the first structure that comes, and then the common bile duct will be closer to the transducer than the PD. So we're looking at the second part of the duodenum with the linear. So here we've got, and we've already identified now straight away our PD, ampullary region here, common bile duct coming here. But other important structures that we need to identify is the aorta. And then if we torque the other direction, we see our superior mesenteric vein and superior mesenteric arteries. And we can, if we've got the ability to do pulse Doppler, we can confirm which one's the arterial, and we can see easily that the arterial structure is the one deeper, and then the venous structure, the SMV, will be closer to the to the pancreas. And obviously this is extremely important in dealing with staging of pancreas cancers in the head of the pancreas, looking for abutment or invasion of the vessels in that region. And that will help our surgical colleagues decide whether a patient is resectable or not resectable. So really important to know our anatomy. I'll just go through a few quick, because we've got a little bit of time, just a few quick slides of some cases that we'll see. And obviously you'll see lots of fantastic cases that Amol has organized for you all. Here we've got a hypoechoic irregular tumor in the uncinate or head of the pancreas. And we're seeing an arterial waveform here identifying that there is a clear plane between the tumor and the superior mesenteric artery. But between the tumor and the superior mesenteric vein, we're not seeing a plane of tissue. So we can say that there is abutment to the superior mesenteric vein from the second part of the duodenum. Obviously, it's important for when we do FNA, we need to target the right areas. So we use our linear echo endoscope. Gallbladder is really important to look at as well. So we've talked about looking at the biliary tree. Gallbladder is often seen just in the pylorus, can be sometimes seen from the pre-pyloric region, and occasionally you can see it from the duodenal bulb. So if you don't see it and the patient hasn't had a cholecystectomy, you need to keep looking, because it's really important it may be in any of those three locations that you see the gallbladder. And why is it important? Because we often see small stones, sludge that's missed by conventional imaging with transabdominal ultrasound. Here is a nice example, again, in a patient that wasn't seen. This is the splenoportal confluence. This is the splenic vein, this is the superior mesenteric vein, and the portal vein. And this patient has pancreas cancer, which is invaded directly into the confluence. And we're seeing here a filling defect, and it's not a clot. And if you needed to confirm that, we can actually do an FNA of that lesion within the vascular tree as well to confirm that it's malignancy. Elastography, hopefully we'll see some cases during the day with elastography as well. It's a really nice tool to help determine the stiffness or the hardness of a lesion. And this quite clearly shows we've got a lymph node here, and it's quite hard compared to the surrounding duodenal mucosa and the deeper structures here. And also a very nice thing is to utilize the fine flow on the echo endoscopes. Both the systems will have fine flow as opposed to the regular Doppler. And that's very nice to assess for neuroendocrine lesions such as this one. We can often see it lights up like a Christmas tree with lots of vascularity, lots of flow. And that can help, A, make your pre-FNA diagnosis of what this lesion is, but also then to help us guide an appropriate area for a biopsy if we need to do that. And just last one, again, some celiac lymph nodes with elastography. So if there are any questions, I'll be happy to take it. Otherwise,
Any questions from the audience, please?
I think everyone's keen to get their hands on the scope and start doing it themselves.
Excuse me. Yeah. For biliary and pancreatic system, shall we start from the duodenal bulb and come up, or start at cardia and go down?
So I think it depends. I always like to start from the cardia. And the reason I start from the stomach is I like to get clues from the body tail of the pancreas as to what may be going on down in the head of the pancreas. So if I'm seeing changes of chronic pancreatitis, if I'm seeing duct dilatation, if I'm seeing atrophy of the pancreas, then I'm more suspicious there's going to be a lesion further downstream in the head of the pancreas. So I'm looking for lymph nodes in the celiac region. I'm looking for lesions in the left lobe of the liver. So I always start in the stomach. And people have described various stations to examine, station 1, 2, 3, and 4. I don't think it's absolutely important which order you do them in, but I think it's important to do all the stations so you don't miss things. But the reason I start in the stomach is to look for things that might upstage the patient's disease. So celiac lymphadenopathy, liver metastases, which we often see, and then we can target those for FNA, and we don't need to not waste our time, we still complete the examination, but we have already got our answer from the stomach.
Dr. Palni here.
Just a comment that while examining the bile duct from the D2, water is a good contrast agent that you can use to see the ampulla nicely.
Absolutely. And I think that's more important with the radial EUS. I think with the radial, you want to keep the scope in the center of the lumen rather than up against the structures. So I think then you can either use a balloon if you have the luxury of using balloons. I never use balloons. I don't think they're necessary. They're costly. They're difficult to put on properly. The nursing staff don't like them. So water is very good to transmit, but linear, I think you don't need it as much because the transducer is often quite up against the ampulla in any case.
A clinically suspected insulinoma, where other imaging modalities are negative and ask for an EUS, how difficult is, or do you have a special technique before you declare that nothing is seen on EUS?
No, I think we just...
Because the clinical situation is we had some 6-7 cases, out of which only 4 we could delineate. On 2 occasions we could say that we couldn't fix anything. And all other imaging modalities are negative.
For what type of lesion?
Insulinoma, suspected insulinoma.
Insulinoma. So what I would do in a suspected insulinoma case, I use contrast enhanced ultrasound. So I think it's very important, and that's a really good point, because we know that insulinomas are very small. We know that there can be isoechoic. Mostly they should be small, rounded, hypoechoic lesions, but often they can be a little bit more isoechoic to the rest of the pancreas. So what I do is I will always, in a suspected insulinoma case, use contrast-enhanced elastography, and that will then pick up a vascular lesion like a neuroendocrine tumor. So examine, if I don't see it, contrast, and then if I don't see it, I'm happy that it's not there.
How good is linear EUS for cystic duct stone?
I think it's very good. I don't ever use the radial EUS in pancreatic biliary work because I don't think it's necessary. The only occasion may be assessing for the ampulla and looking at invasion into the bile duct of an ampullary cancer. The radial may be a little bit better than the linear, but I think for all other applications...
Particularly cystic duct stones.
Yeah. I still think you can visualize the cystic duct confluence to the common hepatic duct quite nicely. And I often trace the cystic duct up to the clips if patients have had cholecystectomy, or to the gallbladder if they haven't. So I'll always try to visualize the cystic duct as well. And I think most of the times you can do that without a problem.
Could you tell us, please, about the scope in D2? You came up to D1 and D2. And when we go into the D3, probably we didn't discuss the anatomy then.
So looking at the aorta, the IVC, the mesenteric vessels. So I think we saw that, and D3 is a little bit more difficult. We can get down to the D2, D3 junction, but I don't think truly we can get around well into D3. I think it's important to identify the aorta, and you can sometimes see the SMA origin from there, but often you can't see the SMA origin from the D2, D3. Normally you're seeing that from up in the stomach, and so you can follow the SMA from the stomach for a length of about 5 or 6 centimeters from the stomach. So I think mostly you're looking at, as long as you visualize your mesenteric vessels deep to the pancreas and you visualize the aorta on the other side, I think you've examined the from D2, D3 region quite adequately.
And how much you instill? And or is your anesthetist comfortable with that? Not in ECG, I'm asking in stomach.
In the stomach? Yeah, I think as long as you've got a good relationship with your anesthetist and we discuss these kind of issues, and if it needs to be instilled, water needs to be instilled, my anesthetist is very comfortable for me to put in water, and I will use I don't have a foot pedal that can sort of directly instill with the echo endoscope, so I'll put in maybe 4 or 5 50 ml syringe so 200 mils or more, I'll put into the stomach, and the anesthetist is very happy. Often they'll deepen the patient's sedation before we do that to minimize any regurgitation, gagging, coughing that might bring up the water.
I think we need to stop here because of constraints of time. So thank you so much for your nice lecture, and we move on to the next lecture.
I'm pleased to introduce Professor A.J. Joseph, and he'll be talking on role of radial EUS. Professor Joseph, please.
Good morning, everybody. It's quite heartening to see how endoscopic ultrasound has matured in our country. And now we have a conference purely on linear EUS, and nobody's really talking about radial at all. So, as I say, you have to be careful about your enemies, but you have to be more careful about your friends. I don't know why I was given this topic by Amol in a conference that says everything about linear EUS. Okay, so we know that initially we started off with the radial mechanical endoscopes in 1980s, and the big technological advancement that came was in the early 90s, where 3 things happened. 1, the curvilinear array, 2, the electronic scopes, and 3, the ability to pass accessories in the plane of imaging. So these 3 things revolutionized EUS, and then after that there was no looking back. When we talk about anatomical planes with regard to radiological imaging, you're talking usually about transverse sections, sagittal or coronal sections. And I think we are most comfortable when we see transverse sections, because that's what we see every day on the CT scans. And therefore, I think when people started doing EUS, that kind of resistance to start doing it was least when you could just look at those CT images and then look at the EUS images and say, I can identify the structures, because it's actually quite disheartening when you start, if you put down the scope and you see structures you cannot identify, and somebody has to tell you, okay, that's a portal vein, that's a pancreas. So therefore, the radial EUS was something that people instinctively took to. We don't really see much when I know there are CT reconstructions, but we don't really see too much of coronal and sagittal CT sections. So like, for example, if you look at the transverse section through the level of the pancreas on the CT, you get a very, very similar picture when you do an ultrasound. The portal vein, confluence, the splenic vein, behind that the aorta, the superior mesenteric artery. So you get a very similar picture when you do, this is a transabdominal picture, but transabdominal or a radial EUS. The one advantage also of the radial EUS is that some companies do make radial EUS scopes with the front view. So if you're not very comfortable with the side viewing or a diagonal viewing instrument, a front viewing instrument can help you positioning at the apex of duodenum, places like that. Like I said, because we are used to looking at cross sections, I think there are 2 areas where staging becomes easy. One is the esophagus and one is the rectum. So the images you get on EUS are very similar to your CT or MR pictures. And therefore, it's very easy to learn that once you've already seen those images. So among the radial imaging modalities, there are 3 types of scopes: the regular radial scope, or a mini probe that goes through a regular scope, or sometimes even if you might sometimes need a bigger scope like a double channel scope, or there is a blind scope that goes over a wire after you dilate the stricture. I've seen this being used in a couple of centers in Mumbai, but this particular scope has actually gone out of production because it is not really being used a lot. The radial versus linear arguments, actually you don't see any literature on that now, but if you look at the 90s, and you will see some literature that has compared linear EUS with radial EUS in detection of gallstones, in detection of chronic pancreatitis, in staging of tumors. And generally, there is not much to choose between these 2 modes of imaging when it comes to pure diagnosis. You do find that in some locations it is a little tricky, especially when you are looking at submucosal lesions. Like I know in the, like inferior wall of duodenum, you're, doing a little bit of calisthenics with the scope in hand if you're using only linear. With radial, you really don't have to bother too much about where the scope position is. With mini probes, 3D rendering is possible when you have radial. It's quite easy. The exact applications I don't know because I don't use mini probes at all. But this is quite an easy way to reconstruct, for example, rectal tumors, where you can pass a mini probe, or even in the biliary tree, intraductal ultrasound, to reconstruct the lumen as well as the tumor. One particularly useful area is a submucosal tumor, especially with high frequency probes which have frequencies ranging from 10 to 30, because you really need only the first few layers. You're not looking for deeper structures like lymph nodes or vessels. In this particular situation, high frequency probes are particularly useful. And generally these are radial imaging probes, though linear probes are also available. In conclusion, cross-sectional type of imaging are easier to correlate for the beginner. So if you have a resistance to starting, it might help if you look at some radial EUS images. Forward views are possible. Staging, it's easy, especially in the esophagus and rectum. Easier for submucosal lesions with the radial probe or the mini probe, and for 3D reconstruction. Now the question is, it's always asked, I hear constantly people asking, what if I want to buy one scope, what should I buy? If you want to buy one scope, definitely linear. There's no doubt about it. You have to buy the linear scope. If you have money for 2 scopes, people might still say buy 2 linear. But if you are a training institute, I think you have to have a radial scope. EUS, when we look at our department complications, every month there's an audit of complications. EUS, of all the procedures, EUS has the least complications. EUS guided, this diagnostic as well as therapeutic EUS has got the least number of complications. There are more complications with ERCP and colonoscopy. So if you're still not doing EUS, I would urge you, just jump into it. Listening to techniques and in a conference is good. It's, you know the number of people doing it, but you just have to do it. It's probably hyped a little too much, the whole EUS thing. Okay, and when you look at endoscopists, there are 2 types of endoscopists. This is my last slide. There are people who use EUS as a tool to do something else, and I would compare them to fighters or bombers. I mean, really, you need to get the bombs to where you want to drop them. That's that is one type of endoscopist. There's another type of endoscopists who like to spend time. They're really not, they just want to collect a lot of information. So that's, I think sometimes it depends on your practice also. You might want to define every bit of anatomy that you're seeing and not really go in with a particular plan to do a therapeutic intervention. So these are like the AVACs, where you collect a lot of information and you come back with tons and tons of information that you analyze. So you know there are, in our country also, when you talk to people, there are people who go into anatomical ecstasies, there are people who do do it with the therapeutic intent. So it depends also on what kind of endoscopist you are. By nature, people are different. So yeah, that's my last slide. Thank you very much.
Thank you, Professor Joseph. Nice informative talk. And the talk is now open for the questions.
Actually there are too many people now doing EUS in my institute, so there are 5 of us who do it regularly, plus there are students. So it's again, what the simple thing I want to tell you is just do it. If you're not doing it, do it. I'm sure there must be I'm guessing there must be at least 300 installations in the country by now. Maybe somebody from Olympus will be able to tell me the exact number.
So, in our institute we have both one radial and one linear. Now can you just tell me which cases we should really use radial, only radial for diagnostic purpose?
It also depends a bit on the referral pattern. I don't get EUS for staging of malignancies at all. The only time I use radial EUS is for submucosal tumors, submucosal lesions, to define submucosal lesions. Otherwise, I don't use radial.
AJ, any thoughts on the learning curves?
I don't think it's it's a big learning curve, really. I really think this learning curve thing is a bit hyped too much. You just have to start doing it. And there is no single right way to do it. Sometimes you don't even have to do it. You just have to stand next to a person doing it. It's the number of images you've seen. Identifying the pancreas becomes easy after some time. You don't have to do the station-based approach. You put in a scope, you can see the pancreas. Like the radiologists who do ultrasounds. They know where the pancreas is and what it looks like. After some time, it will become like that. So it's not this learning curve is, it's very easy, it's very short.
Sir, since we are talking about the learning curve, would you recommend for the beginners to spend a couple of days or a few weeks with the ultrasonographist, or have him by your side in the initial 10-15 cases to understand and identify the structures?
Yeah, I think, we all, when we started, there weren't many people who could teach us how to do it. So we always would do a transabdominal ultrasound. And, even just to see what the pancreas looks like on ultrasound images, which you've not seen, because radiologists, at least in my institute, people are very compartmentalized. So radiologists do not like us to do ultrasound abdomens at all. So it was, those things were barriers to overcome rather than the learning curve. So if you've seen what the pancreas looks like, then you really don't have to have the station-based approach. So, but I think it does help.
Yeah, thank you.
Thank you.
Thank you.
Professor Lorenzo will be talking on, are we overdiagnosing chronic pancreatitis on EUS?
So thanks a lot. Good morning to you all. Amoy has asked me to go through with you this particular topic in the first session because this also gives an overview as an example of how we do or how we utilize linear echo endoscope in our daily practice. So I think he gave me this topic about chronic pancreatitis, which I think is relatively common in India. And the question is, why are we so interested in chronic pancreatitis? I think chiefly is because the pancreatic cancer rate is actually rising in many parts in Asia, similar to the phenomenon we see in the West. And this will become a issue because I think of the next big problem. Pancreatic cancer has a very high mortality rate, especially in the West. And it's actually very interesting. If you look at the cancer rates, there are two modes in terms of the survivor. Those cancers with high survivor and those with low survivors. If you look at it superficially, nothing strikes you. But if you look at it, all these rates a bit deeper, you know that most of the low surviving cancers are actually GI cancers. And then you ask yourself, why? Why? So I think it's mostly because GI cancers are hidden away from us. And the more the cancers are hidden, the tougher it is for us to find the cancer early. And that's where the next issue is we need to find a way to quickly diagnose the cancer early so that cancers early can be interrupted. So that's the only issue we need to deal with in daily practice. Otherwise, we end up doing EUS and we cannot. We're only doing a mopping up job, diagnosis, stenting, and then we are not changing the natural history of tumors. And that's where I think the next big thing is for pancreatic cancer is about what we are doing now with colorectal cancer. It's about finding early cancers, finding polyps, intervene, or like in Japan, finding early gastric cancer, interrupted early. But now we don't have a way. So one of the ways perhaps is to look at certain risk groups, such as chronic pancreatitis. The hereditary pancreatitis is still relatively uncommon. That's already a screening protocol. Then the question is whether we look for other risk groups. So one of which we know is chronic pancreatitis. Unfortunately, not all cases are equally at risk. And there's still a question about whether we target every single patient with chronic pancreatitis or just those with severe chronic pancreatitis, but the cancer rate seems to be higher compared with patients with mild chronic pancreatitis. We still don't know. We still need further research. But my point is perhaps we should start with seeing how we reliably agree in terms of diagnosis of chronic pancreatitis so that we can collectively embark upon some sort of surveillance protocol. Okay, so there's still a lot of unanswered questions. I think firstly, the previous speakers, Dr. Gupta and a few others have already shown how you use a linear echo endoscope to diagnose the pancreatic lesions, do pancreatic examination, and you know that the tough thing is because the pancreas is a posterior organ. So it needs something which is close to it in order for us to look at it reliably. So that's where I think the next thing is about the EUS criteria. We know it's useful. You know it's probably more useful than a lot of other modalities because of our superb ability to diagnose pancreas lesion at close range. So what about the diagnostic criteria then? The West, I think people have studied these issues for the longest time. They've come up with so-called the different criteria, Rossman criteria and a few others. So if you look at it, in the literature, they mention about 10 different features suggestive of chronic pancreatitis, and those are listed here. We all know them. But so some of those things are shown here. Some are easier to recognize than others, such as hyperechoic margins, the so-called tram line, and then also a lot of the small little dots here in the parenchyma. And then you have also so-called lobulation with honeycombing, and the longer hyperechoic lines called strands. And of course, you have all these features of the pancreatic duct which are irregular and dilated. So I think these are thought to be features of chronic pancreatitis. The worse, the more mark the features, probably the more severe the chronic pancreatitis is. And finally, sometimes you can see stones within the main pancreatic duct. So I think these are all the features people describe to diagnose chronic pancreatitis. So I think then, what is the cutoff then? Again, this issue has been dealt with previously. Sham published many years ago, close to 10 years now, that you need about 4 features in order for you to make a confident diagnosis of chronic pancreatitis versus gold standard of histopathology. But in this day and age, I think Amoy was wanting me to discuss a bit. Okay, with all these features, are we actually overdiagnosing? Because we find that when you do EUS in India, almost all patients have all these features. Then you are stuck, you see. So that's a very unusual country where a lot of patients have chronic pancreatitis. It probably cannot be the case. So our limitation currently is whether we are overdiagnosing chronic pancreatitis. And further, this issue is complicated by the fact that if you ask people about all the features, what is the confidence, what is the agreement between endosonographers in terms of those features? Actually, it's not very good. Okay, the best is only 0.6, which means your agreement is tossing the coin, whether you think there's this feature or not. So if you have all these problems, then you've got a problem between endosonographer with diagnosis. So we need to solve this. And secondly, as I mentioned before, when we were doing this, this is a precursor group of AEG. So when in those days, we kind of did a pilot study where we asked people to collect data from EUS for those non-pancreatobiliary indication, which means supposedly normal patients with SMT, for instance, and so forth. And then I asked them to look at the pancreas specifically. We found that a lot of patients, 80%, have at least one feature of those described, the Rossman criteria. And then 1/4 of patients have more than 3 signs. Then you've got a problem. 1/4 patient with chronic pancreatitis, so-called normal pancreas. So, and then this is where the high proportion, we got a problem. And secondly, we also did another study where we asked EUS experts to say that what would they actually, how many criteria would they use in order for them to diagnose chronic pancreatitis? So then a lot of them say that maybe 3 is good enough. So you can see there's a toss-up. 1/3 rule. 1/3 say 3 is good enough, 1/3 4, 1/3 5. So everyone, again, disagree. First, they disagree about the features. They don't agree on what constitutes the features. Then they disagree about the number of criteria and so forth. And then they found a lot of people with chronic pancreatitis in their practice. And the worst thing is, people are prepared actually use the number of criteria to actually treat the patient. So they are prepared to label them and then treat them accordingly, even though they are asymptomatic. So this is where I think the current status is. The field is still very blurred, and that's why Amoy asked me to talk. Is there overdiagnosing? So clearly there's a problem. So I think the only way around is perhaps we need to relook at these issues, I think, which has been talked about many years ago and has started losing interest. So we need to bring the interest back to force and look at the issue again one more time. And how do we do that is we plan to do it a multi-center study. I think some of you are already involved. For instance, I saw Sandeep at the back. We are already involved in this multi-center study. And the aim is really, firstly, I think we have to redefine the features and then come up with a way where we can use certain criteria to diagnose. And then after that, we look at all the other issues prospectively. So the first thing we wanted to do is, of the 10 features, which can be reliably picked up. Not all features can be picked up, okay? So then we did a reliably study where we show videos, quite a number of videos of different features to a panel of experts, 30 of them in Asia, and asked them to interpret videos. Some are normal videos, some are abnormal videos, some different videos of the pancreas, and just ask them to indicate. And from this study, for instance, I think it's a video. You can see that, well, whether you think that this dot is normal or not, and so forth. Whether you think there are some hyperechoic foci, and so forth, okay, in a prominent side branch. And also you have videos such as this, where you can perhaps see some stones within the main pancreatic duct. So I think we just toss it out and ask them to identify first. So that's a reliability study, and then the results were tabulated. Okay, again, not very good results. Many of the features cannot be agreed upon. So we took those features where we think they are good enough, to fair to good agreement. For instance, calculi, most people agree when they see one, and dilated side branches, most people agree. Dilated main ducts, cysts within the parenchyma, lobularity, and hyperechoic foci. So I think from among the 10, we picked 6, which are best agreed upon by people. Because I think if you want to actually use something which can be accepted by most people, you've got to make it simple for people. 10, if they are not agreed upon, no point using all 10. You rather use things which can be agreed upon and easily pick up. So then we choose 6. And then now we are in the process of validating these 6 criteria among people with normal pancreas and those with chronic pancreatitis. So how do we know people with chronic pancreatitis? So we actually did a so-called website study where all these patients who are recruited, the data will be entered into the web-based system. So this is a multi-center study, and these are the subjects up to June. We have more cases since that time. So I think different centers in Asia have participated in this study so far. And from the thing is, I think the diagnosis of chronic pancreatitis is based on other gold standards. We need a combination of CT, MR, and so forth. So I think this is just a preliminary results of the different indices to suggest how good these features are. So if you look at the 6 features, I think the best one perhaps is so-called hyperechoic foci with shadowing. It's probably the most sensitive and specific. Most people, actually, the patients with chronic pancreatitis have it, yet the patients with no chronic pancreatitis do not have it. So that's what we mean by very sensitive and very specific, and especially the MPV is quite good, which means if they don't have these things, probably don't have chronic pancreatitis. So I think we need to qualify is not every hyperechoic focus, but the focus must have shadowing at the back to be definitive. And then if you look at other features such as cysts and dilated side branches, although they are very specific, but they are not often found. So that's where the sensitivity is low. Okay? So then we know that if you just look at a few features, probably you cannot make a definitive diagnosis. You've got to actually combine the number of features. So then when we started looking at what's the number cut off, we found that actually 2 in this particular study, 2 is good enough for us to cut off, not like what they say is 4 and so forth. They're using a different form of calculation. We are using a practical way of trying to help people to make diagnosis. So we look at it differently. So 2 is the best, almost close to 100% for everything. You just need 2 of any of those 6. And when we constructed ROC curve, this is really good. Almost hit 1, which is perfect in terms of sensitivity and specificity. So I think our conclusion is, I think so far, with more data are coming in, we want a huge sample in order for us to be confident of our findings. So I think if you look at these 6 features, if you have any of these tools, then you have a very high reliability in terms of diagnosis of chronic pancreatitis. And we are thinking of in future calling these features the Asian criteria for diagnosing of chronic pancreatitis. So I think the study is still ongoing. Hopefully, I think we have something for us to do. And the next step is perhaps use this to actually start to collect cases of chronic pancreatitis and then follow them through. Because the ultimate endpoint is to be able to pick up early cases of chronic pancreatic cancer so that we can intervene early. So thank you very much for your attention.
Thank you very much for this nice lecture. A question I had for you was what should be the therapeutic strategy for these patients in whom you diagnose early chronic pancreatitis?
So I think, yeah, that's what we mentioned. I think once you have these cases, I think which I agree upon, I think the next step is we must actually, because of a number of cases, we should develop a consensus-based protocol about screening. So whether we say that, okay, among these patients, whether the more severe chronic pancreatitis, we should screen them every 2 years, the not so severe one every 4 years. And then similar to the early days of colorectal cancer, you know, the colon polyp study, where they have different intervals of studies. Finally, the agreed upon is 5 years. So I think we need to actually establish some sort of thing or screening protocol so that we don't miss cases in between. And then after that, I think it's also the next stage is perhaps, I think, early intervention, how to intervene in these people with small little lesions. Maybe it's using EUS, maybe it's surgery, I don't know. Because the future, I believe that EUS intervention is posterior side. So if you have a way, now with all the intervention coming in 10 years' time, when we sort out our devices, we can actually enter posteriorly, safely, and maybe we can do something to the small little lesions. I don't know. Similar to how we do for early gastric cancer. Hi, Joseph.
Hi. My question is, you mentioned this hyperechoic lesions with shadowing.
Yes.
And separately you've said calculi. What's the
difference
process behind that?
So I think the hyperechoic foci with shadowings are those within the parenchyma, whereas the calculi are within the duct. So now we from the 10 criteria, original Rossman criteria, we narrow down to 6. Of the 6, 3 are parenchyma criteria and 3 are ductal criteria. So I think you still need to have both in order for you to be confident.
I am willing to go live now.
One more question, just to pick your brain on this. We see a lot of patients with calculi. And what's the best screening test in those patients? You know that EUS is terrible to pick up focal lesions and the gland is full of calcifications.
Yeah, so I think if the first stop is still, I think we need to know whether those calculi are within the parenchyma, like you say, or screening for malignancy. We don't know the answer. That's where I think we certainly need more data in terms of screening for malignancy, because you're right. I think with all these things, I think it's potentially very challenging for us to pick up those lesions in the midst of things. And then there's also the thing that even if you see a mass, what do you do? Is this a chronic pancreatitis mass or is this a malignant mass? We don't know. So that's where I think a more longitudinal multi-center study with lots of cases is very, very important for us to sort out this particular issue. So no answer yet.
In a given case, is it advisable to do tissue diagnosis to prove early chronic pancreatitis?
I think currently it's still not recommended outside a research setting, whether this will produce a yield of chronic pancreatitis. So currently for studies, we are basically just establishing some EUS criteria. But in future, when we are doing surveillance, if we see a mass, then we probably have to. But I don't think it's justified now, because putting FNA is very different from taking biopsy. It's not totally risk-free. So we still do not actually recommend that. Second thing, I think if you want to really say you want the cellular or tissue confirmation, you have to do a biopsy, not the cytology. Cytology will not give you anything. So that's where I think at this stage, we still don't recommend taking biopsy to confirm diagnosis of chronic pancreatitis.
So, last question.
What are the changes in the pancreatic parenchyma in acute pancreatitis? And to establish a diagnosis of chronic pancreatitis, how much time period will we wait after an attack of acute pancreatitis to see if chronic pancreatitis changes?
Oh, so your question is a time interval between the first episode. I don't think there's any particular time interval, because I think assuming that this is the first episode of acute chronic pancreatitis, but the patient may already have chronic, so it's acute or chronic. So I don't think there's a definitive time interval between this. But I do think that the issue of acute pancreatitis is different altogether. I think we must first, establish an etiology for the acute pancreatitis, because the chief concern is whether we can prevent a second episode. Because the more recurrent episodes the patient has, of course, the more likely the patient is to develop chronic pancreatitis. So etiology is number one. Second question, I agree with you. So I think I would say that if a patient has acute pancreatitis and there's no other reason, I think we should still do EUS to make sure we look at the exclude structural lesion, exclude inflammatory lesion and systemic lesions. I think inflammatory is like AIP, and then systemic is like calcium and lipids, that sort of thing.
Thank you.
Okay.
So thank you very much, Dr. Lawrence, for your nice lecture.
Thank you.
I'm sure you all like this session, and most importantly, I think the speakers spoke so well, and we have finished before time, in fact. So I thank all the speakers. I thank my co-chairpersons, Ravi Gupta and Dr. Navratne from Colombo, and I'll hand over the mic to the moderators. Thank you very much.
Thank you, chairpersons. And we come to the end of the first session. We'll be starting live demonstrations shortly from the Dinanath Mangeshkar Hospital. And I would now like to invite the chairpersons for the live demonstrations. Dr. Manoj Sahu, Dr. Sandeep Pandey, Dr. Mukta Bapat, and Dr. Suresh Jain.
Hello, Suhas.
Hello. Yeah.
Hello, Suhas.
Hi, Amol.
Hi, can you see us?
We can see the endo image, endo
Okay.
and EUS image.
Yeah,
we can
okay.
see you. We can see you.
Are you getting a flicker out there or?
Flicker.
Okay, I think they're just connecting the,
Yeah.
checking the signal. Is it better now?
Yeah, better.
Okay, so welcome once again from the Shivanand Desai Center for Digestive Diseases, Dinanath Mangeshkar Hospital. We have our full team over here, Dr. Harshal Gadikar, Dr. Rajendra Pujari, Nachiket, I don't know where he's gone now, and Dr. Mahesh Mahadik, Tarun, Shiva and Rahul, our fellows currently, and Nilay and Pankaj, my close friends. They are always here for every course.
Amal, there is a lot of disturbance.
Yeah?
We have lost
Okay.
you. We have lost your image.
Okay, I think they're still trying to set the image.
Okay.
And we have Dr. Balasaheb Pawar, our pulmonologist over here.
Amul, just hold on. We
Okay.
cannot see you. I think it's okay.
I think it's better. Yes. So Dr. Balasaheb Pawar is our pulmonologist, and we have our international faculty over here. Dr. Shyam Vardharajulu from Orlando, who's going to start the first case, and Saurabh Gupta over here, who will subsequently be showing the next case in the other room. So the first case, I think we want to start with the basics, as I mentioned. So I've got the best guy to do that. And Shyam will be showing the anatomy and everything. So let's start off with the case. And this is the history, and someone will give the history. Arun?
So here we have a 27-year-old male who has presented 1 month ago with a history of epigastric pain associated with vomiting. At the index hospital admission, his amylase lipase were elevated, definitely more than 3 times. Amylase was 700, lipase was 1200, and he was treated for acute pancreatitis. And now he has presented with epigastric pain, and now at present amylase and LFTs are normal. But imaging has shown that CT abdomen showed dilated biliary system till lower CBD, and now we will demonstrate you whether this is acute on chronic pancreatitis or just pancreatitis. He has history of 2 years of alcohol intake, And now we will demonstrate you the further biliary anatomy and any complications and what is the ductal structure like.
Okay, good morning.
Hi,
Okay, thank you. Good morning. So this is a linear examination of the pancreatic biliary system, and I'll also show you the mediastinum. So when you intubate, there are three things to be aware of with a linear echoendoscope. The places where you can get a perforation is usually the cervical esophagus at the throat, and the second place that perforation can happen is usually at the duodenal bulb when you are trying to navigate. So it's important to be very careful with intubation, particularly in elderly patients aged more than 70, because for some reason they have got this thick cervical osteophyte that can create a problem at intubation. So let's go to and have the endoscopic image now. So now I'm going to just show you the endo view of how we intubate. It's what you want to do is to advance the scope under vision, direct vision, and then you go to the back at the posterior part of the tongue, and once you see the epiglottis, just tip down with your big knob and then slide in gently. If you can't advance the scope, never try to push it. You can always come back and use a gastroscope to pass a guide wire and so on, but never push it. And once you go in, you just slide it. And first let us look at the pancreatic biliary system, and then we will talk about the mediastinum later on. So once you go to the GE junction, which you can manually see on endoscopy, you just suck air and then you turn the scope, you will find the liver. So there are two ways of identifying the body of the pancreas. One, once you find the liver, all that you do is to torque the scope counterclockwise. So what you do is, can you just show my hand motion possible on a small view? You turn 180 degrees to the right. And if you turn 180 degrees to the right, you will almost always be on the pancreas. And see that? You're already on the pancreas right there. So I'll just use a cursor and demonstrate to you the pancreas. There you see the pancreatic duct, and this is the pancreatic parenchyma. So this will be the splenic vein. So once again, counterclockwise torque, you're on the liver. So once you see the liver, it's impossible not to see the liver from the stomach. You just turn 180 degrees to the right, and then you will be on the pancreas. And this anechoic structure in the middle is the pancreatic duct. A second way of identifying the pancreas is, you can see on my picture-in-picture view, you're at the GE junction, and once you're at the GE junction, you turn till you find the aorta. Everybody in the world who's walking around and moving around usually has an aorta. So here's the aorta, and then once you pass the scope down, the first branch of the aorta happens to be the celiac artery, right? So once you follow the celiac artery down, you will be on the pancreas, and this is the body of the pancreas, and for that you need to let go of the up-down. So once you have seen the pancreatic duct, you do a few things. You move your shoulder to the left and you turn the scope anti-clockwise, which means to the left, then the pancreatic duct goes to the genu. There is no more pancreas to be seen, and you can see here that the pancreatic duct is now taken all the way down to the neck of the pancreas. And what is the diameter of the pancreatic duct in the body? It's usually 2 millimeters. In the tail, it's 1 millimeter. In the head, it's 3 millimeters. So it's a 3-2-1 rule. 3 in the head, 2 in the body, 1 in the tail. And if you check the diameter of the pancreatic duct here, carefully, you will see that it is approximately 2.6, which is almost close to normal. So once you do that, you move your shoulder to the right, and then you gradually pull the scope. You gradually pull the scope. You move the shoulder to the right, and then you trace the pancreatic duct. As you keep tracing the pancreatic duct, you will see a structure inferior to the pancreas. It's got what we call an echo-poor cortex and an echo-rich inner portion. So this is the left kidney. So the pancreas that is superior to the left kidney denotes the junction between the body and tail of the pancreas. So if you've got an atrophic pancreas, usually the pancreas will terminate over the kidney, most common with chronic pancreatitis and pancreatic cancer. In a normal pancreas, the pancreatic parenchyma and the duct will terminate in between the left kidney and the spleen. So you still see the left kidney, and then you continue your motion, which is shoulder to the right, clockwise or right hand side motion on the shaft of the echoendoscope, and you continue to gradually pull back. And you need to constantly keep the pancreatic duct in view at all times. And the reason is that you need to see the pancreatic duct terminating into the hilum of the spleen. Here again is a pancreatic duct, here again is the left kidney, You continue to torque further and further, and what you will see now is the spleen and the pancreas terminates here. So this pretty much is a normal exam. There are a few things in the pancreas that you need to look for findings of chronic pancreatitis. But before we go there, once you have seen the spleen, what you need to do is to exactly repeat the opposite of what was done. You push the scope into the patient and then you gradually turn anti-clockwise, your shoulder to the left, and then you will start tracing the pancreas once again back to the neck region. And you want to do this a couple of times to make sure you're not missing a pathology. And there again, you see the cursor that is going into the hilum. So once again, clockwise torque to the right, moving the shoulder to the right, takes the pancreas and the pancreatic duct to the spleen. Doing the opposite, pushing the scope into the patient, anti-clockwise on your shoulder, left hand turn on the shaft of the endoscope will take the pancreatic duct to the neck of the pancreas. When you check for chronic pancreatitis, never look for chronic pancreatitis in the uncinate or the head region, because you've got the bile duct in the head and there's something called the dorsal and the ventral analaga in the head and uncinate region of the pancreas that may mimic findings of chronic pancreatitis. So the body and tail are the best places to find chronic pancreatitis changes. What findings of chronic pancreatitis do we have? There are two changes, right? One is the parenchymal change and another is the ductal change. In the parenchymal change, you want to look for lobulations, you want to look for strands, you want to look for foci, you want to look for cysts and sometimes calcifications. In the duct, you want to look for duct dilation, hyperechoic duct wall, side branches, and sometimes calcifications in the branch. So there are 9 criteria. Let's look at this patient. There is the pancreatic duct which is not dilated. We do not see any side branches. All that you find is a bright wall. So there is one feature. You see something called a strand. Everybody has got a strand. To be called a real strand, it has to be more than 1.5 centimeters, and these strands are not 1.5 centimeters. There are hardly about, say for example, let us freeze it at one point here. And you can measure the strand and see this probably I can tell you is only going to be like 6 millimeters at best. Let's keep moving. And you can see it's about 5.1 millimeters. So this patient actually strictly by definition does not meet any criteria for chronic pancreatitis. So we looked at the body, we looked at the tail. The only structure that we have not seen is the adrenal gland. How do you see the adrenal gland? Here is the aorta, you advance it. That happens to be the celiac artery where the cursor is. You push in 1 centimeter and then you turn to the right generally. You should find the adrenal gland in most patients. If you don't see it, that's all right. Here is the aorta. And once again is a celiac. Push in, turn, keep torquing, and you can see you have to be very mindful. Sometimes it's so small, see that? It just makes its appearance and it just goes back and forth. Especially a non-pathologic adrenal gland is very hard to visualize. See that? It just comes and goes inside. It's too small, can be difficult to see. Right there is the adrenal gland. It's called a seagull shape, and here is the seagull shape of the adrenal gland right there. See that? This one. So now we have looked at the body and the tail of the pancreas. It's pretty normal. We need to now go back. Yeah, you're about to ask something. So picture in picture view. Okay. Now I'm going to advance the scope into the into the duodenal bulb so that we can demonstrate the pancreatic head region. So now we are in the duodenal bulb. So once you go into the duodenal bulb, what you need to do is to look at the left-hand screen, which happens to be the lateral wall of the duodenum. Usually when you look at the lateral wall of the duodenum, you will find the right lobe of the liver. Once you see the right lobe of the liver, to identify the pancreatic head, what you want to do is to make a 180-degree turn on your shoulder. And then when you do that 180-degree view, you will always land up on the pancreatic head region. In this particular case, it's a thin patient. So once more, here is the right lobe of the liver. You turn your shoulder to the right, and then you see that when you do that clockwise turn, you will find the pancreas. Right there is the pancreas. Here is your portal vein. That is the pancreas. That is the gallbladder. Now this is a very thin patient, so you have to be a little bit careful because there is only so much parenchyma that can be visualized. See that he appears to have lot of collateral vasculature for some reason. I don't know why that is. He's got some collateral vasculature there, but everything else looks good. So what I will do now is look at this pancreatic head and try to see if I can find the bile duct and so on. See that this is all pancreatic head. What I have not shown you is bile duct, and I have not shown you the pancreatic duct very well, and here is pancreatic duct. There was the liver. This is the pancreatic parenchyma. If the bile duct is very small, sometimes it's going to be hard. So don't waste too much time. If you can't find all that you want, I don't see any mass in the pancreatic head. It looks pretty good to me. What I'm not able to show is to trace the pancreatic duct to the ampullary region. So you shouldn't waste too much time on it, because sometimes if the patient is thin, the anatomy can be challenging. So gently advance the scope into the second portion.
Can we ask you a question here?
Yeah.
So if you are not using the Doppler, how do you identify a structure which is a blood vessel as against maybe a duct?
Usually the vessels will, no matter what, will have flow motion through it. For example, if you look at it, you can see here, this is the portal vein, and we can see a movement within the portal vein, right? I mean, you can see this clear movement. Right next to it, you've got another structure there that does not have anything at all, that just looks very bland. It is very non-stationary. In other words, sorry, it is very stationary, and it looks, the walls of non-vascular structure, if it is of ductal origin, is more hyperechoic, whereas that of a vasculature is very, very thin. The second thing is the vasculature can be compressed. See that? You can push it in and you can compress the vasculature, whereas a ductal structure generally cannot be compressed. So those are the ways to differentiate. But if you are a beginner, the ideal thing to do is to just simply go in and put in a Doppler, and it's going to show you all the vessels and differentiate. And you can see that duct is not taking anything, and the vessels are all Doppler positive. So now, as we said, I have not demonstrated the bile duct, and we know that on imaging, the patient has a dilated bile duct. So I'm going to advance the scope into the second portion, and then you shorten the scope like what you would do for an ERCP. So you pull the scope just gently, but not fully down, and then you suck air. And when you do that, what you will find is there are two structures that you should always look for, and one will be the aorta and the other is the IVC. The aorta is not compressible. The IVC is a very compressible structure, and they're usually to the left of the transducer. So if you move your shoulder a little bit, you see this structure that's got a lot of vascular flow within it, more than likely the aorta. So see that? More than likely the aorta. And you can see the aorta in a cross section of 45 degrees. It starts on this half of the screen and it comes down. But what you want is this aorta to become flat, 180. Once it becomes 180, you will start seeing the pancreas coming back here, and that will be the ventral analaga. So what we will do is, there is the aorta, you gradually pull, you pull. I'm not doing anything except pulling back gently. Sometimes if you pull too fast, the scope falls into the stomach, particularly in thin patients. And as I pull back, see that there is the aorta, I am pulling back, you can see the configuration changes from 45 degree to 180. Look at that aorta and look at the amount of flow in it. So now, once the aorta is going to be almost 180 and flat down, right there, see that I'm going to pull back, and once it becomes flat, all that you do is to just torque the scope to the right, and there is your pancreas. And here you can see the pancreas, and within the pancreas there will be two structures that are non-pulsatile, and those structures are going to be the bile duct and the pancreatic duct. So here you see the bile duct on the top and the pancreatic duct below. So we call this the snake eye because they look like the eyes of a snake, better appreciated on a radial than a linear scope. If you got any confusion, put in a Doppler and you see that. See, there is no Doppler uptake on those structures, right? So keep torquing, and there we are. And it is very true that this patient does seem to be having a ductal dilation. Why it is, we don't know, but this maneuver is very important. And how much does it measure? It measures 7.7 millimeters. And yeah, and then I can take a picture of that. And then you got one more structure at the bottom, pancreatic duct, which looks pretty skinny. So you know here, this examination is very important because the issue is it's a dilated duct. Now you need to trace this duct all the way into the ampullary orifice. See, that is the papilla. That duct takes this bird beak appearance into the papilla right here. And this is a dilated bile duct with no obstructive mass or stone. So sometimes you may not find a stone from the duodenal bulb. It could be an impacted stone in the papillary orifice. But if the bile duct can be traced into the papilla and there is nothing here, then this is benign ductal dilation. And here is the pancreatic duct as well.
So Shyam, sometimes it's difficult to see the ampulla from this area. So does water insufflation help, or does the balloon help? Which is better or both are the same?
I don't I mean, I think if you are not able to appreciate the papilla, generally it's because the patient can have a small duodenal diverticula. In that case, I think water will help. But I think if you don't have a duodenal diverticula and you're not able to find the papillary orifice, one other thing that you can do is endoscopically you want to visualize the papilla. And once you do that, we do what we call the kissing maneuver. You just tip the scope up. Don't crush the papilla, just kiss the papilla by just touching it and suck all the air, and you will get a very similar view. Because you remember, I went to the second portion, pulled the scope. Right now I am just against the papilla, and you see this very nice view of both ductal structures going to the papilla. Another thing that you have to appreciate here is not in this particular case, maybe due to ETOH use, something that is not seen very well here, but in most patients you will find is the transition zone between the ventral and the dorsal pancreas. So you can see that in this case, as I told, it's not very obvious, but this pancreas is a little bit more hypoechoic than a rich hyperechoic pancreas here, and this is because of less fatty infiltration due to embryonic development, and this is what we call ventral analoga. On the CAT scan, sometimes they will say mass in the ventral pancreas not excluded. It's because of this transition, and even here you can see this transition. Where the ducts originate, it's more hypoechoic. Onto the right, it's more hyperechoic. It's normal. So go on.
Can we go on to the mediastinum because
sure.
we need to go to
One time. All right. So here is the bile duct again on the top, pancreatic duct at the bottom, and I'm just pulling back, and you can see how normal this structure is. Yeah.
Yeah, I'm Dr. Suresh Jain here.
Yeah, Suresh.
First thing is, does the depth matters?
What matters?
Depth. How deep we do the endosono, like centimeter wise, 7 centimeter, 9 centimeter. Does the depth matters?
No, Suresh, it doesn't matter, to be honest.
And the frequency?
No. I mean, generally you want to fix the megahertz at 7.5 and then nothing else matters. So it really doesn't matter, just follow those stations. So I'm now back at the GE junction, Suresh, and what I'm going to do is they want me to demonstrate the mediastinum very fast. Let's put the ultrasound view again. So once you manually identify the GE junction, there is the liver, you torque until you find the aorta, and once you have seen the aorta, what you do is just torque the scope 360 degrees until you find the aorta once more, come back 3 centimeters and continue to torque 360. As you do the torquing, you find this big pulsating structure, that's a left atrium. Pull the scope back 1 centimeter and tip up. And in between the there is the left atrium on the left and the pulmonary artery on the right side. And this is the subcarinal space, left atrium. And then there will be the pulmonary artery on the right side. And this space in between is a subcarinal space. This particular patient has a small lymph node, if you can appreciate. It's not a lymph node actually, it's a small effusion. There's nothing else, no nodes, nothing. And then once you do that, you continue to torque till you find the aorta. Come back another 3 centimeters and you torque again, and you will see these rings there. You see that hyperechoic ring? These are the tracheal rings. Any node here is the paratracheal node. You continue to torque, and there are some small lymph nodes. They are not pathologically enlarged. They are all benign. You torque and torque 360 degrees. You see the rings again. And generally what you will do is you will be landing up at the aorta. So come back another 3 centimeters. When that aorta disappears, you can see that aorta disappears there. That's the aortic knob. So you push in a little bit, and then you turn anti-clockwise, and then you will be landing at what we used to call the AP window. It is not the AP window, it's called 4L. The structure to the left is the pulmonary artery, the one to the right below the transducer is your aorta, and this is the 4L area, what we call the aortopulmonary window. Any node here is the AP node. Usually it's so hard to reach. Any node here is the 4L node. So this completes the examination of the mediastinum and the pancreatic biliary system. So GE junction, aorta, 360 degree turn, all the way to the upper sphincter. You will not miss any lymph nodes. Thank you.
So you always examine the mediastinum from GE junction up, or is there any way you can do it from above down also?
I mean, you can do it, but if you are going to, sometimes on the CAT scan and the PET scan, they will give you a landmark and they will say go after that lymph node. But if you want to be thorough and not miss anything, if you start at the GE junction and you systematically turn 360 degrees and you work your way up, then you generally will not miss anything. You'll be perfect.
Right. Suresh, are there any questions? Because I think we are shifting to the other room. So
any questions? Yeah.
Shyam, this is Sandeep.
Hello. Sorry.
usually how long we have to wait to assess the changes of chronic pancreatitis after an acute episode?
Don't have to wait, Suresh. I mean, there used to be this thinking, well, if somebody has got a CT finding of lot of peripancreatic fluid collection and inflammation is not a problem. Peripancreatic fluid collection, then, and if your concern is cancer, because after age 60, the most common reason for pancreatitis is pancreatic cancer. So there can be a small cancer that's hiding. In those cases, you want to wait for 1 month until the pancreatitis is fully resolved. On the other hand, if on CT scan, if you don't find peripancreatic fluid collections, you can go right away and do EUS to check for a small pancreatic mass. No problem.
Thank you, Shyam, for such a nice demonstration.
Thanks.
I think we'll shift to the other room now.
Yeah. So we welcome our next faculty, Dr. Pankaj Desai, who will be demonstrating a case of a patient who is a 40 years lady with who came to us with PO for 2 months, and she's a previous imaging thoracic CT had shown the multiple nodes in the mediastinum. So plan will be to show the mediastinal anatomy in detail and demonstration how we can sample these nodes. Over to you, Doctor. Yeah.
Hi. Good morning and thank you, Amol, once again. Shyam has just demonstrated a wonderful overview of the whole anatomy, and I will just not take much time, and we will just start, as I told you in my talk, that we will start at the liver, at the G junction. What you are seeing is the liver here, and yeah, okay. Once we start at the liver, what we will do is, see, this is the IBC as Shyam showed, 180-degree torque, as again we are seeing here. This is the aorta, and we'll trace the aorta, and what we find is the celiac. I am interested here in seeing the celiac because what I would like, because the patient has mediastinal lymphadenopathy, and we would like to see if there are any other abdominal lymph nodes. So just take a quick look at, this is the celiac trunk which you can see here, and landing on the pancreas. Yes?
Can you ask cameraman to focus on your hand movements also? For beginners it will be really useful.
Yeah, can you give a PIP here?
Don't zoom, zoom out and show both his hands.
Okay.
You don't need to show the face. Face cut झालं तरी चालतं.
That's body movements, hand movements.
Yeah, yeah. So that is better. That is better.
Okay. So again, this is the liver. We are seeing the IBC here. Now what I am doing is just see my right hand. I am just torquing it 180 degrees, and you land up on the aorta. And can I have someone here help me with the cursor? Yeah. So what we are seeing here is the celiac taking off. That's the celiac. And we trace the celiac, just gradually push and tip down on the scope. We'll end up on the pancreas here. This is the pancreas and the pancreatic duct. I am not interested in seeing the pancreas here. I am just looking for any nodes in the peripancreatic region, any nodes in the celiac axis here. So once we are satisfied that there are no nodes here, what I will do is just pull back on the scope. Just pull back slowly on the scope. This is the aorta again. Just keeping the scope anteriorly, I will just withdraw the scope so that we end in the mediastinum. In a moment, what we will be coming across, you are seeing this, as I showed you, is a large anechoic structure here. Can you see that? Yeah, where the cursor is pointing. That is your left atrium. There you see the mitral valve. Still gradually I am just withdrawing, just torquing a little, just a little more withdrawal, and what we come in view is I am trying to bring the left atrium to the left of the screen, and you can see the pulmonary artery on the right, and you see some mass which is coming here. Can you see that? Yeah, that is a mass, and that mass is a big lymph node sitting in the subcarinal region. Just withdrawing a little more. This is a big lymph node here, and the moment a little more withdrawal is there, on the right of the screen you can see the tracheal reverberations. Can you see that? That are the tracheal reverberations. So that is the area of the carina. So what I have to do is now I have to just position my scope in such a way that the node comes exactly here, because I will like to FNA this node from here. One more thing, we can just have a quick look at the rest of the mediastinum. I'll just keep on withdrawing. As Dr. Shyam showed you, this is the aorta. I'm just withdrawing, turning my scope right, and when the aorta ends here, a little tip up. These are again the tracheal rings which we are seeing anteriorly. And here we come to the aortopulmonary window here. There are big nodes. If the patient is coughing, can you just give her some sedation? So this is the area. This is another node which we are seeing here. So the patient has, this is the area of the aortopulmonary window. So I will be again just going down a little because we will target the biggest node which is there for our FNAC. Do we have Dr. Chantel here?
Yes.
Yeah, Dr. Chantel. Yeah. Can you comment what we are suspecting and looking at this node is probably this is a. Can you hold the scope, someone? Probably it is a variegated appearance. It's a big node, homogeneous, and some small fibrotic strands are seen there. Probability of Cox is very high.
I'm sorry?
It's probably of tuberculosis in this. So what is your recommendation as a pathologist? What would you like to have? You would like to have samples of smear, or would you like to have a core also of this node?
Well, ideally, we would like to have a sample of a smear so we can do on-site evaluation.
Yes.
Sometimes when you have fibrotic nodes, aside from tuberculosis, there can be other infectious etiologies for having fibrosis. And typically what happens is that you have granulomas. And granulomas happen to be a coalition of macrophages, which then form the actual fibroblastic proliferation inside the nodes. So ideally, we want to be able to do on-site evaluation, confirm the presence of granulomas. In addition to that, it would be nice to have material to take to micro so we can actually make sure that it actually happens to be tuberculosis versus other infectious etiology.
That's right.
Core is always great, but if you can do enough passes with a regular FNA needle, that can also be sufficient.
That's right. See, what I usually practice is we usually take FNA first, and then if we find a granuloma, we would take core and send it for culture. And also maybe if you take gene expert, yeah, that is routinely what we do at our setup. Anything else what you do in your setup, Amol, or anyone in the audience would
one thing that we would always do in a lymph node is take some sample in saline, because that is what you're going to be needing for TB culture, gene expert, all these things. Because lymph nodes in India mean tuberculosis unless proved otherwise. So you have to look for TB, and only when you're sure there's not TB, then you look for other things. That's how it is.
Okay. So quickly now, we'll just, what I am going to use, I am using a 22 gauge needle. Nilay has something to do.
Yeah, Pankaj, I think it's sarcoid, it's not TB. Okay. There is no necrosis, you can see fatty hilum, you can see those white strands going in.
Yeah.
So which
it's
goes
sarcoid
more,
versus tuberculosis.
Yeah, I think it is, because see, you do gene expert, you take TB culture, even if it is TB, it will come negative. I still remember in one patient where I saw necrosis, and I started AKT. Patient was very rich, went to US, that the diagnosis of sarcoid was done, and after 2 weeks the call from US came that it is not sarcoid, it is TB. So basically it's extremely difficult to differentiate most of the times whether it is sarcoid or TB.
That's right.
But if you see these white strands, you don't see any necrosis, I would rather err on sarcoidosis than TB. Because whatever you do, sometimes everything comes negative. Gene expert comes negative, TB culture doesn't come positive.
That's right.
So that's how I differentiate. I may be wrong, but that's the way I do it.
Right, okay. So basically what we are going to do now is take a sample. Can you focus here for all the beginners? Few small steps. Can you see the needle here? It has 2 locks. The lower lock is for adjustment of the sheath. The upper lock is all for the adjustment of the needle. And we have a stillet which is going inside. Okay. So the needle has to be in neutral position with both the leaves locked. What I will do first is I will open the distal lock and I'll try to bring the sheath out. You can see on the screen there is some, I'll just position it properly.
You'll visualize under endosono or endoscopy, the sheath?
I always visualize under endosono.
Endosono.
Pankaj, why you are using 22 gauge instead of 19 gauge?
I can use a 19. See, for 19 gauge, you will have a very bloody sample.
Yes.
And initially what we need is cytology. And for cytology, we can use either a 22 or a 25. 19, if I require a core from this, I will use a 19 gauge needle. You can see the tip. Can you see the tip coming out here?
Yes.
Okay, so that is the tip. So once that is visible, I'll just withdraw a little, just go back on it a little, and I just fix it. So this is the wheel. The sheath is just out. You can see that on the screen also, but I usually prefer to see it only on the endosono. The next thing we do is release the upper lock and slightly pull back on this stylet. Okay. So now once this is done, a lot of people would advise that you measure the length of the node and measure the distance which you have to traverse, and then fix this wheel accordingly so that your needle doesn't overshoot. What I prefer is, I prefer the vision on the screen and the control of my hands rather than doing any measuring of this. So what we will do is, once this is done, I will just try and get the needle in the lymph node, and it is in. So once this needle is in, I will go back to the stylet, just push the stylet in a little, and then gradually will withdraw the stylet, and I will try to make several passes. Yes?
Pankaj, do you use suction?
No suction for the lymph nodes, because that again will make the sample very bloody. And what I will try to do is, keeping the needle, I'll try to go to the margin of the lymph nodes. It said that if you get tissue from the margin, usually that is where you get good tissue sampling. So gradually we are taking out the stylet. Can you take out the stylet? Slowly, yes. And then.
So the reason for gradual removal of stylet is?
Yeah, it's proved that it has better cellularity with that, but it's okay. So what I am trying to do is, I am just with my big wheel, I am trying to go into different areas of the lymph node, and this is the technique which Dr. Shyam has defined as a fanning technique. You see my hand, I am just trying to go at different angles, go into different positions and make around 16 to 18 passes. And once that is done, I'll pull the needle back, take this wheel and lock the needle. It's very important that you lock it properly, otherwise you can damage the scope. That is done. Again, release the sheath and lock, and then we take out the needle. So this is as far as the sampling of the material goes. Now we will take this material on a slide, and Dr. Chantel is going to give us a result on site in a few minutes after we do it.
Pankaj,
you want to shift to the next room?
Pankaj.
Yes.
How do you do core biopsies with this?
How do you do?
Core biopsies.
Core biopsy, yeah. Usually what we use in our set, see, we have a pro core needle which is available now, but for practical purposes, I think what we do is with a 19 gauge needle, and that gives you a very good core. So if we need a core, we use a 19 gauge needle, make 4 to 5 passes, and that's probably giving us a very good core.
So again a fanning technique, or at one place only you have to give 4 5?
You can, I don't need to fan when you are doing a core biopsy. For cytology you need to core. You can take at 1 or 2 places only, because the core will be then adequate.
Pankaj?
Okay.
Pankaj?
Yes.
Initially when you brought the sheath out, you had some difficulty in focusing it on endosono view.
I'm not getting you properly.
No, when you initially before puncturing, you brought the sheath out.
Yes.
And it was difficult for you to visualize on endosono. I have this difficulty on 2-3 occasions. What is the difficulty and how you brought it into view? The sheath.
I am sorry, there is some noise in the room. I am not.
Pankaj, the question is how you visualize the sheath under endosono.
Yeah, I showed you.
No. What I'm asking is.
That's it.
For esophageal lesion.
Such a small.
Pankaj?
Yes.
Particularly in esophageal FNA. Visualizing the sheath is sometimes difficult.
Yes, it is difficult.
See, and how you corrected it?
No, you always, the sheath usually comes out a little bit more than you can see, and what I showed you, I withdrew the sheath a little inside. Just 2 or 5 millimeters inside after you see the sheath on the screen. So I don't try to see the sheath with my eyes on the endoscopy picture, never. That is not usually possible in esophagus, because you have to go away and sometimes you lose the lymph node. Now can you see they are showing you how to prepare the slide and smears there.
Yeah, Chantal?
Yes. So if you can slowly express the material
Make the picture
onto
big.
the slide using the stylet. The stylet would allow for you to have a controlled expression to make sure too much material is not expressed from the needle at once. So therefore, we try to see only one drop come onto the slide. Okay, that's good. Let's repeat. Okay, since we want to send this for testing, we're going to collect the rest in a petri dish and then add saline so then it can be sent to the lab. Even doing a visual inspection, you can see that there's more than just blood because you can see tan white fragments of tissue. So macroscopic evaluation of tissue is always encouraged. Okay? We like to make sure that all material is expressed from the needle. So you should always express with either air or saline to make sure you clear the needle of any residual material. And you can see you have nice tissue fragments. Okay, so we did this twice.
Yeah.
Okay. That should be enough.
Are you seeing there?
Yes. Okay. Needle
Yes,
pack.
yes.
Yeah, okay.
Suresh, were you able to see the entire thing?
Yes, yes, we could see them.
Okay.
Only the question is, why you put the sample in a saline separately?
No, that's for culture and gene expert if we finally realize that this is having suspicion of tuberculosis.
So here you can actually see on the smear that it's somewhat granular. So you can tell there's tissue on the smear and not just blood. It has a certain granularity. So
We can't hear you.
So here you can
Yeah.
see with the smears that it appears to have a granular appearance. So it's not just flat. Typically when it's only blood, it'll be very flat, but there's granularity. So therefore you can tell that there's actually tissue on the smear. So what we want to do is actually air dry the smear. So just by waving vigorously, the slides will dry relatively quickly. Then we have 3 solutions. So I'm going to open up the Coughlin jars. The first solution happens to be a methanol solution, and this actually takes and
5.3 by
fix the cells onto the slide. So it prevents the cells from desiccating, so it preserves the cells in their normal state. So we do a few dips.
How does alcohol spray compare to this methanol dip?
Well, alcohol spray is better if you're going to do Papa Nicolau staining in the lab. But this is actually for immediate on-site evaluation.
Pankaj, suppose pathologist is not there with you, how to assess the adequacy of sample?
We have to do it ourselves.
How many
what I do is I have a microscope and we use the DICVIC and we see at least if there is cellular and not only blood inside.
So,
we are not very
probably
expert.
Senthil, what
And
are the
otherwise
basic
the other
things
thing
that
is to
one should
take-
know?
Yeah, you take couple of more passes just to be sure that you don't lose out if there is no tissue much. But what I see, if you practice, if you see the material which is coming out onto your slides, I think that material will tell you whether there is cells or whether there is blood inside. If you start doing it, you definitely will realize that we have good cellularity on the slide. It starts coming when you start seeing lot of, take more samples and just see those samples before you go ahead.
So yes, even if you do not have on-site cytopathology support, you can evaluate macroscopically. So if a material being expressed from the needle appears to be completely red, most likely is blood. There are some exceptions. Neuroendocrine tumors are very vascular. Renal cell carcinoma is very vascular, so they will both appear to have a red appearance. Also lymphomas, because they're discohesive, they will also appear to be majority blood. However, if you're looking at fibrotic lesions and lesions that are epithelial, you're looking for tan white fragments. So if the specimen is only red, and it's most likely only blood. However, if you see tan white cores, then actually you're most likely have diagnostic material.
That's right.
So I think we are done with the staining. We just put it under the microscope and see if we can show you. Until then, we can just start with the other case.
Yeah, so I think Dr. Chantal along with Dr. Bide and Dr. Purandara who are here from our department, they will be staining the slides and coming back to us with an on-site report in a few minutes. Till then, we'll move to the next room, and Dr. Nilay Mehta will start is already got the scope in. So Rajendra, can you take up from there?
Pankaj?
Yes, yes.
Yeah, it was a wonderful demonstration.
Thank you,
very
Suresh.
much. Yes, Nilay, you're on. Yes, we can see you. No, not audible.
Okay, we'll just, they've already seen granulomas here, so let's just finish this. Okay. Yeah, so we'll just give the microscope image in a moment, and Chantal, you can probably describe.
Can we see that?
Can we show the microscope image?
No, we are not able to see.
This is
Yeah.
we can see Nilay actually on screen.
Thank you. Permanent.
Hello, OT number 4, can we see the microscope image?
Yes. Slides and Baddu.
Not yet. Okay.
Yes, we can see.
Yeah, it's there. You can probably demonstrate from there or other. That's not the one. That's not the image. That's not the image. Live image. We need the live image. Yeah.
बड़ा नहीं है, hypoechoic है. More hypoechoic than the other one. That is normal actually.
Amol, we are not seeing the microscopic image.
No, I think there. Give us a couple of minutes, and I think we'll be. We'll go to Nilay, and we'll come back with the microscope image whenever we are ready. Okay, we'll go to Nilay. Go to OT5.
Hello.
We'll check the microscope image in the background, and we'll go ahead.
Hi, am I audible now?
Yes, you are audible.
Yeah. Basically, again, this patient has mediastinal nodes. We have just placed the scope at G junction, but while doing so, what I found was node at the porta hepatic. Actually, I'll show you how to go about it. Like at G junction, what you see is liver. That's the left lobe of the liver. And to
Nilay,
yeah.
Can I interrupt you while?
Yeah.
Dr. Rahul is here. He's going to tell
Give
us
the history.
details
Okay.
about the case.
Okay.
Good morning all. This is a 70-year male
Oh,
patient.
little louder, Rahul.
This is a 70-year-old male patient who was diagnosed as a transitional cell carcinoma of bladder 3 years back, for which he has underwent TURBT and intravesical chemotherapy. On further follow-up, he has diagnosed as a mediastinal and periportal lymph nodes. On PET scan, it is pick up. Now we are planning to do EUS mediastinal and do EUS FNA.
Okay. Really we need to see whether there is any metastasis in the node or not. Okay. So this is at the G junction, and the first thing what you see at G junction is liver, left lobe of liver. My way of seeing mediastinum is a little bit different, and also how to see porta hepatic region. So I go to the GE junction, and then I see the left lobe, and I see the hepatic vein. And you can see this hepatic vein, you can see the hepatic veins going towards that yellow spot. That's where the IVC is there. You can see the hepatic vein. Stop.
Yeah, yeah.
Can you stop it?
Yes.
You can see this cursor. Yeah. These are the hepatic veins, and IVC will be somewhere over here. So all these hepatic veins will converge into the IVC, and that's what I try to find and see where they go into the IVC. So you can see the IVC now?
Yes, yes.
Yeah? So when I see IVC, I do a clockwise torque, a little bit. So you can see the hepatic veins going into the IVC, and then I do a little bit of clockwise torque and pull. My journey is all the way clockwise torque. So you can see now the heart is coming because IVC is opening into it. Now you can see the right atrium. And if you do a right turn, that is clockwise turn, then you can see the aortic outflow also. But that's not what we want to see. We want to see the subcarinal space. So I am again pulling. And then this is the subcarinal space.
Rajendra.
You can see on the left side of the screen is the left atrium, and on the right side of the screen is a pulmonary artery. So basically this node is not actually a subcarinal, but little. So I'll just torque the scope in this space and see where the node is. So this is the node. But I don't think it's too big a node. I would just, if there was no history of malignancy, I would just pass it as a normal node. I'm sorry about my voice because of upper respiratory tract infection, but I'll just enlarge the view so that you will appreciate it better. So you can see a node into the subcarinal space. But if you see the feature of that node, I don't think it is hypoechoic. It has got fat into it. It looks quite okay to me, frankly. So this is subcarinal space. To see AP window, I'll do again pulling and also the counterclockwise rotation. That is towards the left. So my scope, you have to focus on this hand. So when I do it, again counterclockwise, so the pulmonary artery will come into the left side of the screen, and on the right side of the screen you will see aorta. Before that you will see the tracheal ring, the subcarinal ring. You can see the rings over there, next to the transducer, and you pull a little bit more, and you will see the AP window. So basically,
so it is a 180-degree rotation.
No, I don't do any 180-degree rotation.
You just follow
so this is basically the AP window.
Right.
I just do a clockwise, counterclockwise rotation from the GE junction and start pulling.
Yes.
That will show me subcarinal space and AP window both. I pull it again, and then you will see the aorta and the great vessel coming out of the aorta, as you can see over here.
Yes.
So that's how I complete my subcarinal and AP window. Of course, if you need to see other, like if there are some lower periesophageal node, or you want to see the hilar node, where do you see the hilar node? That is when you see the subcarinal space. So this is the subcarinal space. A little bit, just a 1 centimeter above the subcarinal space, turn right and left, torque, and then you will see the hilar nodes over there. So this is aorta. So if the hilar nodes are enlarged, you will see in this space. And further anti-clockwise torque, will see this ring and then the AP window. So there are no nodes in the AP window. There is a node into the subcarinal space, but I don't know. I don't think it's too pathological. Stop. You see, this node doesn't look to me very.
Dilay, what made you to think that this lymph node could be just a reactive?
See, I like more hypoechoic node.
Yes.
There should not be too much of normal hilum thing.
Okay.
There should not be those white streaks in the node.
Right.
Then I would say it is more pathological. Of course, if you have a history of malignancy, you have to take biopsy, even because I think the PET has shown avid areas, right?
Yes, yes.
Yeah. So that suggests that you have to take the biopsy. This node, of course, you have to see that 9.4, which is more important, 38 and 9.4. But now let us go back into the abdomen, and this is liver actually again. And how do I see the portahepatic region? Again, I see this IVC. I push a little bit more. When I push and do anti-clockwise rotation, I see hilum. And there is a node at the hilum. So you can see the liver, you can see the portal vein, and then there is a node, and then there is hepatic artery. So this is the portahepatic region, and this is the node.
Yeah.
It looks more hypoechoic to me. I don't know in PET which is what, like, you know, what's the PET report shows, because I want to target my lymph node biopsy according to what the PET shows. I don't want to just put needle in any node. So the PET should guide me. The other way to see the portahepatic region is go to the pancreas, and in pancreas you will see.
Nilay, all lymph nodes have been shown to be metabolically active.
Okay.
So you can.
So even that subcarinal one.
Yeah, even subcarinal will also.
Okay.
Be suffice.
So what do the panelists say? Which lymph node should I target? Dr. Lawrence Hoy is here. So what lymph node should I target? This one is, yeah.
I think the other one is probably more looking like draping lymph nodes, which is more reactive. I think this one is rounded, ovoid, and very homogeneous, as you mentioned, especially in the portal hepatis. And the second reason is you do want to get away from as far as possible from the main lesion.
Right.
So this is where I think
and so the other way to go into the porta is when you see in the pancreas at the genu region, you will see this SMV and confluence, and then you have to pull the scope and turn the scope to the right, and that will lead you to the portal vein and eventually to the portahepatic region. So again, I have gone to the portahepatic region. So again, this is pancreas, the body in front, and then head below the vessel, and then when I follow the vessel counterclockwise and pull, and then it goes into the liver. So again, it has gone into the liver. This is portal vein, and so we'll target this lesion. Can you hold the scope, please? Yeah.
What gauge of the needle are you using?
I am using 22 gauge needle.
Right.
Here you can use any of them because you want to really know for the metastasis. You are not worried about any other diagnosis. And so what I'll do is, this is 22, right? I'm using expect needle from Boston Scientific, just leave it. Expect needle from the Boston Scientific, and I'll just put it in the channel, and then I'll do a lure lock of the needle. Now can you focus it over here? See, how to bring out the needle is very important. This is absolutely mandatory, because if you puncture the scope with a needle, you have a big damage to the scope, and you will have problems of the repair. So I'll just unscrew it. This is the thing which will take out the sheath. So what normally the needle is at 1.5 centimeter, and that is where probably this is not a problem, because this is a straight scope. But if you are into a duodenum or very bent thing, then you have to be absolutely sure. So what I'll just unscrew it, and I'll push the needle in. First take it out to the 0, push the needle in. When it goes away from the, means it comes out of the scope, comes out of the elevator, I get a feeling, I get a giveaway feeling. That tells me that I have come out of the scope. The elevator gives me that feeling. And then I'll just pull back a bit, and then just fix it up. I don't have to do anything about it. I even don't see, there is a node there also. Yeah. So this node, which is below the portal vein, you have to go into the first part of duodenum. Yeah.
Actually, we couldn't hear Professor very well.
I'm sorry?
We couldn't hear the Professor Lawrence very well. What?
Yeah.
How you
Professor, they want to hear you back.
I just want to know how you decide, which node you decided, and on what basis.
Okay.
Just explain why this node is selected. Yeah, I think if you look at this lymph nodes versus the one in mediastinum, which is a subcarinal node, I think the one in the subcarinal node is more a draping node, which means it's very ovoid and then very stretched out. Especially there's a comet, there's a tail there, and usually it signifies a draping node, which usually is benign. Not uncommon at all, we see in the subcarinal region. So this way, I think the chances of getting a positive yield is probably lower. Whilst this one, we don't usually see a portal hepatis node. Furthermore, I think this node is a bit, is more rounded. And also more homogeneous in looking. And generally, those features are more likely to be malignant nodes. And that's point number one. And point number two is, I think we want to target away as far as possible towards the abdominal side rather than the mediastinal side. Because if it's positive there, I think it's more likely to know that this is metastasis as opposed to a regional node, which is in the mediastinum. So I think that's the reason why I think Nile has chosen very cleverly that this is a place to target for the cytology.
And this node is approximately this much. It's 12 by 15. Yeah, you want to go back? Okay. So I'll start the Doppler and see whether there are any vessels in the path, because the needle will come out from this and it will be like this. It will come out like this. So, okay, cursor out, flow out, and then see, this is not the place I will be doing biopsy like this. It has to be like this. So how do you position your lesion is when you push the scope, the lesion moves toward the right. When you pull the scope, the lesion moves toward the left of the screen. The other thing is, what you do is, when you do a big wheel up, it tips up the lesion to the transducer. When you do big wheel down, the lesion will move away from the transducer and it will go towards the right. So now let us start doing FNA. Can you take
Would you keep the flow all the time?
No. I'm just trying to take it out. It's it doesn't want to go. ऐसा पकड़ना भैया. So now how do I start my FNA? I'll just, if you see this, the needle is in. I'll just take out needle a bit so that there is no stylet inside the needle for few millimeters. How do you do it? Okay. So the needle has come out. You can see the needle. I'll just do the movement. You can see the needle. You can see that green mark, and you can see the needle. And I'll just see which one. Okay, yeah. So this sometimes it is very tricky in perigastric region because lesion keeps on moving, as you can see over here. But that's fine. So I have reached near the wall, and then I'll do a jab, and I'm inside the needle. Then, excuse me, sir. Then
focus on this.
Yeah. Then I'll push the stylet in, so that you could see the stylet going into the needle, and then my partner will start pulling the needle out. Can you? So, slowly. I want you to do it slowly, okay? Otherwise, take it out, no problem. Take it out. Normally, at home, I do it is slow pulling method. Here, I'll just take out the entire needle, take it out. This is what I don't like. Actually, I should be in the right side of the lesion. I am on the left side of the lesion because I always try to go from the right. Okay, but that's fine. So I'll just pull the scope. Yeah. I'll pakad ke rakho bhaiya. It moves quite much. Okay, I puncture it again. So now 1, 2, 3, 4. And again, you do it your needle movement with the index finger and thumb. भैया ऐसा पकड़ के रखो उसको, खींच के रखो, है ना? Then I'm doing the fanning thing, so the needle remains in the lesion. It doesn't come out, and then I change the axis. I always go from right to left because that is better. And always try to take a needle into all the region. You can see I'm going at the periphery of the node. This is very important.
Nila, what maneuvers do you do to do the fanning technique?
Yeah, as I told you, I'll show it. Shall I do it again, or this is out? This is done actually.
Done. Okay.
Yeah. So what I'll do is I go to the right side of the lesion.
Right.
Do 4 passes. Anything between 3 to 5 passes are good enough. So first position, see the lesion, position the lesion.
Yes.
The lesion has to be somewhere here in the natural path of the needle without elevator, because as far as possible don't use the elevator. Start from the right edge of the lesion, do 3 to 5 passes. Then you have to do 2-3 things. You can pull the scope as I showed you, and that move the needle into the other path. The other thing you can do is use the elevator. That will also change the path. And the third thing you can do is turn your shoulder.
Okay,
and
Nilay,
these 3 things will change the path of the needle.
You don't use negative suction?
Oh, I never, in lymph node, never use negative suction unless you do it without suction and you get 2-3 dry taps. Almost always in lymph node you do it without suction, or I do a slow suction by pulling the needle out slowly, which is called pull maneuver. That is what I usually do, and that gives me the best result as far as FNA is concerned.
Okay, Nilay,
yeah.
We are ready with the next case in the other room, so we'll just move to room number 3. And Dr. Chantal and Dr. Bide, the pathology team, they will prepare the other slides, these slides as well, and they'll come back with the microscope. The microscope is now ready. So we'll just see Dr. Praveer Rai in room number 3 and then go to pathology. Okay?
Thank you, Nilay. Wonderful.
Thank you.
So room number 3, Praveer, I think Harshal is there with him.
Thank you, chairpersons. We'll now be thank you for chairing this session, and we'll be calling the next set of chairpersons. Dr. Rajkumar Wadhwa, Dr. Kiran Peddi, Dr. Suvadeep Chatterjee, Dr. Lalit Shim.
देख लेते हैं. लिया नहीं है ना? इसका पहले लिया नहीं है ना? तो ले लेते हैं ना, पूरा बराबर ले लेते. नीडल आए बाद में ना? आया है ना?
Can you hear me over there?
Yeah, we can hear you.
Who?
Yeah, we can see you, hear you. This is Lalit Chimpi.
Okay. Okay. Yeah.
Good morning.
Yes, from room 3. This is 37 years old gentleman who has presented with 1 year history of mild epigastric pain and 1 year back he had a small volume hematemesis. And since then he has been having intermittent melena, not requiring blood transfusion, but he has a history of iron sucrose blood transfusion. And on scopy elsewhere, there was a antral lesion that was superficially ulcerated. So here we are interested in seeing that what is the submucosal layer of origin of this tumor and whether FNAC is to be done or straight away the patient can go for a definitive treatment. So antral submucosal lesion with history of upper GI bleed.
How big is the lesion?
This is 3 by 3 centimeter.
Okay, so I have passed in the scope, and right now we have a patient, 30-year-old, presented with hematemesis earlier, now just having melena. Endoscopy done outside shows a submucosal lesion which is around 3 centimeters in size, and he is having recurrent melena for the last 1 year. So one thing is clear, this patient is definitely symptomatic. So symptomatic patient with a submucosal tumor. So the purpose of examination here is primarily to see what layer this lesion is arising from, one. Second is what is the size of the lesion, the exact size of the lesion if you can see that. Third is what is the nature of this, possible nature of this lesion, whether there are some features which may suggest malignancy in this particular case. And obviously the primary step is to differentiate between an intramural and extrinsic compression. So with this intention we have passed in the scope. I think while passing you can obviously see the mediastinum. It's very important to do the complete examination and a quick go which you can do in a minute or so in the mediastinum. As has already been shown, what we are seeing right now on the left side of the screen is the left atrium, and on the right we have the pulmonary artery, and the area as has been shown earlier is the subcarinal space. I'll just point it out and we'll come to the region of interest straight away. So this is the subcarina, and I'll just show you another method of reaching the AP window. So you see the aorta, so this is aorta, and you just pull back on the aorta, you can see the reverberation artifacts of the aorta. So this is the aorta, and you just pull back the aorta, the aorta arches, and once the aorta arch, you can push in a centimeter, rotate with the tip up. So once you do that, you can see aorta on the right side and the pulmonary artery on the left side, pulmonary artery on the left, aorta on the right. This is station 4L, this is station 5. So we have examined the mediastinum very quickly. So we go down and we will straight away reach to the region of interest. So we are in the stomach right now, we need some air. So we have already instilled some water here. So we, on upper GI, as I am told, we have a lesion in the antrum, and now we have reached the pylorus. We'll reach the pylorus, endoscopic view. Okay. So, okay.
Dr. Pravir, if you have antral or gastric submucosal lesions and you have a radial scope, do you tend to use that? I mean, keeping aside the fact that you want an FNA if it's a large lesion,
yes.
Would you prefer a radial, and do you think linear is as good if you want to?
Usually I would go ahead and do with a linear first, and sometimes if I am not able to pick up the exact wall layer, I may think of using a radial. So we have reached the first portion of the duodenum. I just want to be sure that this lesion is not arising from the pancreas. So I'm in the first part of the duodenum, EUS image, air off. And then now you can see straight away the portal vein here, the bile duct running in front of it. I'll just show you by the cursor. So this is the portal vein, this is the pancreas, you have the pancreatic duct here, and you can see the pancreas is relatively free. Adjacent to the pancreas, we have got a hypoechoic lesion here, so big in size. So this I am imaging from the first part of the duodenum. This lesion obviously appears to be separate from the pancreatic tissue. So this is the pancreas, that is the portal vein, that is the bile duct, the pancreatic duct, and this is the lesion. So this is the lesion, and in the lesion, if you can see, so this is a large lesion. So as I mentioned, the important points that we want to see in the lesion are first the wall layer, which layer it is arising from. So to be certain what layer it is arising from, you need to be sure of the transition zone. You can just freeze this right now. Okay, so some points here straight away. One, this is a large lesion, irregular outline. You can see the outline which is irregular. Along with that, you can see areas of anechoic areas here. So large lesion, anechoic areas, and if you measure the size of the lesion, this is around.
Praveen, I'm sorry, you're from the first part of duodenum or from the antrum?
This is from the antrum now. You have slipped out, and now the lesion is in the antrum, so it doesn't make any difference now. So this is around 3.6 centimeters in size. So a lesion which is around 3.6 centimeters in size with anechoic areas inside the lesion with irregular borders, irregular outline.
Praveer, just a simple question. This patient has an ulceration at the tip.
Yes.
Isn't it better that you take a biopsy directly rather than looking at the FNAC? I know other characteristics cannot be ascertained, but if you have a tissue, you will have a far better diagnosis than an FNAC in this situation.
So till now we are not talking of getting an FNAC. We will decide whether we want to do an FNAC or not with this large lesion. So as I was mentioning, three important points I have said. One, the large size of the lesion, irregular outline, presence of anechoic areas. And now as I mentioned, to be sure which layer it is arising from, you need to see the transition zone. However, the transition zone is primarily the normal wall layer where it starts, where the lesion starts, normal wall layer and where the lesion starts appearing. So that is known as zone of transition, which is very important, and that is the site which will tell you that where the lesion exactly is arising from. So sometimes what happens here, what is exactly is happening is, if we see this lesion, it's becoming very difficult to delineate the zone of transition. So what can be seen very clearly if we just see the lesion is, just freeze here. Okay, so here if you see,
we need some comments from you here for a moment.
So if we see here, so this is the first wall layer, second wall layer, third, and here if you see, this appears to be serosa. The fourth layer, which is possibly the hypoechoic muscularis propria layer. So just for the sake of information, there are two hypoechoic layers, which are muscularis mucosa and second is muscularis propria. These are the two hypoechoic layers in the GI tract, and we need to be sure of these two hypoechoic layers. Majority of gist arise from the fourth or from the second hypoechoic layer, that is either from the muscularis propria or from the muscularis mucosa, that is the deep mucosa. So this layer, since I am not very sure of the transition zone, I am not able to trace it, because as I am moving forward, I am just entering into the pylorus, and as I am coming back, what is happening is I am losing the vision. So that is the problem why I am not able to make out the transition zone. But this layer appears to be involving at least the fourth layer and the third layer for sure. So with this big lesion, probably in the stomach, this large submucosal lesion arising from the muscularis propria, possibly, is usually a GIST. GIST is a gastrointestinal stromal tumor, which is a form of mesenchymal tumor. And the points which I mentioned, the three important points: large size, irregular outline, anechoic space, and a symptomatic patient with a history of hematemesis, history of bleed. I think this patient straight away merits surgery rather than doing any sort of FNA or biopsy. I don't think that is needed in this particular case.
Lawrence, you have something to comment on this?
I absolutely agree with Praveen. I think the first issue we need to deal with in terms of submucosal lesion is whether the lesion is symptomatic or not. So I think that's where, if it's symptomatic, there's no issue that you need to treat it rather than choose to follow up on the patient. So I think the question is whether EUS still has a role in these days of a submucosal tumor. So I think clearly, I think the role is biggest in terms of differentiating between extramural lesion versus intramural lesion. So I think that has been demonstrated in this particular case because sometimes you are dealing with vascular lesion. You don't want to simply deal with vascular lesion, so you do need to know exactly whether this is actually a vascular lesion. And secondly, I think in terms of wall layer and all those features, unfortunately, the literature already told us that it's very hard to tell in terms of whether this is something which is malignant or not, because I think the gist, the differentiation from leiomyoma is still very tough, because there's just so many overlapping features that we are not very sure. But in this particular case, I think the patient clearly needs resection because it's symptomatic. So I think I do agree with Pravil that I don't think we need to do a FNA. And also I think perhaps if you really want a histology, I agree with the audience that we just take a biopsy and then the patient needs surgery because it's very big and so forth. I think the risk of malignancy is also big. But I think in this case, I think the resection is more because of symptom rather than because of malignancy.
Yeah, one or two very quick points for the benefit of the delegates. So one, if the lesion is less than a centimeter, possibly even, and a patient is asymptomatic, you don't even need an EUS. If the lesion is more than 3 centimeters, patient is symptomatic, the patient straight away goes for a surgery. So with the size of the lesion, primarily for just if it is 1 to 3 centimeters, then that is the time when we should be doing an EUS. And if there is a doubt about a diagnosis, then you can go ahead and do an FNA, not in this particular case, but otherwise, if there is a doubt about diagnosis, you do an FNA. In FNA alone is not sufficient. In that, you need to do an immunohistochemistry for CD117. If CD117 is positive and the patient has symptoms, size between 1 to 3 centimeter, this patient goes for surgery. If CD117 is negative, then you have to look for the high-risk features of EUS, which I have mentioned. If the patient has more than 2 high-risk features, this patient again goes for surgery. If this patient has less than 2 high-risk features of EUS, this patient again can be followed up if the patient is asymptomatic.
Pravir, how easy or difficult it is to do CD117 on FNA?
Yeah, so it's FNA is primarily you have to do a cell block. So you make a cell block, and in cell block you do immunohistochemistry, or you can try to achieve a core tissue if possible. So, but cell block I think should be a routine, especially when you are expecting a lymphoma or a GIST. It should be done invariably. Otherwise, you do an FNA and then you again have to get a tissue to establish a diagnosis. Say in case of lymphoma, the subtyping, that is IHC you need to do. So for IHC with FNA, you can make a cell block, which is easy. Good pathologists can definitely make it, or take a core tissue and subject it to immunohistochemistry.
For antral submucosal lesions, you need additional technical details? How much water, what position? Do you need to intubate the patient?
Yeah. So I think a very good question. If, especially with the linear EUS, you are trying to do a submucosal, especially the small submucosal lesion in the antrum, definitely you need to instill water or you need to use a balloon. If you are instilling a lot of water, then you definitely need to intubate the patient because of the risk of aspiration for sure. Somehow if you are using just a balloon with a radial, you can do with minimal of water, and in that case probably you may not need to intubate the patient. Yes, with the linear EUS instilling lot of water, you definitely need to intubate the patient to prevent aspiration.
Pravir,
Yeah.
Pravir, is that the cystic spaces are blood vessels or?
No, we have put Doppler on that. I will show you again. So that are typical anechoic spaces which probably suggest high-risk features in malignancy. We will put Doppler again. So you can see those are totally anechoic cystic areas in the lesion.
Okay, Raju and Pravir, I think Chantal is ready with the 2 FNA specimens, and she can also probably address some of the pathology questions. So over to Chantal over here, and can we move here? Pravir, you have anything else to comment on?
No, I think we can go on to the pathology.
Okay, right. So Chantal? And of course we have Dr. Bide, Dr. Mandolkar and Dr. Purandare over here from our department.
Okay, so for this particular specimen, we use the diff quick stain. The diff quick stain allows for you to be able to actually contrast between the nucleus and the cytoplasm. Now, in evaluating the diff quick stain, can we have the slide up? I don't see the slide. Oh, okay. So, so in evaluating the diff quick stain, it has three components. The first component happens to be a methanol stain, which actually fixes the slides. It fixes the cells. It prevents them from degrading. The second stain is an eosin stain. The eosin stain stains the cytoplasm. And the third stain happens to be a methylene blue, which is actually going to stain the nucleus. Now, the way we differentiate most cells is based upon the cytoplasmic features. So we look at the nucleus and the cytoplasm together in order to be able to tell what the lesion happens to be. Are there any questions regarding FNA? And I heard the previous speaker talking about cytology and the evaluation using...
Chantal, you can tell us about how best to prepare a cell block in this situation.
Okay, so in this particular situation, in evaluating lymph nodes, it's best to take and actually make a cell block. Cell blocks mean that you would actually take the tissue and you would centrifuge in order to create a pellet. Remember, when you're evaluating lymph nodes, typically lymphocytes are discohesive cells. So they do not have ecadherent or desmosomes to hold the cells together. So by them being loosely discohesive cells, it's best to aggregate the cells together. And the way to do that is to prepare it making a cell block. Now, the method in which you make a cell block, typically you spin the cells down through centrifugation, and then you would create a pellet. Then you would use some type of agglutinin, whether it's albumin, plasma thrombin, histogel. There are multiple different ways to make a cell block. There's about 31 different ways to make a cell block. But ultimately, you want to congeal the specimen and keep all the cellular fragments and blood components together. So the important thing in making a cell block in this case is that you want to make sure you don't lose any of the actual granulomas. Because with the granulomas, you want to be able to evaluate for AFB and PS stain in order to rule out TB and other fungal organisms. So let's say you are considering a diagnosis of sarcoidosis. It's important to rule out infectious etiology. So you can do a GMS stain, you can do an AFB stain, you can do a PAS stain. So in order to do these stains, you want to make sure that you actually retain all of the diagnostic material. Does that make sense?
Yeah, the only query is if while doing an FNAC the blood contaminates the cell, how does it affect the quality of cell block?
So it depends on what you collect your cell block material in. So in the US, oftentimes we use a product called Cytolite. Cytolite actually lyses the background red blood cells, so therefore you don't have any obscuring artifact. But for the most part, if you're not using suction, and you're using a smaller needle such as a 22 gauge or 25 gauge needle, you're not going to actually get that much blood. So it shouldn't actually prevent you from making a diagnosis. And because we are doing rapid on-site evaluation, the reality is that we've already made it on-site diagnosis of calling it granulomatous lymphadenopathy, but now we're trying to only evaluate what is the etiology for the granulopathy. And in this case, if you have adequate material in the cell block, what happens is that you actually take multiple sections. And if you do immunohistochemistry on these sections, morphology is not so much what you're looking for, but you're actually looking to see if there's an immunohistochemical antibody-antigen reaction. And if it's positive, then that confirms that a particular microbe is present.
Any questions? Are we still on? Raju, can you hear us?
Yes, we can hear you well.
Okay, so we're still trying to get the slides on the screen over there. Still going to take some time, but I think we have Rajesh, Dr. Rajesh Gupta over here from AIG, and Rajesh has got an interesting case over here that he started. Can we have the history?
He is 30-year-old male, presented with history of abdominal pain and fever for past 2 weeks. CT scan showed multiple peripancreatic lymph nodes. The plan is to show EUS guided FNA technique of peripancreatic lymph nodes.
What are you suspecting with such a short history of 2 weeks?
Hi, good morning. First of all, I would like to thank Amol for giving me this opportunity to get involved in this workshop. It's a wonderful workshop in beautiful city of Pune. I am using a linear echo endoscope by Olympus 180, and as my predecessors have already discussed. Rajkumar, can you hear me?
Yes, I can.
Yeah.
We all
so
can.
you heard the history. History is pretty short. He is a young male. He is having pain abdomen. So probably we are dealing with some infective pathology, and he has some fever. Yeah, intermittent fever and pain. So Rajkumar looks like some infective pathology we are dealing with. So quickly because already we have shown 3-4 cases where anatomy has already been discussed. And so I'm going to skip, I'm straight away into the stomach. And the first point what I say is always for our endosonographers is when the moment we enter stomach, we see this liver and you can see the IVC. Right? Can you see it? Can we appreciate? Yeah.
Yes, we can see the IVC up here.
Okay. So now if we give a turn, then you start seeing aorta. Right? So this is aorta. And down aorta, we have to see the 2 major vessels because it is going to be our base station for future exploration of our future examination. The first vessel, cranial vessel, is celiac axis. The lower one is the SMA, and that is the landmark. But because sometimes could be some variation in the origin because it can arise from anterior or it could be arise from the side. So sometimes the celiac axis origin is not clearly visible. As is in this case, it is not clearly seen. But as I give a little torque, you can see the first vessel. Rajkumar, can you appreciate the celiac axis?
Yeah.
And what I am seeing here is, so this is the area and you see there is some kind of ill-defined hypoechoic lesion which is abutting the left lobe of the liver and the ill-defined lesion, and this a bifurcational celiac axis is encasing the bifurcation of celiac axis. That is what the lesion appears to be. And if you go a little above and you can see the normal looking pancreas, right? This is the body of pancreas, right?
Yes.
So the body of pancreas is absolutely normal. The ducts are normal. There is no any calcification, ductal dilatation, anything. So we'll have a quick scan and then come back to the area where we are interested. So this is the body of pancreas. What I am seeing, it is going down toward the head area. And if we give a little anti-clockwise clockwise rotation, so now you start seeing again the same area, and this is little anti-clockwise rotation, and you can see the portal vein SMV, and it is seen to be going into, you can see it is going into liver hilum, right? Can you appreciate that?
Yes.
Yes. So this is what, so rest of the vessels appears to be normal, the portal vein appears to be okay. So there is a distinct lesion that is a ill-defined hypoechoic kind of lesion which is in continuity and it is merging with the left lobe of the liver, and you can see now the portal vein entering to the liver hilum, and below that the vessels are there.
We can also see some lymph nodes there.
Yes, exactly. These are necrotic lymph nodes. Yes. This is a hypoechoic with some anechoic kind of or more hypoechoic area within these lymph nodes. You are absolutely right, Rajkumar. Okay. So
can we differentiate very clearly whether this is coming from the pancreas or is there an interface or it's adjacent or an exophatic kind of lesion coming from the pancreas?
So that point is very valid, and because you can see, Rajkumar, there is a clear cut, there is a clear space between the pancreatic parenchyma in this area. So these nodes are quite distinct, and this mass here, it appears to be merging with the boundaries of the pancreas, but it is also merging similarly with the liver parenchyma. So it is little difficult to say whether it is arising from pancreas. But if we look around, if we have because this if you look around, the rest of the pancreas appears to be absolutely normal. So I'll bet it is not arising primarily from the pancreas, it is arising from peripancreatic area rather than from the pancreas.
Do you think the
based on
confluence-
the characteristics you have just shown us, what would you predict with the history? Whether it's an infective pathology, you still stick with it, or you would like to change something?
No, I still stick with the infective pathology for the primarily for the two reasons, because the nodes, the characteristics, they are benign looking node, bizarre shaped, heteroechoic, showing echoic and anechoic areas and little heteroechoic areas in between, and this ill-defined lesion which is there, and the history is short, though he has, but he is still having fever and pain abdomen, young patient, and rest of the pancreas is absolutely fine. So I will still stick with the diagnosis of infective pathology. Maybe some surprises will always be there, but I'll still stick with the diagnosis of infective pathology. So this is the area which I am interested, and you can see it is going little away from the liver surface, and it is arising from, maybe it is an infected abscess or something which is ruptured, because I can see a little bit of hypoechoic lesion just close to the surface of the liver as well.
Do you think there is some involvement of the confluence, because lesion looks quite close to it? Maybe.
Yeah, but the confluence is not involved. It is basically the celiac axis bifurcation which is involved here, because I can see the bifurcation of the celiac axis there, and it is emerging there beyond that. So it is basically a bifurcation of celiac axis rather than the hilum as such. So we move to the FNA now, because this area we need to FNA to confirm what we are dealing with, because that is the aim of the examination, and rest of the pancreas appears to body and tail. I think because of shortage of time, I'm not going to detail, because I've been instructed to just focus on this area, and because the anatomy has already been discussed in 3-4 cases. So this area to me appears to be ill-defined hypoechoic area, maybe infective etiology, and few couple of
Rajesh, now you have a pathology, you have a lymph node.
Yeah.
Why are you choosing pathology and why not lymph node? If it's a malignancy, you are highly likely that you will get a
You're right, Amol, Rajkumar. The thing is, basically the nodes are benign looking node, echogenicity wise, because they are little, as you can appreciate. See this node,
but
this is
they are at least 1 centimeter in size.
I think it is less than a centimeter. Can you measure it, please? Yes. Yeah. So, can you measure it, please? Yeah. Eight. Yeah. So it is 8 by 4. So it is a sub-centimeter lesion. Oh, it's a little bigger. Sorry, it's 11 into 6. So it's a marginal lesion, but more I am, because it's a benign looking, ideally, yes, if I'm suspecting a malignant pathology, I will target a node rather than the mass. But here I am suspecting this lesion on echogenicity basis. I presume it is a benign, so I am targeting the mass. As the needle is already, I am using a echo tip needle 22G by Cook here, and the needle is already, you can see the needle tip coming out, and you can see, can you see the movement of the needle? It's very smooth. There is no hardness, unlike, because it looks like a benign kind of, I mean infective kind of, because it's a very soft lesion, and I can easily penetrate. Otherwise, sometime in malignant lesion, it is very, very difficult because they are very tough to puncture. So it's very easy, and I will do 3-4 passes here, slow passes, then aspirate. Okay.
You want to use suction, sir?
Yeah, I'll use suction here, because
it's a very soft
lesion, so I'd like to use suction also, because it's a soft lesion. So I use suction, and I'll do 4-5 quick passes here, and generally the yield in these lesions, sometimes the problem is because these lesions are soft, you may aspirate some necrotic area, and in the necrotic area you may not get good yield. So if the tissue is not there, I will go more towards the periphery rather from towards the center of the lesion.
Dr. Rajesh, would you want to show some elastography on this one?
Pardon?
Would you want to show some elastography?
Yeah, sure. So, can you? Elastography, yeah. Oh, no. Okay, can you switch on? So with me here, I have Nachiket, who is our old colleague from AIG. So he's helping me in fixing this elastography. So it's a mixed kind of, Can you freeze it? Freeze it? Okay. Go back, go back, go back. Now, freeze. Now.
Yeah. We'll just freeze and go back to the image.
Okay. Okay. Yeah. So it's a mixed, greenish, more of the greenish tissue, less of bluish. So it's a softer lesion, Rajkumar. Can you appreciate that?
Yes,
more
yes,
of
we can appreciate.
Yeah. So it appears to be more of soft lesion. So I'll still bet it could be, it is more likely to be a infective pathology or a benign lesion rather than malignancy. Though there may be some surprises, but I am not putting too much money on malignant pathology.
Rajesh, this is Kiran here.
Yeah, Kiran, yes.
Sometimes it can be difficult to differentiate a necrotic lymph node from a mass lesion.
Yes.
Are there any tips you can provide us how to differentiate these two?
Yes. So the thing is, it's a very good question because it is very common to have necrotic lymph node in our country, especially because tuberculosis is still endemic in our area. So if it is a conglomerate of nodes, sometimes you can see all around node, but here you are seeing a distinct node here, Kiran.
Yes,
if it is a conglomerate of node and then it gives an impression towards a necrotic lymph node which is there, and if it is a mass, it will be all over and ill-defined margin would be there. It will not be a separate or lobulated kind of thing. So that's how we. Sometime, but if it is a lesion, the necrotic mass is too big, or if the necrotic nodes have coalesced too much, then it is really very, very challenging. In
That's
that
right.
case.
Yes.
Okay, so finally we've managed to get some histopathology images on screen, and we'll screen them to you. And Chantal is here to describe that, because that just looks pink and blue to me.
So here you can see you have a very cellular specimen. So obviously in the background there are numerous lymphocytes. And where you see the arrow now on high power imaging, yes, this is the first case. So you can see there's numerous lymphocytes, various sizes, showing that there's a reactive type process. Then you can see in the center, there appears to be epithelioid histiocytes. So when these epithelioid histiocytes coalesce, this becomes a granuloma. So you can see a poorly forming granuloma present. And so what happens over time, this will coalesce and become a well-formed granuloma. Now let's switch to the next case, and you'll actually see well-formed granulomas. Can we switch to the next case? Okay, awesome. Okay. So here, once again, you can see a very cellular aspirate. And now you can see multiple well-formed granulomas. So there are scattered single lymphocytes in the background. Remember, lymphocytes typically do not coalesce. But then you have larger cells with abundant cytoplasm, and these happen to be epithelioid histiocytes. And they're forming nice little groups. And so when they actually form these groups and they coalesce, we call these granulomas. And sometimes they can even have a fibroblastic type of appearance. But here you can see the nice round nuclei, the abundant cytoplasm, the overlapping, and these happen to be numerous granulomas. Now what we do not see any necroses. So if you see necrosis, you would typically say it's a caseating granuloma, but we do not see any necroses. So therefore, these are typically early granulomas. But remember, in TB, you can have non-caseating granulomas. So it's important at this point in time, in order to be able to do stains and actually PCR and cultures, to rule out TB and other infectious etiologies. Okay? So this is diagnostic for on-site evaluation. Any questions?
Would you clearly say this is tuberculosis, or just as a granulomatous cytology?
I would say this is granulomatous cytology because I do not see any caseating granulomas. If I actually saw caseating granulomas, meaning if I actually saw necrosis, there's no necrosis present. But if I actually saw necrosis, then that would favor TB. But since I don't see any necrosis, and these are actually well-formed granulomas, I know it can be various different etiologies. As you mentioned previously, in India, TB happens to be the most common. However, you can have other infectious etiologies that can give you granulomas. You can have foreign body granulomas. You can have granulomas secondary to reactive conditions. Granulomas can also be associated with various neoplastic conditions, including Hodgkin's lymphoma. Obviously, I don't see any features of a neoplasm here, but we want to rule out infectious etiology before you start thinking of neoplastic or autoimmune conditions such as sarcoidosis. But so all I can say here is that you have well-formed granulomas, and given the patient's clinical presentation, it's probably going to be TB.
Amul?
Yeah, Raju, we all take gene expert TB culture, but you know that even though it is TB, not necessarily it should come positive. But in my case, where I did EUS, there was one significant history which was positive. That was PET positive. So PET positive and granuloma, I would think it is TB, because TB, we are all aware of it, that it can give PET positive, while sarcoid would not. The other, it sometimes means, at least I have seen 2 cases where actually it was histoplasmosis.
Yeah, that's the reason I asked whether, you know, in this case, especially we need to keep the possibility of fungal granulomas also.
Yeah, so we have to wait for gene expert and TB culture. But in my case, I would start treating as tuberculosis because it was PET positive.
Yeah,
in the first case, I still think it is more of a sarcoid than the TB, because the lymph node was more like sarcoid, not like TB. But you can never be 100% sure on just EUS findings.
I agree with you on that.
Nilay? Amul?
Yeah?
Amul? Audible?
Yeah.
Nowadays we get patients who are otherwise asymptomatic on mast cell checkup. They have large nodes. We do an FNA and it comes as granuloma. And no further evaluation on that. How to go about and what to do with them? No?
See, you'll need to take some sample in saline. You'll need to do a gene expert and TB culture to look for tuberculosis, because in our scenario, I think you definitely need to rule out tuberculosis before looking for other pathologies. And especially if there is a granuloma, I think you need to do the entire battery of investigations to rule out TB before moving to other things. And then the rest of the things will be depending on what the pathology report is, the clinical features are, and what your pathologist feels about the specimen and everything else. Okay, so we'll now move to the next room. I think Saurav Gupta is...
We got a question from audience.
Yeah?
PD is with our arrow.
Okay, we are moving to Saurav Gupta. I think Saurav is already there. I can see him on screen. So
Amul, we got a question from audience here. This PD here. Yeah.
Is it for Chantal or Rajesh or me or Nilay?
Should we do AFB stain on this material routinely?
Yes, AFB stain they should be. Okay, we have Dr. Purandare. Maybe she can comment on this. Yeah. The question is, should we be doing AFB stain on this material that is?
So I'll start from showing from the body of the pancreas.
What we do is,
I'll
if we
start
get
from
the
here,
cell
and I'll
block,
show. That's right, exactly.
On the cytology smears also you can do Zn 20%, and even on the cell block, if the clot is prepared, you can take sections and do Zn on.
What are the chances of AFB positivity in these such smears as vis-a-vis PCR and gene expert?
If there is necrosis, if there are caseating granulomas, there are more chances of having.
Yeah, but in this
AFB
particular case, we are asking, since we have not found the thing, so should we?
No, still, yes, we still go in for it.
Is there any difference?
AFB. Whenever we have a granulomatous lesion, first we think of tuberculosis, and we rule it out by doing Zn stain.
Is there any difference in the fixation when you're doing EUS if you want specifically AFB stains or?
No, for AFB we collect the clot in saline, and then we use it for, we give it for microbiology for culture. While in the clot which has been collected in the formalin can be used to do AFB on the cell block.
So if you're suspecting tuberculosis, it's a good idea to collect clots in saline
as well as formalin.
Yeah,
right.
I think it, just last point, I think when you are dealing with these kind of nodes and all, it is always better to have a specimen both in saline as well as in formalin, because that should be the policy in all the units.
Right. I think Rajendra, y'all can take it up from the next room.
So we are ready here with the next case. Dr. Saurabh Gupta is going to demonstrate us, and Dr. Rahul is going to tell us the details of the case.
Hello, good afternoon all. This is a 53-year-old female patient with complaint of
epigastric pain, nausea, decreased appetite, and weight loss since 5 months. At serial of investigation, which was normal, and then the UHG suggested of some lesion in the head of the pancreas, and MRI shows 3 into 3 centimeter cystic lesion, multicystic lesion in the head of the pancreas. Now we have planned to do EUS to demonstrate and characterize the pancreatitis.
Great, thank you. So I'm using obviously the linear echo endoscope because that's the nature of this meeting, and we do that traditionally for all pancreatic biliary work now. So what I've done is I've advanced the scope to into the stomach, and I always start by examination of the pancreas from the stomach. I won't go too much into the anatomy here, but what we can see is just below the transducer, we're seeing the pancreatic body and the junction of the pancreatic body and tail. And deep to that, you can see the left kidney. Now, what's important when we're looking at cystic lesions, what we want to characterize from here is we want to look at the diameter of the main pancreatic duct.
Yeah.
So what we're seeing here is a main pancreatic duct that is almost invisible. It's so narrow caliber that in the body and tail it's almost impossible to see, which basically means that's fine. It means it's not dilated. And so that's what I want to look for. Is there a dilated main pancreatic duct? And probably if we freeze it here and look back, if we scroll back, we might see that the pancreatic duct is just there. So if we get our cursor, this is possibly our pancreatic duct right here, and it's very, very narrow caliber. So we follow the pancreas because just because we've seen one cyst on the MRI doesn't mean there's not more cysts in the pancreas.
So you need to scan the entire
So we need to scan the entire pancreas. So from a number of reasons. One is obviously smaller cystic lesions may not be picked up on an MRI.
Right.
But secondly, if we're thinking of pathology such as IPMN, then we know that it's not just the cystic lesions that can cause problems and malignancies in these patients, and we have to look at solid lesions and other, because remote adenocarcinoma can occur in IPMN cases as well. So again, we'll use the body to torque the scope in a clockwise fashion and slightly pulling back and coming back towards the spleen, and the spleen is coming into view there, and what we'll see there is a small rounded hypoechoic structure between the transducer and the spleen. And so, some people you worried about a lesion there. Sometimes you worry, is this a lymph node there? But in that location, you'll often see a small accessory spleen or splenunculus.
Right.
And the trick to that is it's very well rounded, it's very well demarcated, but it's also the same echo density as the spleen that's just deep to it. So I think we shouldn't get confused and worry that that's a lymph node. We can actually see accessory spleens that are even intrapancreatic. So that's been described. People have biopsied them and it comes back with simple lymph node tissue like splenic tissue. So we wouldn't worry about that. So now we've got the whole spleen here. So then we start scanning the pancreas the other direction. So rotating counterclockwise and just advancing the scope a little bit. So we've got the pancreas between the transducer and the kidney. And now here, as we get to the genu of the pancreas, we can start seeing the pancreatic duct a little bit more.
Dr. Saurabh, that small hypoechoic lesion, could it be a neuroendocrine tumor within the tail of pancreas?
Sure. I mean, it's all possible, but I think we look at the probabilities of what this lesion is, and given it's the same density and right in the splenic hilum, I think my money will rest on this is going to be an accessory spleen rather than a neuroendocrine lesion. But look, if the patient's history was something different and we were suspicious of a neuroendocrine lesion, we could look at various different techniques. We could look at contrast enhancements to see if it lights up with vascularity, which would be more suggestive of a neuroendocrine lesion. But I would do that with a non-invasive approach rather than doing an FNA to rule out a neuroendocrine lesion.
Saurabh, is that the confluence which you are seeing now?
So what we're seeing here, there's our portal confluence. Yeah. We can see just there. If we can freeze that image just there, that shows here our the portal confluence. So we've got the splenic vein coming in from here. we've got the superior mesenteric vein coming in from this side, and going away from the transducer here, we've got the portal vein.
Yeah, very nicely seen.
So that's our nice shape of the splenoportal confluence, and the pancreas that sits above that, this region is the neck of the pancreas, or the genu of the pancreas. And so what's important here is we need to, as I mentioned in the talk, we need to tip, once we get that genu of the pancreas, we need to really tip the scope up so we can, and you can see if I let the scope relax in that position, you can still see the genu, but the superior mesenteric vein is quite deep. So now what I'll do is I'll tip up the scope with my big wheel, and I'm bringing that SMV closer to the transducer. And so what that's doing is allowing me to see the neck of the pancreas much more close to the tip of the transducer. And there we can see our cystic lesion coming into view. And adjacent to that is again, if we can get the cursor. Yeah, if you can freeze that. Yep. So what we have here is obviously the lesion, but it's important not to get immediately taken up by the lesion. We need to look at the relationship between this lesion and the pancreatic duct, which is over here. So once again, the pancreatic duct is not dilated. It seems separate from the cystic lesion over here. And what's important is we need to follow that. We need to follow that pancreatic duct adjacent to the lesion to see if indeed there is communication or not. So there's the cursor with the pancreatic duct, and so he's slowly trying to move back and forth the pancreatic duct, which is just there next to the cursor, and there it is in the head of the pancreas now.
Right.
There's the pancreatic duct, and deep to that you can see the bile duct. And so often in thin patients you can see the CBD from the stomach as well, and you can see the actual, there's the pancreatic duct right there with its hyperechoic walls there, and you can see the common bile duct deep to that. And you can see how the pancreas differentiation between the hypoechoic pancreas of the ventral and larga, and you can see the relatively more hyperechoic pancreas of the dorsal differentiation. So here we try to follow that pancreatic duct again to see if there's communication between the lesion, and so we're following it. It seems to go very close right there, but I can't say with certainty that there's communication between the cystic lesion and the pancreatic duct, which would suggest an IPMN or some lesion like that. So I'm not confident that I can definitely say that, but obviously we need to examine the lesion from the duodenal bulb as well. So if we concentrate on the lesion itself, what we are looking at is several things. Obviously we need to look at the size of the lesion, because that's important, especially for things like IPMN, because size for branch duct IPMN is considered a criterion for surgical referral. We're looking at the wall of the cystic lesion. Can we see a thick wall? Is there a thin wall? Is there no wall at all? Then we're looking at septations, because obviously the differential for this lesion is going to be, this patient's had anorexia, she's had weight loss, she's had some abdominal discomfort. So are we dealing with an episode of pancreatitis, and is this a benign inflammatory pseudocyst? It doesn't look typical for that, because generally a pseudocyst won't have the septations like this lesion does. Are we thinking about a serous lesion, which is a simple serous cystadenoma, which is not ruled out because of the absence of the honeycomb pattern. Most of the serous cystadenomas you see are a combination of either the microcystic lesion plus some oligocystic, larger cystic components, or they can be purely a macrocystic like this lesion as well. And then we're thinking, is there any internal debris or internal nodules, mural nodules, internal solid component, or an associated mass? And we're really not seeing any of those as we scan through this lesion.
Except the septations.
Except a few thin septations. And I always like to put on the Doppler as well, and I look if the septations contain vessels, and there you're seeing quite a nice little demonstration of a vessel within that septation. And so that, I think, is really useful to do, because we know that serous cystadenomas have very vascular walls. They're made of fine capillary networks, vascular walls. So again, this would make me think more likely that there's going to be a benign serous lesion rather than a MCN. But because it doesn't have the typical appearance of a serous lesion, and because at this size, if it's an MCN with the patient's symptoms, you would be considering surgical management, it may be worthwhile doing a cyst aspirate from here.
Yes.
Which would do two things. One is we'd definitely get enough fluid to assess whether it's a serous or mucinous lesion.
Right.
And secondly, if it is a serous lesion, then we don't subject the patient to ongoing surveillance for a cystic lesion that is completely benign and doesn't need any follow-up.
Yes, yes.
So I think it is an invasive procedure in FNA, but I think it's very simple here, it's very safe, and it will stop the patient having ongoing follow-up.
Right, yes.
But before we do that, we'll go into the head of the pancreas, and we'll into the duodenal bulb and have a look at the head of the pancreas. So again, we switch to our endoscopic view. We pass the scope.
Saurabh, while you are looking at FNA in this patient, would you like to aspirate completely? Because otherwise you carry a risk of infection in the cyst.
There's absolutely a risk of infection. That's what we always worry about with FNA of cystic lesions. I think it's going to be possible to aspirate this almost completely, if not completely, because I suspect it will be a serous cystadenoma. So I think it's going to be thin fluid, and we should be able to aspirate it completely dry. But again, often you'll see by the time you finish the procedure and you re-look, there's going to be fluid within that cystic lesion again. So I think it's not, whilst it's nice to be able to drain it completely.
You are looking at 5 to 7 ml of fluid to be aspirated. Would you prefer a 22 gauge or a 19 gauge needle?
Well, I generally, for these lesions, use 22 gauge. Here we can aspirate it either from the duodenal bulb, which is where I am now, or we can aspirate it from the stomach. I think, again, duodenum is probably preferable for anything you can access from the duodenum from my perspective. It's thinner wall, it's easier. A 22 easily passes. And I would routinely use a 22 gauge for cystic lesions.
My concern is if it turns out to be a thick mucinous lesion.
Sure.
Will it not be better that you have a 19 gauge needle doing from stomach rather than 22 gauge from duodenum?
I think if it's a thick viscous fluid, I think even if we use a 19 gauge, we're not going to be able to aspirate this thing completely dry, because it's going to be just too thick, too viscous. So I don't think then the worry is there of not aspirating it completely dry. So, but I do agree that you've got the option, and if you're comfortable and happy and you've got a good position with a straight scope, a 19 gauge is perfect. The other alternative here, and I use this for cystic lesions in the uncinate process, is I'll use maybe the 19 flex needle, which is the nitinol needle from Boston Scientific, which is extremely good at getting around the corner in the distal duodenum to access this. So that's an option here. Obviously, it's a more costly needle, especially where I come from. It's almost 1.5 times the price of the standard EUS needles. So we don't use that routinely if we don't need to use that needle.
So you are going to use 22 gauge needle here.
So I'm thinking of using the 22 gauge EcoTip Ultra needle from Cook. And
so
we notice this. Yeah.
I mean, had there been a mural nodule along with this cyst, what would have been your plan?
Sorry, if there was an internal nodule, a mural nodule.
Yeah.
So I think, so the plan then changes, because then it's more likely to be a mucinous lesion if we're seeing an internal mural nodule. So then my routine practice for that would be to use contrast. I would use contrast enhanced ultrasound to assess whether we're dealing with a mucus ball or mucus plug, or are we dealing with a true mural nodule. And I think contrast really helps differentiate the two lesions. You can, the poor man's, if you don't have the contrast software, you can just use the fine flow Doppler and look to see if there's any vascularity within the mural nodule, which shouldn't be there if it was a mucus ball. And then, if you're going to consider, if there's a mural nodule and I'm convinced on contrast that there's a mural nodule with vascularity, I don't need to do an FNA, because this lesion then would be something that requires consideration for surgery if the patient's a surgical candidate. So I would not do an FNA, I would do contrast and then leave it, refer them to the surgeons. If it looks like there was no flow in the nodule, then I would do an FNA. And if I'm FNAing, I'd try to target the nodule first, because often you just suck that nodule up and it's gone, so it was a mucus ball, and rather than a true nodule.
Saurabh, if these small peripheral cystic lesions that you see on the periphery of this larger lesion, do they help you differentiate between a serous and a mucinous in any way?
Well, I think they're actually all communicating. I think it's a multicystic septated lesion. There's the I think there's septations here rather than multiple, thank you, than multiple cysts. I think it's all one cystic lesion with some septations there that we can see. And so what I routinely do, and I don't know if, I always, especially if I'm in the duodenum, I will shorten the, I don't know if we can show the camera on the FNA needle. So I'll actually, it comes preset at 2 or 2.5 centimeters when you take it out of the packet. I will always pull back the sheath so we're at 0, and then I would actually introduce the needle into the housing with the sheath set on 0. So that means I'm not going to stick the sheath or stick the needle or bend it as I'm going through, and it allows me then to, in a more controlled fashion, then release the lock of the sheath and try to advance the sheath under direct visualization under EUS, and you can see the sheath coming out there.
Yeah.
Very nicely see the sheath there, and we just make sure it's out maybe a centimeter, and so here now the sheath is between 1.5 and 2 centimeters out of the scope, and I'll lock it in place there. I know I've got two things. I've got a very stable scope position. I've got a very short distance between the lesion and the needle and the duodenal wall, and I've got no vessels between. So if you put the Doppler on with the sheath out, you'll often get an artifact with a flow artifact adjacent to it. So it's important to do it before you put the sheath there, just to confirm there's no intervening vessels. So then we'll obviously take our lock off the FNA needle. The needle will come out, and you can see the tip of the needle there coming out through the scope and through the sheath. And with the ultra needles, I'll pull the stylet back a tiny bit just to expose the sharp tip of the needle, and then a single puncture in to the cystic lesion. And then we get all the way out, yes, and the suction, please. And so for cystic lesions, I'll use full suction. So I'll use full suction and to try to really, as we talked about, to try to aspirate the lesion entirely. Yes, please. And if we think we're correct, we should be getting thin white fluid coming out into the syringe, and that's what it looks like we're getting. If we can zoom in on the syringe itself here, so we can see straw-colored thin fluid coming out.
So it appears clear.
Very clear,
Yeah.
very thin, and it's easily coming up into the... so that would be consistent with our suspicion that this was going to be a benign serous cystadenoma.
Yes.
Dr. Saurav, do you always give prophylactic antibiotics for these lesions?
So we do give prophylactic antibiotics. I think the patient's just getting a little uncomfortable. So we might, what I don't want to do is, I think we've got enough fluid here for, I think, so I'm just going to take the FNA needle out. We've got enough fluid there for analysis. And if we look at this then, if we can zoom in on the fluid there, we can see if we just move it up and down, it's very thin, it's clear, and it's watery. So that to me
goes in favor of serous.
Is going to be a serous lesion.
Okay. So we are shifting to the room number 3. Thank you, Saurav, for a nice demonstration.
Hello? Hello?
Pull the chin.
Hello?
Xylocaine jelly.
Hello? Hello? Hello?
Hello. Check. Hello.
Hello? Hello, are we audible from here?
Yes, you are audible.
You're audible,
okay. But we can just,
so,
we can't see.
We are on to the EBUS section now, where Dr. Dhamija is going to be demonstrating EBUS, and I hand over to Dr. Pawar, who will be taking us through the various steps.
Hello, very good morning to all. This lady, elderly female, 3 years back, she was treated for carcinoma of pancreas.
Thank you, chairpersons.
And
we'll now have a
last year, she had undergone MRM for CA breast, And now last 3 months he has presented to us with loss of appetite. She has lost her weight. She is having cough. And her CT is showing there are multiple mediastinal glands.
Please carry on.
Now,
neck extend.
Dr. Amit, over to you.
Neck extend. So we have this lady who has undergone ripples.
Chairpersons.
Am I audible?
Dr. Vikram Bhatia, Dr. Kedar.
Are we audible?
Dr. Vijay Shri Bhide.
Yes,
you are audible. You are audible.
शक्ल मत दिखा, कुछ नहीं होता. That's okay.
I request Dr. Lalit Shri Bhide to please continue with the session.
All right. Am I audible?
Yes, you're quite audible here.
Yeah. So we have a lady, elderly lady, who has undergone ripples about 3 years back. Later on, she developed CA breast. She underwent MRM, then she underwent chemotherapy. She's been unwell for the last 2-3 months when they noticed a small right paratracheal lesion. It was sampled outside but drew only lymphocytes. A month down the line, the lesion appeared to have grown significantly, and it actually looks like a third malignancy to me now. It is in the right paratracheal area, it is encasing the right hilar, and of course we also have a subcarinal lymph node. So we'll try to look at the lesion through the trachea in its entirety and take 2 samples, one from the lymph node, one from the mass. Staging, I feel, doesn't make much of a difference in this particular case, seeing the extent of region on the CT scan. So we are at the vocal cords here. We are entering a different territory now. We are entering the windpipe, not the food pipe, so it will be a little different for all of you there. You can see tracheal cartilages and the posterior wall of the trachea, behind which is the esophagus. And of course, the anatomy, as you see from the trachea, will differ from what you normally are used to seeing when you are into the esophagus. So the landmark, which is first and foremost important to us when we are doing an EBUS procedure, is the carina. So this is the carina where the right and the left main bronchus takes off. This lady has a trachea which is little pushed down because of the pressure of the mass, so it is not a very accommodating trachea, I say. So this is the carina. This is from where we start all the anatomical orientation. We inflate the balloon. Can we have the ultrasound now? So on the right side of the trachea, you start seeing the right paratrachea. Just switch on the freeze. Yeah. You see a heterogeneous mass there with specks of calcification or heterogeneity. This mass appears to be extending right along the right wall of trachea. Along the right wall of trachea, this most likely is the brachiocephalic there. And of course, as you go down, it also appears to involve the anterior wall of trachea. This is the mass in its entirety. I suspect it is going up to the right hilar also. I'll just show you the right hilar as well. This is the mass. It is extending up to the brachiocephalic there. And of course, in the 2-hour station, we do not find any lymph node. This is only paratracheal soft tissue. We go down again. We can see the subcarinal region both from the right main bronchus and the left main bronchus. Okay, so we are in the right main bronchus now, facing the subcarina, and local. If we turn our scope right, you will be seeing the mass again because we are at the hilar. We are at the hilar. You are able to see the mass again. The mass is encasing the hilar, and of course there you see the pulmonary artery as well. The mass is along the right main bronchus, the right hilar, and even the subcarinal region appears to be involved. Yeah, it appears to be a contiguous mass involving the subcarina, the right hilar, and the right paratracheal area. So this is probably not a lymph node, but just an extension of the mass into the subcarinal region. If we go on to the left hilar region, we traverse the left main bronchus. You see the upper division and the lower division. This is the station 11L, but we do not see anything except for the left hilar vessel there. We come up, you see the left pulmonary artery. You see the aorta. There doesn't appear to be any lymph node between the two, so station 4L is clear. So we are clearly dealing with the mass lesion which is encasing the, involving the right paratracheal, the pretracheal area, the subcarina, as well as the right hilar. So we'll take a couple of jabs from here, and of course we'll subject them to microbiology, histopathology, cell block, and of course we'll since it can be a primary CA lung or a lymphoma, we will need lots of PHCs and cytogenetics to be done. We'll preserve subsample from that in the cell block as well. Can we have the needle, please? Conventionally, we use a 22 gauge needle. We tried 21 and 22 both. Our pathologist was not very happy with 21 because she felt that the material is more contaminated with blood when we are doing 21. So we restrict ourselves to 22 gauge needle, and we normally do not use suction in the first pass because we feel that even without suction we are able to get a very good yield. Just hold the scope at the mouth to patient. Without suction also we are able to get a very good yield, so we normally do not take suction in the first pass. We normally see the consistency of the node and the yield of the node and then decide whether suction is to be used at all. So needle gets fixed here. You see the mass in its entirety. You can have the Doppler to confirm that there are no vessels in the direction the needle is going to come out from. All right, this is clean.
Dr. Thamija, how does EBUS compare to your regular EUS and transesophageal FNA compared to an EBUS FNA? Technically, is it easier, more difficult?
Technically, it is a little different because the scope that we use in the trachea is 6.9 mm. It is a thinner scope because trachea cannot accommodate a larger scope than that. And of course, you have access to all the possible lymph node stations right up to station 12. So as far as I'm concerned, as far as my knowledge of EUS goes, you can sample station 2R, you can sample station 2L, 4L, subcarina, and of course 8 and 9. But it is very difficult to go into the hilar areas because that is just inaccessible through the esophagoscope. And of course the 4R station, that is the lower right paratracheal, it is difficult to manipulate the esophagus behind the trachea and reach the 4R. So for station 4R and the hilar, EBUS has an advantage. And of course if we have any endobronchial pathology or if we have any other mass lesion or any other sampling like a bronchoscopy and lavage or a biopsy needs to be performed, then we can complete the whole staging of the mediastinum in just one setting. The vision is not very good. The angle of the ultrasound is just 50 degrees. Of course, for a peripheral lesion, we also have a radial probe available. So technically, it is a smaller scope with a lesser angle, 50-degree angle. But as far as the clarity is concerned, it is same as we have in the US because we share the common processor. Just the diameter and the apposition is different, and of course we have air in the trachea, which can obviously cause lots of confusion because it is not a very good conductor of ultrasound. So you have to deal with air, which is technically a little more difficult. The patient here is very cooperative. You might have to deal with coughs because the patient's respiratory compromised. Sometimes getting to the lesion is a little difficult because the patient is coughing incessantly.
Is it more difficult to get in through the cartilage when you're doing an FNA as compared to the esophagus with esophagus?
I have tried both esophagus and trachea. If you, after a while, you get to know where the cartilage is, and the trick is to avoid puncturing the cartilage. Even if you have to, you can puncture the cartilage. The only thing is that the cartilage decontamination has to be done by the stylet because all you get in the hub of the needle is cartilage if you puncture through that. So the stylet has to be pushed into the needle so that you can decontaminate all the bronchial tissue and the cartilaginous tissue and take a sample. But with time you understand where the cartilage is. You can actually see the cartilage. In this particular case, you are not able to see because this is a mass itself. You are not able to see the various layers of the trachea. The mass seems to be involving the tracheal wall as well. So you cannot differentiate between a cartilage and the intercartilaginous area in this particular case. But in a normal case where you have a NIF node, you can differentiate where the cartilage is, and the aim is to enter the intercartilaginous area and try to avoid puncturing the cartilage. So you can see the needle coming out now. The needle comes out, the 1 centimeter is dimpled, and of course after that you have to decontaminate the needle by the hub. And normally we do not use suction. I would ask my assistant to gradually pull out the needle in gentle motion. Yeah. Keep coming out, keep coming out, keep coming out, keep coming out. Great. Avoid using suction in the first pass until you are suspecting a necrotic material in the cases of tuberculosis or a necrotic mass where you suspect lots of density. Otherwise, for soft lesions, we normally would not start off with the suction in the first place. So you do a couple of jabs, gradually take out the needle, gradually take out the stylet, which will act as a capillary action and give you some suction. That is all that is required. 10 to 20 jabs is all that you need. And of course, then you come out, you repeat the steps of locking and unlocking of the needle and hand over the needle to the pathologist.
So for those who are comparing the FNA of this EBUS needle And EUS needle, we must realize that it is only the top left quadrant which is important for EUS FNA. Because you cannot do EUS of this screen, whatever you are seeing, you can do FNA only of the top left quadrant as we see in this case. Because the needle is going only in this quadrant. Because there is no elevator, but it was a fantastic job done.
There is no elevator, of course, but then you have a balloon which can be inflated. The trachea is very small in this particular case, so we're not using the balloon. But in case of a larger error, you can inflate the balloon, which will do the job of an elevator, just as it does in endo ultrasound.
So what Dr. Amit said, that balloon can probably inflate it, and with balloon you can change the angle. But whatever you are visualizing, in the visualized field, the restriction is that you can do FNAC only because the needle is only going.
The needle goes only in one direction. The needle goes from the right upper corner of the screen to the left lower corner of the screen. And you have the aim is to keep the bulk and the core of the lymph node in that direction only, because you don't have much space to manipulate in the trachea as you have in the esophagus.
So contrary to what you are seeing, because you are seeing the whole screen.
Yeah.
But what you are doing FNA, that part you must keep on the left lower.
That part has to be in the left lower corner of the screen because the needle comes out from the blue dot. Can you have the marker? The needle comes out from the blue dot, and the needle makes an angle with the node, so it goes on along the left lower part of the screen. So this is where the bulk and the core of the lesion where you want to sample has to be.
So before puncturing, the second thing that probably people may have noticed, that at the time of puncturing, contrary to what you see in EUS, the esophageal wall is more soft to puncture.
Definitely, definitely.
So he went a little bit away and the puncture was partly blind.
Yeah, go ahead.
But probably you did it very fast. You did it very well because suddenly you were in, but we did not see you going in.
Basically, it depends on the consistency of the lesion and the integrity and the compliance of the tracheal wall. In this particular case, the tracheal wall appears to be involved with the mass. So mass is solid. When you are puncturing a compliant area, only for a fraction of a second, you do not see anything, you are blind. But if you have somebody holding the scope at the mouth of the patient and your hands are steady, you will very well go into the same region where you have to.
And an interesting thing was about you said about the cartilage, because I still see
there
that
are
normal distance in cartilage is about 5 millimeters.
0.5 centimeters, absolutely.
Okay, so can you show us some cartilages if you withdraw in and out?
In this particular patient, the blackish area that you are seeing, these are two cartilages. No, Sandeep, can you have the ultrasound now?
Yeah, but on EUS also we are seeing two cartilages.
Okay, so this is the cartilage that you see on the ultrasound.
Yeah, these are, now you are between two cartilages.
Now I'm between two cartilages, and you should try to avoid hitting on the cartilage head. You should try to go between the two cartilages as far as possible.
Maybe if you can zoom more, you can see the cartilage, show the cartilage
of course.
to the
Sandeep,
audience.
can you zoom out a little bit? Zoom in a little bit?
Zoom in and pick your pointer on the cartilage
Yeah,
for the
Sandeep,
benefit. Because you have to extract the trick from you, Amit.
I'll just show you.
Okay.
The white solid line that you are seeing on top of the screen is the mucosa and the submucosa.
Yes.
The darker hypoechoic lesion in center, which is oval shaped, is the cartilage. And the aim is to go in between the two cartilages in the intercartilaginous area, which is a little hyperechoic. So your aim has to be to enter between the intercartilages, and against the sharp line that you see again is the adventitia.
So
beyond that is the node.
Black or white?
Cartilage is black.
Black.
The white area is more mucosa, submucosa, and the adventitia. The cartilage is looking grey-black.
But why is cartilage black?
It is ecogenicity of the structure, sir. All right. Can we have the next class now? संदीप होल्ड कर लेना. डॉपलर दिखा. यहाँ पर चलिए. So for a fraction of a second, you definitely lose touch with the needle going in, but as soon as the needle is in, the mucosa tends to bounce back and touch the scope again. So you are able to see the needle in its entirety going inside the lesion, and of course, we'll take a couple of more jabs here.
And that is why as the diameter goes down, because it all depends on momentum, people sometimes say that a smaller diameter may have less, it goes back, recoil, more recoil.
Yeah.
But it doesn't matter, because if you know the correct technique and you have the new needle, the smaller diameter is no problem. So can you show us one or two structures while you are doing EBUS? In the meantime, they are
I'm trying to negotiate. This trachea is a little narrow. It is difficult for me to push in a large scope through that. Let me see if we can.
Because the audience has already seen the sampling.
The same structures through the EUS. So these are the landmarks that we follow in the trachea.
Yeah.
The first landmark is of course the carina. You can see the right main bronchus and the left main bronchus stemming out from here.
And we have the endoscopy screen.
Yeah, endoscopy going.
We don't want to see the slides, Amol, please. Yes.
Okay. So you have the right main bronchus and the left main bronchus. This is the right main bronchus, and on the left is the left main bronchus.
Okay.
The carina appears to be widened definitely because we have a mass infiltrating beyond that as well. If you try to enter the right main bronchus, you are barely able to see the right upper lobe because the angulation that we can make with this scope is not very good. You cannot enter the right upper lobe opening. So the right upper lobe opening is very small, and of course the right hilar appears to be involved so that it is bulging in. This is the right main stem bronchus, then comes the bronchus intermedius. This is the bronchus intermedius. You see the middle lobe at 12 o'clock position. Below this is all lower lobe. The lower lobe also appears to be compressed because of the pressure of the mass, and the scope, the right bronchus intermedius being narrow, the right lower lobe being narrow, will not accommodate the scope. The vision is completely obscured. Similarly, you can enter the left main bronchus and try to show you the upper and the lower division of the left main bronchus as well.
So what we are more interested in drawing the bronchus is probably the vascular landmass.
Definitely.
What do you see rather than?
Normally, if you are already dealing with the lymph nodes, the vessels are not very displaced. The most important landmarks which help you differentiate between a station 4R, 2R, 2L and 4L is the aorta on the left with all the great vessels, the pulmonary artery which is beyond the aorta on the left. On the right, the azygos, which is the boundary between station 4R and 10R, is the landmark to be noticed, which is just at the level of the carina when you turn the scope right. To differentiate between station 2R and 4R, the boundary is brachiocephalic, but unfortunately in this particular patient, the anatomy is distorted because the mass seems to be displacing all the vessels and we're not able to see the vessels very clearly. On the left side, of course, you should be able to.
So the bottom line is when you are in the lower trachea, you turn to right,
you turn to right, you see the azygos. Any node,
superior vena cava.
You see the azygos, and of course you see the superior vena cava.
And on left?
On the left, you see the pulmonary artery. Upwards, you see the aorta. Along the left main bronchus, you see the pulmonary artery again, and along the left division, you see the hilar vessels.
So basically, trachea for the aorta and IVC, and the
SVC.
bronchus for the pulmonary artery and pulmonary.
Exactly. Very true. Very true.
So to summarize for the audience, you go to trachea, on the right side you vena cava, on the left side aorta. You go to bronchus, inside you see the subcarinal area, outside you see the pulmonary artery.
Pulmonary arteries, exactly. And then you see the hilar vessels. Do we need any more passes now? Do we need one more pass?
Amit, while we are doing nothing, can you decrease the depth and see what lies beyond this node? Can you change the depth and analyze, because
we are already about the sharp line that you are able to see here. The sharp line that you are able to see, beyond that is the normal alveolus.
What is this vessel? Is it a vessel or what is this structure?
This is the right hilar vessel.
Which vessel? Artery or vein?
That you really do not know.
Okay.
This is the right hilar vessel, and the sharp demarcation that you see on the right side, you see your soft tissue. Then you have a white line which is the interface between the alveolar tissue and the soft tissue. And to the left lower part of the screen, you see normal lung.
So this should be the right pulmonary artery?
Yeah, this is right pulmonary artery most likely.
Right, but it will divide into two branches if you can see.
I'm trying to negotiate this scope, but unfortunately we're not able to because the hilar appears to be compressed because of the pressure of the vessel. I think it is all displaced because of the
So one thing,
node.
because what if this is a mass, this is involving the right pulmonary artery at this place, and this is an inoperable mass.
It is an inoperable mass, so staging really is out of question in this particular case.
So what are the general signs of inoperability in mediastinal artery, veins, vena cava, and aorta? Anything to
And of course, if you have any lymph node which is in the left paratracheal area and causing vocal cord palsy, it again is tending towards inoperability. Distance from the carina, if you are dealing with the main mass and not the lymph nodes, will be a criteria for inoperability. Size now does not matter with the neoadjuvant forms. You can actually reduce the size. It is actually the involvement of the vessels, involvement of the carina, and involvement of the left vocal cord which will decide whether the case is operable or inoperable.
So that is the clinical one. What about EBUS one? EBUS and EUS, how do you do staging? Do you think EBUS has a role in staging of lung cancer?
Definitely. This is,
I'm afraid we need to shift to the other room.
Okay.
Dr. Lawrence is ready with the other case. Probably we can come back to Dr. Dhameja once we are done there.
Fair enough.
Thank you for an excellent demonstration.
Thank you so much.
Thank you.
Do we need more slides?
Yeah, we have a 50-year-old lady with history of epigastric pain, anorexia and weight loss for past 2 months, and features of cholestatic jaundice for past 2 weeks. On CT scan, showed a pancreatic head mass, which is also involving distal CBD. So, plan to demonstrate, assess the pancreatic head mass and its relationship to vascularity, and demonstrate FNA technique.
We can't get the audio of Dr. Lawrence. We are still not able to get the audio.
Basically, I think the lady has a mass in the head of pancreas.
We need a better audio. It's coming, but it's low in volume. Or you could use the mic, which the free mic which is available. Yeah.
Okay. Is it better now?
Yeah. Thanks.
Excellent. So I think you heard the story of this lady with a mass in the head of pancreas. So our job today, I think the learning point is really to try to do an FNAC of this mass. I think the CT already demonstrated that the mass is very big and has invaded the portal vein. So I think so this is a case where we need a histology for us to to exclude a possible diagnosis other than malignancy. Because if this is something else, I think it's important because this is a lady with potentially what we call non-resectable tumor. So I think it's important for us to exclude other treatable conditions such as things like infection, autoimmune condition, as well as the lymphoma, which is more amenable to treatment. So I think we are now already in the stomach. I won't go through the anatomy. Suffice to say that I think my usual preference is to use a landmark from the aorta, as you can see here.
Dr. Lawrence, nowadays we don't consider portal vein invasion as an inoperability because...
No, you're right. But I think in this case, I think we also need to know that whether there are any other vascular invasion. So I think in this lady as well, apart from portal vein, I was told that the SMA is also involved in this particular case. So I think the staging will be done at the same time, but more importantly, I think we need a tissue diagnosis to basically, I think, try to see whether there's any other treatments to be offered for this lady. So I think the first thing is a landmark. I think people have already shown many times. We go straight from the aorta, and then we demonstrate the first bifurcation, which is here. Okay, so I think we demonstrate the first bifurcation, which is coming from the aorta, and then we will just go from the aorta into the body of the pancreas. Okay, so I think that's the aorta here. So we just go here and then go to the body of the pancreas, which is up here. I think in this particular case, the pancreas is not very well visualized. In fact, it's a very smallish pancreas. And you can see the different vessels along the pancreas. It's a very rather atrophic looking pancreas. This is a body of pancreas which is demonstrated there. We just show the venous flow on these two vessels here. And then I think similar to the thing, we want to go through the entire body of the pancreas to the tail very quickly. So I think I turn clockwise to go in and look at the whole of the pancreas. Very atrophic looking pancreas, so not so well visualized. In fact, we already reached very quickly. That's the So I think when we are lost in this particular case, we'll go back to the orientation again, and then again look at the go back to the aorta here, and then reorientate ourselves into this way. Okay, so I think you see the aorta with the two bifurcation. One is a celiac axis, the other one is a SMA over here. And then from here, we just go into the body of pancreas, which is over here, just up there. So the body of the pancreas, and then after that, we just gradually turn in and turn all the way over to the tail of the pancreas, which is here. And the kidney, we are going past the kidney again. And then there's okay. So I think if you can look at this thing, right in the middle, the one is obviously the pancreatic duct, which in this case I think is dilated. Just going to measure the pancreatic duct here. So it measures, is that correct? 8 millimeter, no, 3.8 millimeter. So I think the pancreatic duct is dilated. Generally, I think I like to just look at the body of pancreas first before we go to the lesion, because we want to get as much information as possible before we study the target lesions of interest.
So Lawrence, this pancreatic duct is an obstructed duct, or it is a duct of chronic pancreatitis?
Yes, I think generally it's, I think most cases with the dilated ducts, I think it's still upon the tortuous CT to give us a clue as to whether this is actually due to the, whether this is a result of chronic pancreatitis or whether this is a result of dilation. So I think obstructive dilation generally is quite regular throughout, because it's due to a downstream obstruction. So I think the duct is just diffusely dilated, regularly dilated. Whereas in contrast for chronic pancreatitis, because the etiology is inflammation, so I think inflammation will just cause what we call scarring irregularly throughout. So some areas will be more tortuous than other areas. In this case, I think if you look at the main pancreatic duct, it seems to be quite regularly dilated. So I think in this case is probably more due to the obstructive lesion downstream.
Can you follow this duct? No.
Sorry?
Because to us, we could find some signals in the area, and there is a possibility that this is a vessel, not a duct. Can you follow the color once more?
Can you see that?
So the signals are appearing in between.
Yeah, I think you see between here.
So they can be color artifact also, or they can be.
I think Malay Shama, is it?
Yes, yes.
Yeah, some may be. But I think this is important, as you mentioned. I think it's important to know which are the vessels and which are not. Can you see that? So I think this is a dilated duct rather than a vascular thing. I think there's some vessel crossing it as well. So I think certainly some areas may be artifact, as you mentioned. So we are in the tail of pancreas. I still believe that this is a dilated duct. This is a vessel here when I twist in. Okay? So some are more the duct dilation. And then we are gradually going to actually go back to the body of pancreas, which is here. And then finally, I think where we go to the neck of pancreas, okay, which has already been shown by previous operator. So I think from the body,
just a question.
Yes.
Sorry. Does this patient have a history of hematemesis? Because if that vascular signal was communicating with the duct, this is how you pick up hemosuccus pancreaticus.
Yes, you're right. I think there's no history to suggest that, and also no history to suggest pseudoaneurysm. So I think sometimes when the duct is very dilated, splenic artery may actually invade into this duct and cause a pseudoaneurysm. That's one of the reasons for hemosuccus pancreaticus, as you mentioned rightly. Okay. So I think this one, I don't believe the patient has any history of hematemesis. Yes. That's a very good learning point as well in this particular case. Okay, so I think there's a dart here right into there. So I think we are just following down, and then I'm actually going down, as you mentioned, to the neck, and then this particular dart just disappear into a mass. Okay. So it just
as you are moving towards neck, it becomes.
I'm actually I'm going to the neck of the pancreas. So I think you can see a mass lesions, which also I think involve to a large extent the neck of the pancreas.
So it has become totally dark. Can you decrease the frequency because we want to see?
Go down to the frequency.
Because maybe we will be able to see what is behind this dark area.
Yes. Can you see that now? We reduce the frequency.
Yes, better, more penetration.
Yeah. I think we now actually go to the full extent, so it's important, full extent of this tumor. And then here also, I think we should try to...
But probably we can see some more duct on the side, lower side, yes.
Yeah.
Okay, so we will have to see it from the other angle, because this angle is not... We'll have to see it from the bulb or...
Yeah, later on. I just want to demonstrate the full extent first. And then the fact that some of the vessels are actually being involved in this particular picture.
But it appears that the celiac artery and supramesenteric artery and the splenic artery both
yes.
are gone.
Yes. So those two vessels on the right hand side, you can see that they are actually involved by the mass here.
So
okay, so it's a huge mass. If you just look at this mass, and then perhaps I think take a particular measurements, you can see that it's a very big mass with a lot of vascular invasion.
So can you try and change the depth of this, because you are seeing only 4 centimeters?
I will measure first, and then after that I'll change the depth. That's just to demonstrate this is the minimum dimension. I think maximum dimension, we haven't seen it. Okay, so even then you can see that it's roughly about 3 cm. So I'll change the dimension a bit more. Okay, so this is on a reduced frequency, I think 5 megahertz, isn't it? Or 6 megahertz.
Maybe if you can move the focus down, maybe we will see more.
Okay, can we move the focus down a bit more? The right, the green button going down.
Yes, I think that is the best we can see. We can see more. But we can now see that the celiac artery is involved.
Yes, the celiac artery has actually gone into the mass itself on the right hand side here.
Into the mass itself.
Yeah, can you see that? It's very good pic. over here. The cursor is here. Okay.
Yes. Yeah, this is the celiac artery.
Yeah, that's the one. So which is actually going into the mass. So I think with this sort of
Wait a minute. Sorry, means as we are. What is this just above celiac artery? This is a node or this is pancreas?
Which
just
one?
above. Just above the celiac artery. This. Yeah.
This is one.
This.
Yeah. No, I think that's a part of the pancreas.
Because generally pancreas cannot come above celiac artery. So it has to be preferably a node.
Yeah, I think you're right. Yeah, that's a node. It's a winking sign. It comes to and fro. In fact, this is probably, I think that's where the celiac artery comes out from. If you push it in, you might be right. That's a node.
Yes, that's more like a node.
Yeah, that's a node. I think it's probably separated from the mass itself.
So that is an important point because the highest point of the pancreas is tuber omental, and that lies at T12 vertebra, and pancreas can never come above the origin of celiac artery. So if you find a mass above the celiac artery, that has to be a node rather than pancreas itself.
Yeah, that's actually a good pickup. I think it's separated from a mass.
It can be an extension of the mass, that is possible.
That's the one you are looking at. So this is probably more like the celiac node. Okay. So the other thing I'd like to actually show while we are here is what we call the contrast, the elastography. Perhaps we can turn it on. So while we are here. So I think that's where I think it's probably not crucial in this particular case, but I think for learning point, we'll look at this part. So if you look at this particular elastography, so basically I think probably Malay, you do a lot of elastography, isn't it? So I think you can see that right in the middle here, this is what we call the blue signal. So generally blue is actually hard mass. So I think this mass certainly is quite stiff. It measures what we call the stiffness of the particular lesion. So I think the whole lesion here is actually quite stiff. Okay, and then there's also so I think in contrast to the outside, maybe here sometimes you've got to be careful. It could be a vessel, but this probably is a softer part. So if you want to actually target the lesion, we'll probably have to target right in the middle where the mass is actually stiffer or harder. So I think blue is actually stiff, whereas green is less, and the red is actually soft. So there's a kind of convention we'll look at. And then another one is to measure what we call the strain ratio. Okay, so I think to do that, you actually do a quantitation. So you take a particular mark and you set it, and then after that you just get a circle here, not too big, enough to cover the particular area, and then you set again, and then after that you go to the second one, go to the reference point. Say we look at this reference point over here. I don't think there's a vessel here. So we can look at the reference point over here and set it again. And after that, we look at it. Okay? And then we set again. So and then on the left-hand side here, move the cursor down. Okay? So if you look at this particular mark, so that's where the strain ratio is. It's actually hard. 11.22.
Check.
Things which are above about 5, I think is considered hard. So I think we can actually look at it. Sometimes I think not in this particular case where we know that there's a high probability of malignancy, but in certain cases where we are not sure, say to try to differentiate between a mass due to chronic pancreatitis versus a mass due to pancreatic cancer, we can actually measure the strain ratio, and also to help us to target the lesion for biopsy. Okay. So I think we'll finish this part, and then after that, we are going to go into the head of pancreas. We'll turn off the elastography. So I go back, and then we'll just go to the bulbar region to look at the head of pancreas, where the main bulk of the lesion is. So I think this particular patient, unfortunately, the mass is relatively big, and it's causing a lot of compression, such as entry into the duodenal bulb is somewhat challenging. In fact, if you look at the top, it's very narrow. it's very hard to actually position the scope adequately for EUS examination. So you'll probably see, can you appreciate, now we are in the head of pancreas area, which is in the duodenal bulb. I think the bulb is actually quite distorted because of the compression due to the tumor from outside. And just above that, this particular area, there's a vessel there. And then just above that, you can see that there's a signal. Okay, so I think relatively difficult to for me to position it because I think the mass itself is causing a lot of distortion. But the above then is likely to be the so-called dilated. I think it's more likely to be dilated CBD, which is above this vessel. Okay, so I think you can. So this is more like the dilated CBD, which is going to the mass. So I think it measures about, let me just see, I can't see the measurements, 7.1. It's not terribly dilated on this, but I think just visually, it's probably dilated. Okay, so I think we turn clockwise back to where the mass is. I probably have fallen out to some extent. We'll turn off the Doppler. Okay, so I think we're back to the head of pancreas area here, which is a duodenal bulb here. You can see that this is the head of pancreas. And then as we turn here, you can see that that's the mass here as you turn slightly to the right-hand side.
Do you think there are collaterals or they are all?
Some of them are collaterals.
We could have a Doppler and just confirm.
We will.
Yeah.
So which vein is blocked? Portal vein?
Some of the portal vein is actually blocked over here. We will just try to get the mass here. But the position is very unstable currently.
So in an unstable position,
yeah.
Do you prefer bulb or you prefer descending duodenum?
I prefer the bulb. We'll try to get a better position.
Okay.
Oh, it falls off again.
So that is also important because in bulb, because you are in a long loop, you are more often more stable rather than in the descending duodenum when there is a chance to slip out as you are trying to.
So I think here we are back to the bulb a bit. Okay. And I think here you probably is a more stable position.
So you would like to hold the scope yourself or you will give it to your assistant?
Generally, I think it depends. Now we are just we are not ready for puncture yet. So I think holding myself is quite okay. But when we are doing the puncture, I think we certainly should get somebody else to hold it. So just let me just look at the vessels again. So I think you can see that there are a lot of vessels around this area, and dilated and tortuous vessels around this area.
But there were not so many vessels when you saw it from the stomach. So
Yeah,
would you
right.
like to go back and do FNA from stomach?
We'll look at that first. I think we'll survey this area first to see whether this one is a bit easier or the one before that.
The collaterals seem to be on one side, so I think if you
Yeah.
can get a window over here, would you prefer doing it from here? Yeah, somewhat here.
There's some vessels up there as well. I think here is probably closer compared with the stomach position, which is further away.
Yes, this is closer here. The distance is very little, but the only problem is
the
whenever
vessels
you apply
intervening.
Doppler, yes, a vessel comes, and more than that, see, because this is appearing as a very thin slice, but when you puncture, at that time, you don't know whether a small vessel will come on the way or not.
So I think we change, that's the...
Why don't you see from the descending duodenum, maybe you will get a better window?
No, I think this one is actually okay. I think it's quite stable now.
Okay.
This position is quite stable now. We'll just check one more time. Yeah, I think it's okay now. So I think it's a question of just getting it into the right position before we do the puncture. So I think it's very stable now. I hardly need to hold it.
Yes.
And I think to answer your question about this portal vein, which is coming down this way, whether it's...
this is a gastroduodenal artery.
Right in the one outside. That's a gastroduodenal, which is probably impeding us. But if you turn this way, I think it's safe.
And this is safer to puncture it because
I think if we turn this way, I think it's safe.
Artery is safer than a vein.
Yeah. So I think if you this is you see the CBD just up there. So I think the CBD is just up there here, over here, and the portal vein, and then as you rightly say, there's a gastroduodenal here. So I think we'll just get a better, I think, position.
So given a choice between going close to an artery or a vein, I will prefer to go close to an artery because the FNA needle is unlikely to puncture an artery, it will slip by, whereas it can hit a vein easily.
Okay.
Yeah, so Lawrence, what do you think? Meaning, it definitely looks like a mass. I
think it's a mass. I think we can measure here. Maybe we're still underestimating, but I think certainly this particular mass here, I think we already showed that it's invaded into the ciliar artery. So I think it's important in this case certainly to try to get a tissue diagnosis ASAP. Okay.
Right. So which needle would you use?
I'd rather prefer because position is not very stable.
Amol, your voice is very loud. Can you ask your mic to...
Okay, sorry. I am a loud mouth person, I suppose.
No, don't worry.
Okay. So I think again, if you look at it, I think just for the sake of demonstration, we show that this one is uniformly stiff here. Okay?
Yes.
So I think uniformly stiff. I don't think there's a particular place to choose. We can just puncture, just about puncture anything, and then you will still get a tumor. So that's the kind of a small little utility of doing elastography. Okay, we'll offer elastography.
Yeah. Okay. So in that situation, you would choose a 22 gauge or a 25 gauge?
I'll do the 25. Two reasons. One is I think the position favors, I think this is unstable position. I think 25 is probably easier. And second reason, I think there's no difference of the elastography. There's no difference in terms of yield between a 25 and a 22 as far as the literature is concerned.
Right.
Okay.
Then so maybe we can just show the technique of FNA because I think we are running a little bit short of time. So we'll just, probably what we can, we'll show the technique of FNA and then probably we'll get the slides ready and then probably in the afternoon session we'll have a discussion on the pathology part.
Okay, that sounds good.
Yeah. So.
Okay, come, let's do it. For this one, I think I need some help to hold the scope.
Yeah,
because it's very unstable. Yeah. And I think the tumor is pushing us down. Okay. So I think same as previous thing, we'll just insert the thing down first, and we're using a Boston Scientific needle, isn't it? A Cook needle, sorry. So and then I'll fix the needle into the okay. So I think in this particular case, we will check again one more time with the Doppler. Okay, we'll accept a bit of vessel. We'll try to actually twist it in a way which is not. And we can adjust it to make sure that I think the schist is coming out this way. Okay, So I think we lock it this way.
Yeah.
Okay.
Yeah, they can show it. They're showing it well. Yeah, no worry.
Okay, I think my assistant is holding it, and then we remove the starter first to make sure that we actually get the sharper end to go in. Okay, so in this particular case, I think I'll release the thing about 6 cm. I think a lot of people just release it completely. I think it's completely fine. Okay, so I think get the position very stable. A bit of pressure inside because as the needle comes out, it's going to, and then you try to actually try to fix a bit of the indentation of the wall, and then just a quick puncture, flip in. Okay, so it's important sometimes to just stabilize with a bit of indentation of the duodenal wall or the gastric wall, and then a quick jab. Otherwise, sometimes it slips.
Yes, that's a very important
very
point. Just
unstable
indentation.
position.
Yes.
Indentation of the wall first, and then come out. After that, I think you can just about doing here. Okay.
Okay, so
and then in and out, I think with the assistant, we can do whatever you want in terms of the what we call the slow pull. I don't think that matters very much. And then I think in terms of the so-called fanning technique, unfortunately, I think sometimes with this sort of tumor, you may have to come out a lot more until it reaches the wall, and then you change position. Otherwise, you're going to hit the same place again and again. Okay, because it's relatively, I think we are in a very unstable position, so it's better if you want to do a proper fanning, come out all the way here first, and then after that, you can change the position. Okay?
Right.
You can change the position so that you can actually obtain maximal so-called areas to puncture. Okay? Again, come out almost outside, so it's close to the wall, and then after that, you can actually change position and puncture again. Okay?
Yeah.
So then I think in this way, your fanning technique is a bit more useful because you hit the as wide an area as possible. Okay, right. So I think each angle trajectory, I think we tend to use five strokes. Strokes. Okay?
Yes.
Amol, we're ready here with Dr. Chantal for the lecture.
Okay.
So,
okay, I think we are done.
Yeah, so
we'll just send this to the cytopath and then see what they think. Okay, keep coming out.
So thank you, Lawrence, for an excellent demonstration of wonderful. So thank you, and I think Suhas and Suresh, you can continue with the talks over there.
Yes.
Dr. Chantal's talk will be first, and then Dr. Dhamija will be presenting the talk from here, and then we can break for a short lunch, and we have to be back at 2 o'clock, and we need to start at 2 o'clock because otherwise, we're going to miss out on a lot of cases in the afternoon. So, CEO, we'll complete the lectures.
Okay, we'll start with Chantal's talk on EUS cytopathology. I request Dr. Malay Sharma to continue as a chairperson, and I request Vikram Bhatia, Kedar Kode, Vijayshri Bide, and Mesh Mandolkar to take as a chairperson.
Yeah, thanks.
Over to you,
Okay, so I was asked to speak about what an endosonographer should know about cytopathology. Pancreatic cancer has a poor disease-free survival even after surgical resection. 95% of patients will die within 5 years. So the best chance of cure is early diagnosis, which is dependent upon high quality and a high quantity of tissue in order for the pathologist to feel comfortable in making the diagnosis. So there has been a lot of talk about improvement in tissue acquisition. And so people want to know, are biopsy needles better than standard FNA needles in improving tissue acquisition and diagnosis? Well, if we look from a historical standpoint in the evolution of core biopsy needles, when we look at both time and complexity, initially we started with the true cut needle, which obviously gave us a biopsy specimen. Unfortunately, you weren't able to actually sample the specimen in different planes. Subsequently, the Procore needle came about with the intention of actually giving you biopsy specimens and allowing for you to actually be able to sample the tissue through the fanning method. In our investigation and evaluating the 22-gauge Procore needle compared to the standard FNA Procore needle, we found that there was no difference in the median number of passes or yield. And in evaluation for actual core tissue, there happened to be no difference. Subsequent evaluation looking at the 25 gauge per core needle, they did find that there was a slightly higher increase in the amount of tissue procured on the first pass. And when looking for actual core specimens, unfortunately, when you looked at the histologic tissue, only 32% of the time did you actually get tissue with retained architecture. So now there has been much discussion amongst most of the companies that produce needles. And recently 2 needles have been introduced, the Shark Core needle by Covidien and the Acquire needle by Boston Scientific. Now both of these needles, they have accessory tips which allow for you to actually penetrate the tumor, and then they have a cutting heel which allows for you to be able to actually cut the tissue so you're able to actually acquire actually intact core fragments. Evaluation of the fork tip, also known as the Shark Core needle, showed that it required minimal amount of, or at least decreased number of passes in order to actually be able to get diagnostic accuracy. But more importantly, 95% of the specimens acquired had actually intact histologic specimen. Our evaluation of the Acquire needle, also known as the Francine needle, showed that you do get sufficient material for rapid on-site evaluation, but more importantly, you also do get material that actually has histologic retained architecture. So in short, preliminary evaluation of both needles show that they give high yield and they give intact architecture, which is new. Now we actually look at a few cases. You can see this is pancreatic, or this is actually pancreatitis. You can see this saponified tissue, which actually has a waxy appearance, and here is a group of acinar cells. However, if you look at the cell block, what you have is this amorphous material, and if a pathologist was to look at this cell block in isolation, they would call this non-diagnostic because there happens to be no pancreatic epithelium. However, using a 25 gauge core needle, you have 86% more tissue, meaning that you actually have acinar cells, you have desmoplastic stroma, and if you were to do 2 passes dedicated with the cell block, you actually happen to have fibrotic tissue with acinar cells, and you have some of the saponified tissue. So combining dense stromal fibrosis, acinar cells, ductal cells, and saponification, a pathologist should have no problem making a diagnosis of pancreatitis. In evaluating neuroendocrine tumors, we typically look for loosely discohesive, monotonous cells that are separated from groups. You have this here, but a pathologist may not be confident in making a diagnosis on this sparse tissue fragment sample. However, if you look at the cell block, you virtually have only blood and a few scant cells here. Now, same patient, using the 25 gauge core needle, you have 96% more tissue at rapid on-site evaluation, meaning that the pathologist will feel more confident in making a diagnosis. But more importantly, when you look at the actual core specimen, you have retained architecture. If you were to look at a carcinoid tumor in the duodenum, it will look exactly the same. You have trabeculate and nest. So this is diagnostic for a neuroendocrine tumor. Why is this important? Because we actually grade neuroendocrine tumors, particularly for patients who are non-surgical or they're they're non-surgical patients. And the reason is that when we look at the actual mitotic indices, if the patient has increased mitosis, they have decreased survival. Now, in order for you to be able to accurately grade the tumor, you need a minimum between 500 to 2,000 cells. Well, if we look at the standard 25 gauge needle, we have less than 30 cells here. Now, do you need to have a biopsy needle in order to be able to accurately grade neuroendocrine tumors? The answer is no. There have been several studies that come from Asia and Europe showing that using the standard 25 gauge, 22 gauge, or 19 gauge needle, you can have concordance with the final surgical specimen that is reliable. If you have over 100 tumor cells, the concordance is about 86%. But if you have more than 2,000 tumor cells, your concordance with the final surgical resection, meaning that the grading, when you look at cytology and looking at surgical resection, over 90% of the time is going to be the same. So what does this mean? It means if you do more passes using larger needles, and if you do this, you should actually get a diagnosis. So more passes equals more tissue, and more tissue equals a diagnosis. Now, if you do not have on-site cytopathology, can you evaluate for adequacy? The answer is yes. You can do macroscopic evaluation. Here you can see you have tan white flecks of tissue collected in cytolite. Here you also have tan white tissue collected in cytolite. This is a standard FNA needle. This is a biopsy needle. So therefore, you can visualize this. Now, if you only had red fragments, most likely you will only have blood. But if you see tan white tissue fragments, you can feel fairly confident that you have sampled your lesion. Now, when it comes to pancreatic adenocarcinoma, typically we have no difficulty in being able to make a diagnosis using the standard FNA needle or a biopsy needle. And here you can see in the cell block, as well in the cell block when you do the core, you have tissue. But 20% of the time, you will not have a diagnosis when trying to evaluate pancreatic adenocarcinoma. And you can see there's no tissue when you are using the standard FNA needle. So why is this the case? Well, one of my colleagues likes to say, they don't care if the needle is in the lesion, they care if the lesion is in the needle. What does this mean? Well, mesenchymal cells give rise to some of the strongest tissue and organs in the body. So it gives rise to osteocytes, which give rise to bone, chondrocytes, which give rise to cartilage, muscle cells, stromal cells, and fibroblasts. Now, when you think of your lesions in the pancreas, whether it's autoimmune pancreatitis, whether it's chronic pancreatitis, or adenocarcinoma, typically there is dense stromal fibrosis. So since this fibrotic tissue is so dense and hard, it is hard to actually procure tissue using the standard 25 gauge FNA needle. Our previous studies have shown that independent of 2 or 4 passes on cell block, 20% of the time it will be non-diagnostic. Moreover, lesions in which you have dense stromal fibroses are more likely to lead to a needle failure. So when is it necessary to use a core needle? Well, if you've done 7 passes and all you're getting is air or very minimal tissue, it may be best to actually switch over to a core needle. Previous studies have shown once you get to 7 passes, there is diminishing returns and you're less likely to get a diagnosis. Now, if you do not have on-site cytopathology, this is another time in which you may want to consider using a biopsy needle. Previous study in which I performed doing a meta-analysis have shown that cytopathology presence is the one factor independent of the skill of the endosonographer and the reference standard for being able to evaluate for rapid on-site evaluation and improving diagnostic accuracy. Subsequent studies have also supported my findings. So when you do a rapid on-site evaluation, your diagnostic yield is significantly improved compared to no on-site evaluation. Also, you have decreased number of indeterminate and unsatisfactory samples. Now, the only time which rows does not seem to make a difference. If your diagnostic or your technical skills at getting tissue are so impressive, then what happens is that the impact of on-site cytopathology may not be as dramatic. Also, if your pathologist happens to be suboptimal, you will also not see the impact of having rows. A recent study which compared having doing 7 passes versus the presence of on-site cytopathology found that there was no difference. They had 80% sensitivity with 7 passes. However, which was concerning to me was that there was only 80% sensitivity with rows. If you're doing rapid on-site evaluation, you have a pathologist in the room, your sensitivity should be above 90%. So there's either one or two things that's happening. Either you have a very fibrotic lesion, you're using a small needle and you're not procuring tissue, or you have a pathologist or cytotechnician who is hesitant in making the diagnoses. It has been proven that in evaluating pancreatic lesions compared to other sites, that there is a learning curve for cytopathologists, and they need to look at approximately 150 pancreatic specimens before they consistently make a diagnosis that is correct. Now, in addition, if you have difficulty in procuring tissue, as I previously mentioned, the mesenchymal cells give rise to the hardest tissue in the body, right? So in that being the case, stromal lesions such as your GIST, schwannomas, leiomyomas, fibrotic lesions with chronic pancreatitis, adenocarcinoma with desmoplastic stroma, and other metastatic tumors such as breast cancer can have a desmoplastic stroma, and colon cancer, you may have a hard time procuring tissue. Architecture. Architecture is very important, but there's only very few times in which you actually need architecture. Typically, when evaluating gastric tumors, if you're looking for a signet ring carcinoma, mold lymphomas, this is when you're going to need to have architecture because signet ring tumors can be very inconspicuous on cytology. If you're looking at liver parenchymal diseases, hepatitis, chronic hepatitis, you're going to need to have intact, complete portal triads, and you're not going to get that with your standard FNA needles. And obviously for lymphoma, if you need to collect substantial material for flow cytometry and for immunohistochemistry, you need to have enough material. So the reality is that every pathologist is not a cytopathologist. So when I look at architecture, I like to compare it to cytology. So if I was to show you this hat, you'll probably say it's a man's hat. But what happens is when it comes to a pathologist, we want to see as much as possible. So if I was to show you this man's hat and also show you this glove and this bottle of propofol, you may have a different conclusion, and you'll have more information in order to be able to determine exactly which man I'm talking about. Now, this is the same thing when it comes to cores. Cores are uninterrupted, contiguous fragments of tissue with retained architecture. Most people don't know how to actually define a core. A core is uninterrupted tissue, elongated, with retained architecture. Here you can see there are two cores. To the left, you have these nice round acinar cells. Here's a schematic showing what acinar cells look like. The nuclei peripherally located, and they form nice round balls. You have acinar cells with intervening stroma, and this is chronic pancreatitis. But to the right, you have these large irregular cells. There is loss of normal architecture. You have some cells with signet ring appearance, and this happens to be a poorly differentiated adenocarcinoma. Now, let me remind you that shape does not determine architecture. Here you have 3 specimens that were all obtained using a core needle. Here you see the chronic pancreatitis, here you see the adenocarcinoma, and here you see an elongated fragment of blood. Blood that is elongated, compact, and coagulated does not equal a core. Core tissue has to have architecture. So sometimes when you see these worms that come out using certain needles, do not misinterpret this as a core. So here's an actual case. We have a 46-year-old female. They had vague abdominal discomfort and gastric wall thickening. We used a 25-gauge needle in the room. We did touch imprints because the tissue came out relatively firm. In looking at the touch imprints, I saw that there was a loss of the normal orderly appearance to this ductal epithelium. But on higher power, some of the cells appear to have somewhat evacuated appearance, and the nucleus was pushed to one side. I was concerned about a possible signet ring tumor, but when I actually looked at the core fragment that was obtained, I saw these very ugly glands that had a loss of the normal architecture. To familiarize with yourself with the normal architecture of the stomach, you have foveolar cells and underlying oxyntic mucosa. This normal tissue does not look like what we saw in the patient. So when I signed the case out, I called it an adenocarcinoma. 1 week later, I got a call from the oncologist saying, did you do any other stains? I said, yes, I did HER2/neu because I'm concerned about this being a gastric tumor and I want to make sure the patient can be receptive to Herceptin. They said, no, the patient also has a pelvic lesion. So at which point in time, I did multiple other stains, including CA-125 and ER, which were both positive. And this patient had a high-grade serous ovarian carcinoma. Now, when evaluating liver, as I previously told you, it's important that we have complete portal triads, which consists of your hepatic artery, bile duct, and your portal vein. We like to have a minimum of 9 complete portal triads when evaluating for hepatitis. The recent publication from multi-institutional study showed that typically when you use the standard 19-gauge FNA needle, you get approximately 14 complete portal triads. At my institution, looking at our evaluation of our own cases, when we typically use a 19-gauge FNA needle, we only get 7, and that is subpar. However, when using the 22-gauge biopsy needle, we get about 19 portal triads, and when using the 19-gauge biopsy needle, we get about 24 portal triads, and we only did 1 case using the 25-gauge biopsy needle, but yet we got 40 complete portal triads, and this happens to be that case where you have bridging fibrosis, and this happens to be stage 3 chronic hepatitis. As I previously mentioned, you also need to be able to evaluate for ancillary studies. Sometimes we miss the forest for the trees. In evaluating pancreatic adenocarcinoma, we focus so much on the adenocarcinoma, but we haven't really focused on the extracellular matrix. Recent studies have shown that the extracellular matrix actually can be a prognostic marker, particularly when you look at necrosis. So to make this short, necrosis is induced by hypoxia-inducing factor 1. What is hypoxia-inducing factor 1? It happens to actually be an interleukin that is produced within the cell. And it actually causes glycolysis, angiogenesis, and migration of the tumor cells. So normally your body produces hypoxia tumor HIF-1 alpha, but what happens is that you have high oxygen concentration, so it's normally degraded. But when there's an oncogenic mutation, you start producing the neoplasm, you have a metabolic shift. So when you have low oxygen, you have an increase in your HIF-alpha-1, which leads to invasion, metastasis, and tumor growth and expansion. But not only does it lead to tumor growth and expansion, it also leads to drug resistance by causing an efflux of the drug. So therefore, patients who have HIF-1, meaning that they have abundant necrosis, they are refractory to radiation therapy, chemotherapy, and targeted therapy. The reality is that oftentimes on cytology, pathologists ignore background necrosis, so they don't mention it. But when you use core needles, and if you look on higher power, you can actually see you have malignant cells, and you have this abundant amorphous necrosis in the background. When you have this amount of necrosis, it should actually be mentioned in your diagnostic report. So you would say that the patient may have vascular invasion, they would have this abundant necrosis, and this patient would have a low disease-free survival, and they probably would be refractory and a non-surgical candidate. Another prognostic marker happens to be fibrosis. Similarly, fibrotic pancreatic adenocarcinomas have been subtyped based upon their molecular profile, and the fibrotic variant, also known as the stromal variant, has a lower disease or a lower survival. The fact is that oftentimes you don't get this fibrotic component when you're using your normal FNA needles, but when you use the core needle, you can see the abundant fibrosis. And the fibrosis, once we also thought that it was only a part of chronic pancreatitis, but actually the fibrosis is an integral part of the tumor. And why is this important? The fibrosis is produced by hyaluronan, and tumors that have a high level of HA have a poor or have a high level of mortality as well. And what do we know? We know that when you have high levels of hyaluronan, you have hypervascularity. What does this mean? It means that your chemotherapeutic agents can't get into the tumor because they have a, sorry if I go back, because they can't actually penetrate because you have this dense stromal fibrosis. So now there are targeted drugs that are actually being investigated in phase 3 trials, which actually show that if you actually deplete the hyaluronan, you will deplete the fibrosis and allow for the vessels to expand, which means that you will have increased delivery of chemotherapeutic agents. So giving the standard gencinapine and paclitaxel really doesn't help the patient. However, if you give it in conjunction with this targeted therapy, you increase or you decrease tumor growth and increase survival. So in short, FNA needles are much cheaper compared to your biopsy needle. Both of them are going to give you early diagnoses. Both of them are minimally invasive. The big difference is that your biopsy needles are going to give you preserved architecture, which you're going to need when you're looking at gastric tumors, liver parenchymal diseases, and also looking at lymphomas. And it also has decreased number of passes. But what you need to recognize is just because you're using a core needle, what you're going to get is more tissue. And it may not always have retained architecture. Sometimes it's only going to be cellular fragments and small groups. So in this illustration, this is what you would normally get when you have an FNA needle. You're going to get some blood, some malignant cells, some normal cells. When you use your biopsy needle, if the lesion is fibrotic or if it's like liver parenchyma, you're going to have intact architecture. However, if it happens to be hemorrhagic, necrotic, or cystic, you're going to get cellular fragments and blood. Do not mistake this and process this as a core specimen. So how should you process a core specimen? When we process FNA needles, or FNA specimens, we want to aggregate those cellular fragments and blood and create a cell block. If you get cellular fragments and blood with the FNB needle, also make a cell block. However, if you happen to get intact core firm tissue, you can process that as routine histology. So the only difference, once again, with FNA needles, you will do cell block. FNB needles, you will want to put it in formalin if it is actually contiguous tissue fragments. But if it comes out as cellular fragments in blood, process it as a routine cell block. Now, mucinous lesions, I'll speak about this very shortly. Last year we had a patient who came in with a 7mm cyst. They just did diagnostic EUS and did not do any aspiration. The patient came 1 year later for a follow-up, and we did on-site evaluation. Here you can see what appears to be more normal ductal epithelium. The nuclei are nice and round. And I like to use the example that you can drive your Fiat relatively easily between the nuclei. However, if you look at this group here, the nuclei are considerably larger. There's multinucleation. You compare this one nuclei to a nuclei over here, you can fit at least 10. It's very irregular, so this is obviously malignancy. So what have we done in hindsight? We know that there are multiple molecular markers that you can use. Immunohistochemical markers, you can do SMAD4, P16.
Can you sum up, please? Sorry about that. We have overshot.
Oh, okay.
Yeah.
All right. Well, I will summarize this very quickly. Okay. So typically when looking at mucinous lesions, you can do both GNAS and you can do KRAS mutations. Typically IPMNs with dysplasia will have one of these mutations. More recently, you can also do a next generation sequencing. Of course, this is very costly. Most patients cannot afford to have this. But what we have found out is that even you can do it in the lab. It's a little bit cheaper, but you will only use next generation sequencing when you have young patients, patients who are non-surgical candidates, and patients who demand this. The reality is that if you actually scrape the cyst wall and you can dislodge some of those cells, we can actually evaluate and see if there's any dysplasia. And it has been found that cytopathologists do have a high degree of inter-observer concordance when you have high-grade dysplasia. So in summary, quantity and quality of tissue can be obtained with standard FNA needles if you do multiple passes. The newer needles, they're great if you do not have a pathologist in the room, and they're particularly better if you have lesions that happen to have a high fibrotic component. The reality is that these newer needles do give you retained architecture, and as I previously mentioned, for select lesions, architecture is important. Valuable information can be achieved if you don't have a pathologist in the room by doing macroscopic on-site evaluation. And correct processing of these tissue specimens is important. Simply because it's called a core needle, it may not give you core tissue, so you don't want to process it as routine histology. Instead, process it as a cell block. There are new pancreatic therapies on the horizon that are important that we actually speak about the extracellular matrix. And finally, when it comes to looking at cystic lesions, molecular markers can help determine dysplastic lesions, and pathologists do have a high degree of concordance when you give us cells that are representative of a dysplastic component. Thank you.
Thank you. So we don't have time for questions because we are running late.
We are ready.
Yeah. Start with the second lecture, Dr. Amit Dhaneja.
So we start with the second lecture.
Amol, he'll address from there now.
Amol, we are ready.
All right. Am I audible? Hello? Hello, auditorium, am I audible?
Yes, yes, you're audible. You can start.
Hello?
Yeah, you can start.
All right. Fair enough. Good afternoon, everyone. First of all, I would like to thank the organizers for the opportunity given to me to come and speak here. I know I am intruding into a primarily GI workshop, but since we share a common hunting ground called Mediastinum, I thought that what we have done over the last 4 to 5 years, that we have had EBUS, about more than 4,000 cases now, I would just share our experience, and it would be both interesting and informative for both GI people and pulmonologists who are a part of this particular conference. So thank you again, Dr. Amol. As we all understand, there are two types of EBUS systems available. We have a linear EBUS and we have a convex EBUS, and we have a radial EBUS. Linear or convex EBUS is primarily to look at the paratracheal or juxtabronchial structures, any airway which can accommodate a scope which is 6.9 mm aorta diameter, and any lesion which is in the surrounding area of the airway can be accessed with a linear or a convex EBUS, as we have just seen in the preceding case. For anything which is not visible endobronchially and is somewhere in the lung parenchyma right up to the periphery, up to the pleura, we would use a radial probe EBUS. But unlike the GI instrument, the radial probe EBUS that we use is just a miniature probe. It is not a dedicated scope, as I would show you. This is the linear EBUS scope. It looks very similar to our bronchoscope. It is 6.9 mm outer diameter, and we have a 1 centimeter ceramic ultrasound tip attached to the distal end. And of course, the alignment of the lights, the angling of the needle is of course technical. I will speak about that later in the conference. This is what the radial probe looks like. You have two versions. This particular version has a balloon which can be inflated with saline. It is primarily used to sample any lesion which is endobronchial to visualize the structures of the airway wall. I will show you an example in a couple of minutes. And of course, the thin probe that you see on the right comes in sizes 1.4 and 1.7 mm, and it can access the pulmonary parenchyma right up to the pleura. In case we have a small bronchus which is going into the consolidation or a mass, it can be seen very clearly. It is a radial scope. It revolves 360 degrees around its own axis. And of course, as I talked when we were presenting the case, the angle of view of ultrasound in a linear scope is just about 50 degrees. So the main indications of EBUS, as we all aware, for the pulmonologist, it is primarily a diagnostic tool for the mediastinum, whether we are dealing with malignancies primarily arising in the airways, or metastatic disease, or lymphomas, or primary GI, primary mediastinal tumors. Now these four on top are primarily looked after by linear EBUS. If we are doing a radial EBUS, of course, we can take care of solitary pulmonary nodules, we can take care of all the kind of pulmonary lesions, be it masses, be it consolidations, be it ground glassing. Of course, we can evaluate an endobronchial tumor to see whether it is actually a carcinoma in situ or an invasive cancer. And of course, if you are doing stenting, laser and cautery regularly, of course, it can actually aid you in your therapeutic procedures as well. And a large study has shown that as high as 40% of your decisions will be altered if you use EBUS for a therapeutic case. You can actually decide upon the stent length, the distance that the tumor has with the nearest artery or a vessel, so that you don't puncture it with the laser or a cautery. You can actually alter your decisions for the benefit of the patient in as high as 40% of cases if you are using EBUS as an aid to therapeutic procedures. Now, most importantly, when we were training, we were taught that it is a primary tool for diagnosing intrathoracic and mediastinal malignancies. Now, a malignancy can present to us in any of these four ways. We can have a small lesion in the airway, in this particular case, right lower lobe. We can have an SPN in the right middle lobe here. We can have a mass in the right lower lobe. And of course, we can have a small lymph node here, which can be metastatic if a case we are suspecting that it is a metastatic malignant disease. Now, let us see how EBUS helps us characterize in a couple of cases and how it helps us to reach a diagnosis in other cases. Now, this is what I was talking about. If you have an endobronchial lesion like this, and you do white light bronchoscopy, this could be an inflammatory lesion, this could be anaplastic or a metaplastic disease, and of course it can be cancer. No CT, no PET scan, since it is very small, will be able to pick it up or light up this particular area to tell you whether we are dealing with a local metaplastic disease or a carcinoma in situ which can be dealt with the local bronchoscopic therapy, or in fact we are dealing with a cancer which has to be dealt with proper staging and would need surgical correction. If you have a radial EBUS, mind you, in this particular case, since you are dealing with a larger airway, we'll use a radial EBUS with the balloon. If you inflate the radial EBUS with the balloon, you see the probe of the endobronchial ultrasound, you have the balloon being inflated and it is filled with saline. To the left side of the wall, you can see the integrity, you see the mucosa, the submucosa, you see the gray bit of the cartilage, the sharp line again is adventitia. The anatomy of the bronchial structure is maintained on the left side, which corresponds to this area on the bronchoscopic image. On the right, you can see a tumor, a soft tissue, which is invading through the cartilage. Anything which is invading through the cartilage in the lung is not carcinoma in situ, it is cancer. So we can see clearly that only the mucosa is visible, which is obviously involved in a certain number of places. You do not see any differentiation of the submucosa, the cartilage, and the adventitia. And in this particular case, we are very sure with just 5-minute workup with the radial endobronchial ultrasound that this case needs to be dealt surgically and not locally like carcinoma in situ. Take, for example, this particular case. He was referred to as elderly gentleman, an 80-year-old gentleman with the right lower lobe mass. He has undergone an endobronchial biopsy somewhere. Of course, it was not fruitful because all we could see was some edema of the mucosa. Now, if you're doing a bronchoscope and you do not have an endobronchial ultrasound, you'll be very tempted to puncture blindly through this area because you know that their mucosa is showing elevation. You see compression of the airway above that. You are 100% sure that this is the area where the tumor is lying. You would puncture it, but mind you, what do you get? If you puncture this particular area, you'll hit a vessel. You would not cause lots of bleeding because that's not much of our concern, but definitely all you will aspirate is blood. You will not get tissue. So with the help of an endobronchial ultrasound, you are not only able to see that there is a vessel in the line of tumor, you are actually able to align yourself to a better looking bronchus and from a better looking area which is devoid of any intervening major vessels. You take a sample from there and you are 98% sure that you are dealing with malignancy, and the pathologist will be very happy with the specimen as well. Mediastinal staging, I don't think I need to talk about. We must have had sessions in the morning. The smallest of nodes, irrespective of the fact that they are PET avid, PET negative, or seen on the CT, but irrespective of the size on the CT, all mediastinal stations in a case of suspected lung cancer have to be evaluated with an EBUS or an EUS, if you have either of the two, to be cytologically, histopathologically sure that you're not dealing with a metastatic lymph node, and of course to upstage or downstage the disease after the patient has gone through all the imaging modalities to stage the lung cancer. Another very interesting case, the case of CA gallbladder. He was posted for surgery when they underwent a PET scan and they see a nodule in the right lung here. I think it is in the middle of lateral segment. Now, if you don't have a radial EBUS, you are blind after this because the scope will not pass beyond this because of the limitation of the diameter. You have 3 subsegments of the lateral segment of the right middle lobe, and each of this will bifurcate into subsegments lower down the line. If you have a radial EBUS, like you can see in the picture-in-picture image here, this is the thin probe EBUS going inside. You are able to see the mass, you are able to see the probe, and of course you are able to see a very sharp boundary. Now this boundary is the interface of air, that is alveolus, with the mass. It gives you a very sharp boundary. You can see that definitely we are dealing with the mass. You can measure the size of the mass. The only drawback with the radial probe that we use is that we do not have a Doppler. So you are not very sure that you are dealing with a vessel, but the echogenicity of the lesion after you've done a couple of cases will definitely tell you to avoid areas which have vessels nearby and try to take a biopsy or a sample from an area which is less vascular and less likely to cause a bleeding. So with this particular radial EBUS technique, we were able to identify the mass and take accurate biopsy. And the yield with the radial EBUS for an SPN in the best of hands would be around 70 to 75% because it is not a real-time guided procedure. If you're doing a linear EBUS, the yield can be as high as 95% in the best of centers, with or without rows, depending upon the expertise and the infrastructure available at that particular center. So it has been an excellent tool to diagnose malignancies. And of course, added on, we of course are able to see the right and the left pulmonary artery. We are able to see the aorta. We are able to see the superior vena cava. And of course, distally, people have now ventured actually into doing an echocardiography through the trachea using the help of an EBUS. So you are able to identify central pulmonary embolus in this particular case who has a embolus in the right pulmonary artery and the left pulmonary artery, and you definitely see that the main pulmonary artery is broader than the aorta, telling you that this patient has pulmonary artery hypertension, and you are able to see this particular clot sitting in the wall of the pulmonary artery very clearly. To give you an example, we had a case here who had a CA breast about 15 years back. She had come to us with hemoptysis. In the workup for hemoptysis, we found out that she had left hilar lymph node which was lighting up on PET, and she also had a thrombus in the left hilar, left pulmonary artery. We actually saw the lesion in the left pulmonary artery. You can see the Doppler. This is the thrombus. This is the needle of an endobronchial ultrasound going into the left pulmonary vessel, left hilar vessel, and we were able to take accurately samples from here to prove that this patient has metastasis, which was 15 years back in the breast. 15 years later, now we see metastasis both in the lymph node as well as in the clot in the left pulmonary vessel, proving that it is a metastatic disease from CA breast. Now coming to the literature, if you have a central pulmonary embolus and the patient is not in a condition to be transported down to a CT scan department, or the patient has some kind of a nephropathy and is not able to get contrast because of nephropathy or any allergic condition, if you pass an endobronchial ultrasound, you are able to see and scan the major vessels. There is a 95 to 97% concordance that you will be diagnosing the patient correctly as a positive pulmonary embolus or a negative pulmonary embolus, vis-a-vis the gold standard now, which is the CT pulmonary angiography. So this is another area. We've had a couple of cases where you picked up incidentally. Unfortunately, we've not had a case where we were able to diagnose a pulmonary embolus on the basis of endobronchial ultrasound. But of course, we picked up a couple of cases, and if the eye of the operator is sharp, you will be able to pick up all the small emboli which are there possible. And of course, I would not advise you to venture into puncturing the aorta and the pulmonary artery straight away. Get experience of the endobronchial ultrasound. Have a surgeon stand by. Make sure that you're working in a center which has the capability to deal with any kind of a catastrophe if you venture into the pulmonary artery or aorta, and then only enter any of the vessels. For beginners, limit yourself to masses and the lymph nodes. So let us see what literature tells us. Now, if you have a CT scan to say that the node is less than 1 centimeter, don't touch it, and if it is more than 1 centimeter, highly likely to be malignant, sensitivity will be around 57%, you'll be specific in 82% of the cases. With an EBUS, the sensitivity can go up to 92% with 100% specificity. And there was a large study in 2006 which proved that even in nodes which are less than 1 centimeter short axis diameter on a CT scan, if you sample these nodes, then your yield of malignancy will go up by at least 20%. So there is logic in targeting each and every node in case of a CA lung when you are trying to stage the disease and not only rely on EBUS, on PET scan or CT scan. Similarly, PET positive nodes in 30% of the cases can have some kind of a tubercular pathology, can have some kind of a sarcoid pathology, or they can be a reactive or an anthracotic lymph node which is lighting up on the PET, but you will be able to disprove that PET positivity by an EBUS or an EUS in as high as 30% cases, and 10% of your PET negative cases will ultimately turn out to be PET positive if all the cases of CA lung are subjected to some kind of cytopathological analysis before we actually go and stage the disease and subject the patient to either surgery or chemotherapy. Now, this is only the first 3 years. We've crossed more than 4,000 cases. We stopped collecting data. If you target mass 71 out of 72 cases, you will be sure that you are hitting it correctly. In the first 3 years, about 135 patients underwent lymph node sampling for suspected metastasis, and we were able to give them correct diagnosis in as high as 95%. And out of these 199 cases, 15% were PET positive, whom we proved that they were not malignant, and the patient was downstaged and underwent a better modality, that is surgery, other than undergoing chemotherapy with the prognosis which is different, very different. Stage 1, 2, and stage 3 and 4, prognosis in CA lung varies greatly. So when we were training and we saw lymph nodes in the West, the first node you puncture was malignant, second node you puncture was malignant, third was malignant. In fact, tuberculosis and sarcoidosis were very far in between, very few far in between, and most of the cases were turned out to be malignant. Unfortunately, or fortunately for us, when we started doing EBUS in our country, the first 300 cases that we published, we saw that as high as 55 to 60% of our cases will have some kind of a benign etiology. Most of them will be granulomatous. They will be either sarcoid or tuberculosis. About 50 out of 300, that is less than 1/6 or about 1/6 only, will be mitotic. Of course, you will be able to see anthracosis, mucor, reactive lymph node, bronchial cyst, and other benign conditions. Of course, they have to be kept under follow-up in case they turn out to be pathological later in the course of the illness. Of course, malignancy will constitute only 1/6 of our work. So let us focus on EBUS for benign mediastinal disorders. Now, this is all our data. We analyzed 129 highly suspected cases of tuberculosis who had intrathoracic adenopathy. We excluded cases who had bilateral symmetrical hilar adenopathy because if we have only granulomas, a pathologist is not able to tell us whether we are dealing with sarcoid or TB. So only patients would have necrosis in the nodes, only patients who had 1 or 2 nodes, or only patients who had asymmetrical nodes and least likely to be sarcoid were picked up for the study. We were able to see 4 cases of malignancies. So 125 of cases of 129 ultimately turned out to be tuberculosis, in which EBUS FNAC was able to give us an answer in as high as 122, which gives us a sensitivity of reaching up to 98%. The most common pathology that you see is necrotizing granulomas. Next in line were granulomas. In 20 cases, we had only necrosis, but microbiology was positive in all of these cases. And of course, only 3 had inadequate sample. So if you go by pathology, in case you have asymmetrical nodes, necrotic nodes, less likely to be sarcoid, granulomas, with or without necrosis in our country, we are dealing with tuberculosis. If we are in the West, of course, histoplasmosis is another differential that has to be looked into. Microbiology, we were getting smear positives in 28%, cultures only culture positive in 28%, almost 37% patients have both culture and smear positive. So almost 84% out of 125 cases we were able to confirm microbiologically to be 100% sure that we are dealing with tuberculosis, not only on the basis of granuloma, but by the basis of AFP and microbacterial culture. We did not have gene expert at our institute during the time the study was done, so we did not have data on the gene expert and other PCR-based methods which can be available, of course, which are available now. But this is only AFP, direct fluorescence, ZN stain, and MTB culture by liquid medium. Of course, then we went on to study whether we are actually able to pick up resistant cases amongst them. We studied 102 cases, and 8 out of them turned out to be having an MDR. That is 7.8%, which is similar to what we see in a pulmonary tuberculosis case. About 5 to 10% cases, depending upon the center that you are working with, will actually turn out to be MDRs. If the patient is previously treated, he has had history of ATT for more than 2 months any time in the past, the chances that the node or the disease is resistant is as high as 33%. In case it is a new patient, the chance of an MDR is only about 2.3%. So I would say that all the nodes in our country, if a patient has high pretest probability of it being tubercular, you have necrosis, you have MON2 positivity, and you have other signs, and you don't have EBUS, mind you, you will be correct in 95% times in giving the patient ATT, and the patient will definitely respond. Only about 2.3% of your cases will turn out to be resistant. In case the patient has had history of ATT in the past, then 33% will turn out to be resistant. Single drug resistance, most significant was streptomycin. So we dissuade everybody from using streptomycin now for MDRs. We primarily rely on amikacin and kanamycin, which are the second line drugs. INH resistance was documented in 5% cases. EBUS for sarcoidosis, this is not my data, but EBUS with sarcoidosis, it is as good as any other investigation now. And blind TBNA, the yield is about 42 to 80%. EBUS TBNA yield is 85 to 90%. EBUS TBNA and transbronchial lung biopsy, the yield can be as high as 95%. So it is virtually becoming the modality of choice now for diagnosing sarcoidosis and tuberculosis. Although not there in the guidelines yet, guidelines would need some more proof, some more papers, but for practical experience, I can tell you that TB and sarcoid, the gold standard for diagnosing in the mediastinum will be EBUS or EUS rather than only CT scan or X-rays. So this is again an extrapolation. Radial EUS was primarily used for diagnosis of SPNs or masses. We further went on to diagnose consolidations, and you were actually able to differentiate the architecture, the ultrasound image of a consolidation to be very different from the mass. You can see the dot, which is the radial EBUS. You can see white dots, which are the air bronchograms. And of course, you can compare the architecture of the consolidation seen on the CT with the architecture of the consolidation seen on the ultrasound. You do not have a sharp interface that you saw with the mass in the previous case. This definitely, we are dealing with a consolidation. And if you target BAL, if you target biopsy from this particular segment, vis-a-vis a conventional bronchoscopic biopsy and a lavage, the yield will vary by about 25%, and we were lucky enough to diagnose nocardia in this particular patient. So just to summarize, EBUS and EUS have proven to be excellent tools to sample lymph nodes for malignancies, and they're gradually replacing the gold standard mediastinoscopy. But in our country, in our experience, and all the centers in the country with whom we have interacted with, it is definitely proving its worth in diagnosing mediastinal benign disorders as good as malignancies. Thank you so much.
Thank you, chairpersons, for chairing the session. I will disperse for lunch and will come back in 20 minutes. Thank you.
सेम है, मेरा हैंड डिफरेंट है. आना चाहिए इसमें. ठहरो. हाँ अब आएगा. नहीं उधर करके दिखाओ. हाँ ठीक है. हाँ करता हूँ. बस ठीक है जी, डन. ठीक है, तो ये सेटिंग ठीक है मेरा. नहीं मेरे ख्याल से सेकंड या थर्ड सेशन का है नेक्स्ट. बाकियों को काम नहीं करेगा. हाँ मैं लैपटॉप लेके जाता हूँ.
आपके पास है कोई, इस पे लगा दो, कोई किसी का हो तो। व्हाट इज डीबीए? कौन सा विजय तो है? विजय वाला नहीं है आपके पास? अच्छा चलाओ। हाँ चला दो, कई बार धोखा दे देता है, देख लेते हैं। देखो हो गया। ये फिर बड़ा क्यों आ रहा है, दिखाओ तो।
नहीं वो रेजोल्यूशन उसका चेंज हो गया।
कैसे करोगे?
आपका पीपीटी कौन सा है?
ये पीपीटी खुला हुआ है, ये पीपीटी खुला हुआ है।
एक मिनट में उसको एडजस्ट कर लेता हूँ। ये फर्स्ट स्लाइड है।
ये फर्स्ट टाइम है। चल रहा है?
नहीं एक मिनट,
बड़ा आ रहा है ना?
नहीं बड़ा नहीं, इसमें वेव्स आ रहा है।
क्यों आ रही है?
नहीं सर वो नहीं।
उसके बाद मुझे वहाँ जाना है। हाँ। क्यों आ रही है खराबी? इसको हटा रहे हो वहाँ से? हाँ? कोई आने तो चाहिए, लोगों को अनाउंस तो कराओ, अनाउंस तो कराओ। बिना अनाउंस के तो फ़ायदा नहीं होगा। बट ये तो फ्रीज है। दिस इज फ्रीज्ड। बहुत सी चल नहीं रहा, ये फ्रीज आ रहा है। व्हाई दिस इज कमिंग एज फ्रीज? व्हाई द स्लाइड्स आर नॉट मूविंग? इमेजेस क्यों नहीं चल रही हैं? इमेज वो स्लाइड मूव नहीं हो रही। ऑन करो
तेरा हैंग हो गया है
उसको पहले हटा के चला के देखा कुछ चला तो था बीच में कुछ आया था
कोई बात नहीं तेरी इट्स की नोट ना की नोट पे है ना तेरा तेरा हैंग हो गया एक काम कर निकाल ले फिर से डाल ये पूरा लैपटॉप बंद कर दे
Good afternoon. We'll be starting our lecture soon. There is one announcement that the EBUS live demo stations will be on the first floor, and those who are interested in tomorrow's hands-on training can give their names to the Olympus counter. I would now like to invite chairpersons for the session, Dr. Vinay Thorat, Dr. Rajesh Gupta, Dr. Vivekanand Kulkarni, and Dr. S. Palniappan. Yeah.
बस वो उसके ऊपर है
नहीं होगा सर वो वीडियोस वगैरह सब नहीं चलेंगे अब नहीं चलेगा वो द मॉर्निंग
Ravindra, can you do a favor? Can you just inform the all of them to come, no? Ravi?
We have, since we are running late, we are restricting the time of the lectures to 12 minutes plus 3 minutes for discussion. And I am sure.
Good afternoon. May I request all the guests to please take their seats. We are shortly going to start the session.
Should I now? Or should I go down?
The first lecture after lunch, Dr. Rajesh Puri is going to talk about next level of EUS imaging. There is slight change in program. Actually, Dr. Rajesh Puri has to leave a little early. So he is going to be the first speaker in post-lunch session, and he is going to talk about role of elastography, contrast, and tissue harmonic modes. And Rajesh Puri is a senior consultant from Medanta Medicity, Gurgaon. Rajesh, please.
Good afternoon, everyone. It's a pleasure to be here, and I would like to thank Dr. Amol Bapai for giving me the opportunity, and would thanks Nilay. He always be helpful for starting the computer. So I'm going to talk subsequent 15 to 20 minutes about the next level imaging, contrast, harmonic EUS, and elastography. We all know that EUS has an advantage over CT scan and MRI because of the better spatial resolution of the EUS. But there are certain gray areas where EUS is not able to give the answers, and where these advanced imaging, contrast, EUS, and elastography may be helpful. So the question is, are these techniques are the master strokes? So in the next 15 minutes, I'm going to say, are they master stroke or they are complementary? It is very important for me to highlight contrast, EUS, and elastography are not the standard of investigation. They are only useful when you are not able to give the answer with the EUS morphology or with an EUS FNA. EUS FNA is still the procedure of choice and standard of care, but FNA has a sensitivity of around 85%, which further reduced to 75%, especially in the mass-forming chronic pancreatitis, where the repeated FNA is negative. Or you are not able to do EUS guided FNA because of the coagulation or intervening vessels, or if you are getting the false negative results, or if the patient has a renal failure, you cannot do the contrast CT and MRI. In those situations only, the contrast EUS and elastography going to use. So it has a limited application, especially in those cases where you are not able to reach a diagnosis with the help of EUS or EUS FNA. The important clinical applications are to differentiate between the benign and the malignant solid and cystic lesion of the pancreas, to differentiate between the benign and malignant lymph node, differentiation of the GIST, benign versus malignant. It increases the accuracy of EUS by giving the guidance to the FNA, especially in a patient who has an underlying malignancy with an acute pancreatitis or mass-forming chronic pancreatitis with suspicion of malignancy, or it helps in decision making in those cases where the EUS FNA is negative. So the equipment needed is, generally there is a pre-installed software of contrast EUS and elastography, which is available in the EU-ME2 as well as Alpha 10, and the scope with the wideband transducer. All echo endoscope is not equipped. Those echo endoscope which has a wideband transducer, you can do the contrast EUS and elastography. So if you look at the fundamental of contrast EUS, similar to the CT scan, it based upon the perfusion of the tissue or the microcirculation of the tissue. So if you look at the Doppler EUS, which only detect the flow into the major vessels, it cannot depict the low flow blood vessels or the small blood vessel at the perfusion level. So if you do a contrast enhanced Doppler EUS, it has a limitation of motion artifacts in the blooming. So to overcome this, the concept of contrast harmonic EUS come. And what is contrast harmonic EUS is, you use the microbubble as a contrast agent, and it goes to the slow flow or at the perfusion level and give the vascularity of the diseased area. And on the basis of the perfusion of the diseased area, you can predict, is it a malignancy, is it benign? The nature of the lesion can be depicted on the basis of the perfusion. And it overcome the problem which arise with the contrast Doppler EUS, that is motion artifacts and the blooming artifacts. What is contrast agents? These are the microbubble, which are 1 to 3 in micron with the central gas and outer lipid layer. Depending upon the constitution on the basis of gas and outer lipid layer, there are various contrast agents are available. The commonly used agents are Sonoview and the Sonozoids. These contrast agents are very safe and they have very least side effects. So the clinical profile, they have no side effects when you use the contrast agents, and it can be used in a patient who has a renal failure because they excrete it through the lungs. As I said, the commonly used agent is Sonoview and Sonozoids. In India, the Sonoview is available, which has sulfur hexafluoride as a gas, and they are 2 to 3 micron, and they can be reconstituted with the saline. The concept of harmonic EUS is, When the sound waves goes to the tissue revert back the sound waves in the form of fundamental frequency. And these are the linear scatter. Along with this fundamental frequency or linear scatter, there is a generation of the second harmonics, which may be the multiple of the fundamental frequency. So in harmonic EUS, the second harmonics generated from the microbubble, and because of the phase shift, the second harmonics are much more larger in comparison to the fundamental frequency. And because of the wide transducer, it suppresses the signal from the tissue. It only picks up the signals from the microbubble, and it gives the idea about the perfusion of the disease organ. And most important is it should always be examined at the low mechanical index, that is 0.1 to 0.6. Regarding the constitution of the contrast agent, it is depicted on the box which comes along with that. And once you reconstitute the solution, it is very important you should use around 16 gauge cannula at the antecubital vein. Attach the contrast agent in parallel to the cannula, and around 10 ml of the saline should be used at around 90 degree, that is another port of the cannula. You inject the contrast agent 1 ml per minute, 1 ml per second, and roughly around you use 4 to 5 ml of the Sonoview. Before injecting, you focus the area into the B mode, use the contrast panel, you will get the dual image. One image is of the B mode, and another image which has a low mechanical index of 0.1 to 0.6, and that is generally black in color. So when you inject the contrast agent, roughly around after 20 seconds, you will get the contrast coming into the normal tissue as well as to the abnormal area. And first 30 seconds is an arterial phase, and subsequent 30 to 60 seconds is the venous phase. Generally, the Sonoview lasts for 60 to 90 seconds, while Sonozoid lasts for 1 to 1.5 minutes. So this is how you inject the contrast agent. You will get 4 kind of pattern while using the contrast EUS. You will get the avascular, especially present in the patient who has an avascular area or the cystic area. You may get the hypovascular, which indicate about the malignancy, isovascular in chronic pancreatitis or in the normal tissue, and if the lesion is hypervascular, indicate about the neuroendocrine tumor. So this is one example. If you look at here, there is a hypoechoic lesion on the B mode. Can we get the pointer? So there is a hypoechoic lesion on the B mode, and with the contrast EUS, you see still it remains hypovascular. That indicate this is an adenocarcinoma. Similar to that, in this you see a large ill-defined mass lesion in the head of the pancreas, and when you do the contrast EUS, you see the contrast agent started appearing here, and you will get an hypovascular area, and that also an small. So it gives the idea about the size of the lesion, as well as in differentiating, is it hypo or hyper, and depending on that you can find out what lesion you are. So this is another example, a small lesion in the body and tail of the pancreas. You use the contrast EUS, and you can see the contrast agent started appearing in the vessel, and similarly the lesion which is seen as an hypervascular area here indicate about the neuroendocrine tumor. Similarly here, you can see the lesion started enhancing, as well as you can see the tumor thrombus that indicate a neuroendocrine tumor has gone to the splenic vein. So depending upon the enhancement, you can differentiate, are you dealing with the hypovascular lesion or hypervascular lesion. Contrast EUS is very important in differentiating the mural nodule versus the mucinous globule. In the above movie, you can see there is an enhancement of the wall of the mural nodule, while here on the B mode image you can visualize there is a mucinous globule, but they don't enhance. So within contrast EUS, you can differentiate in a cystic lesion, are you dealing with the mural nodule or mucinous nodule? That helps in differentiating, are you dealing with the malignant neoplasm or non-malignant. So this is the meta-analysis of 11 studies, more than 1200 patients, and which shows contrast EUS has a pool sensitivity of more than 90%. This is the study from Kitano. were the 277 patients of pancreatic mass. When they compare the contrast EUS with an EUS FNA and MDCT, for the lesion of more than 2 centimeter, the accuracy of CS contrast harmonic EUS and the EUS FNA is similar. But 67 patients where the lesion is less than 2 centimeter in size, and what they have seen, the contrast EUS has a sensitivity of 91% in comparison to the MDCT, which has 70%. And when they did the EUS guided FNA using the contrast EUS, the sensitivity of EUS FNA increased from 90 to 100%. This is another study which says the same about by using the contrast EUS, the sensitivity of EUS FNA increased from 70 to around 90%. They can detect the false negative test, which is seen on the EUS guided FNA, but when the contrast EUS was done, which shows an hypoechoic lesion in favor about the malignancy. Contrast EUS and another advantage in differentiating a benign versus malignant gist, and the important point is if you see the abnormal large vessels, that indicate about the high grade malignancy, but if you see an homogeneous and the regular vessels. So the important thing is if you don't see these vessels that is irregular and the enlarged in size, that rules out that the gist is malignant in nature. Now a few words about the elastography. Elastography is a real-time evaluation of the tissue stiffness, and the degree of deformity is the function of stiffness, and the pressure is applied by the transducer of the echoendoscope or by respiration or the vascular pulsation. So once you focus the lesion and when you start the elastographic mode, depending upon the stiffness of the tissue, you will get the depicted the different color pattern on the B mode image, where the blue color indicate the hardness of the lesion, while the red and the yellow indicate about the softness of the lesion. So the soft tissue will have a larger strain in comparison to the hard tissue, which has the less strain. So hard tissue favors about malignancy or more stiff lesion, while the soft tissue indicate a benign in nature. There are two kinds of elastography: the qualitative elastography, which on the basis of color mapping, and second is quantitative elastography in the form of hue histogram and the strain ratio. What is the qualitative elastography? In the qualitative elastography, once you focus the B mode image, use the elastographic mode, you will get the dual panel image. And once you get the dual panel image, select the area of interest. This is very important. This box should not involve the entire area of the image. It should take around 50% of the area should be covered by the lesion, as well as 50% from the surrounding tissue. And it is important you should avoid the blood vessels as well as the bony part. So, and you see the color pattern. If you see the color pattern which is similar for 5 seconds, that is the main color pattern will decide. If you get the green pattern like this, that indicate you are dealing with a benign node, but if you see a predominant blue pattern, that indicate it is malignant lymph node. But the qualitative elastography has certain limitation because it is subjective. We are biased because before doing the elastography, we know that we have in mind that this lesion might be malignant or benign. So there are various color pattern come. So it is very difficult to decide which image is right or which is wrong. There is an inter-observer variation. There is a lack of reproducibility of the image, and sometimes by the excessive compression of the transducer, you will get the different color patterns. And sometimes it is very difficult to get, when you get the mix of the color, it is very difficult to say how much green or red is allowed in a blue area to say it is malignant or benign. So qualitative elastography is an observer dependent and it is more subjective. To overcome the limitation of the qualitative elastography, the concept of the semi-quantitative or quantitative elastography came, and one of them is the hue histogram. What is hue histogram? Is a graphical representation of the various color pattern. In the qualitative, you just see the color which comes on the screen, which lasts for more than 5 seconds in the same way. But here you will get the graphical representation. On the y-axis, you will see the in each color pattern how many pixels are there, and on the x-axis you will see the different color pattern. And the mean value indicate the elasticity of the lesion. And depending upon that, using the cutoff value of 175, if the value is less than this, it indicate the lesion may be malignant in nature. And if it is more than that, it indicates it is benign in nature. So using the Hue histogram, the Adrian soft 2S says it has a sensitivity of more than 91%. Another method is quantitative elastography is strain ratio. What is the strain ratio? Similar to the elastography, you develop the dual panel image, choose the area of interest, which is a 50% lesion and 50% normal tissue. You see the image color pattern which has come. Now you choose the area. A is an area of interest, which is the diseased area. It is very important to select the maximum part of the area, not the part of the disease area. Try to select the maximum part of the area. The question comes regarding the reference area. In various studies, some people has used the reference area as an intestinal wall, and the concept comes from the breast elastography, where the reference area was the fat. So some people use the reference area as an intestinal wall.
Rajesh, just a small request because of short of time, because we're already
I think
late.
we have 4 minutes.
No, I think the 15 minutes.
Okay.
So you
just give me 2
have to-
minutes.
Sure.
So the area, the reference area will be either an intestinal wall or the normal tissue, and the ratio of B upon A is called as strain ratio. So because the reference area included in the different study is different, so you will get the different value of the strain ratio. In some study it is used as 3.28, in some study it has been used 6. So in the study by Adrian, if you're using the cutoff value of 6.04, it has a sensitivity of predicting about the malignancy is around 100%. So this is a meta-analysis using both qualitative and quantitative elastography, which shows the sensitivity of more than 90%. Now the most important question for endosonographer and the most difficult question is, how can you differentiate a patient of mass-forming chronic pancreatitis with the malignancy? I think that is the most important thing which you require to answer. And in my opinion, using the clinical profile of the patients, tumor marker, doing the repeated FNA, or using the contrast EUS and elastography as a separate or in combination is going to give the answer, is the patient of chronic pancreatitis with the mass is having underlying malignancy or not. There are new quantitative approach in the form of time intensity curve, which I'm not going to discuss. So this is the recently published study in 2016, where they have used the soft and the hypervascular. Soft is on elastography, hypervascular on contrast, and hard and hypovascular. If both the things are present, both the things in a one disease area, if the hard or hypovascular, the positive predictive value and specificity of contrast EUS and elastography is 100%. So if you find soft on elastography and hypervascular, that indicate it is benign, and reverse of that is malignant. So this is our one of the case where the repeated FNA was negative, and we did both elastography and contrast EUS, and guiding that we did a contrast EUS guided FNA, and it turns out to be malignancy. So in future, these modality may be used to assess the response to the chemotherapy, because those patient who has a abundant intratumoral flow, they respond better to the chemotherapy. It gives the idea about the surgical planning, because it gives very clear-cut demarcation between the vascular involvement, may be used as a therapeutic agent by delivering the bioactive substances, and may be useful for depicting the early chronic pancreatitis till where the hyperechoic foci and stent has not come. So the answer to these is these techniques are master stroke. I think still the EUS and EUS FNA is the standard of choice. Contrast EUS and elastography, we as a limited data, we require more and more studies. So to conclude, elastography and contrast EUS are very promising technique, but especially where you are not getting the result with an EUS FNA, tissue is still the issue. These techniques are complementary. They don't replace the EUS FNA. They help in targeting the site of FNA. Can these techniques replace FNA? I think still there is a long way to go. And these technique has a short learning curve. I think we can learn easily these techniques. Thank you.
Thank you, Rajesh. For just one comment or question, because of want of time, we will not allow any other questions. Any
I
comment?
invite Dr. Vinay Thorat to join the chairperson group.
I have done in around 8 to 10 cases. I have published in GI endoscopy also. In those cases, in the tuberculosis, what we have seen is the mixed pattern because of the necrosis. There is an area where there is a no enhancement, and there is an area where there is an isovascular. But it is not typical because in the tuberculosis we get lot of necrosis or in the center. So I have done in around 8 to 10 cases, and we have published in the GI endoscopy also.
A small request for a speaker, please restrict yourself to 15 minutes because lack of time we are making a short lecture.
Thank you.
May I invite the next speaker, Dr. Nile. All of you are quite familiar with him. He's a very aggressive gastroenterologist from Ahmedabad, very well read. And so he's going to talk on technique of EUS FNA. Nile.
Yeah, thank you, Vinay, for the introduction. I'm coming back to basics from the very hi-fi, and which probably I still haven't been able to understand it fully. But as Rajesh told us that what matters is tissue, and that is what we are going to talk about it, how to get good tissue. We know that it's the cornerstone of our endoscopic ultrasound therapy, that's taking out biopsies, and it is very accurate in pancreatic lesions up to 85%, lymph nodes 90%. But as you know that it's not 100%, number one, and we still sometimes struggle to get better tissue. So there are challenges. Sometimes the tumor is too hard, sometimes the lesion is behind the calcific area, but many a times we do a lot of struggle, take out the tissue, and then it is acellular or paucicellular, and we can't get the diagnosis. Or it is bloody necrotic aspirate. Or worse, it is non-representative sample. So how to get all these issues sorted out, and that is what we are going to discuss now. Before we talk, we have to understand we should not be doing FNA if there is no influence on management or treatment outcome. We have to consider risk of tumor seeding. Of course, it's pretty low in case of endoscopic ultrasound guided biopsy. And of course, if there is a risk which is involved, like bleeding, infection, or trauma to surrounding structure, we should not be doing EUS FNA. What are the steps? And I'm going to restrict my talk on technical part. We have to verify the indication, whether it is indicated or not. We have to localize the lesion, choose the correct needle, insert the needle in the right path, and take the biopsy or FNA in the right way. And we are going to discuss it one by one. When you choose a lesion, the scope has to be in a straight position. If it is too coiled, then you can have a problem. Once that is done, you have to localize the lesion and also put the lesion into the natural part of the needle. What does that mean? That means that elevator is open. You don't use elevator as far as possible while doing FNA. So elevator is open, and the lesion is such that the needle which comes out from here, you can take biopsy from here, you can take biopsy from here, you can take biopsy from here. And there is a way to hold the needle while taking biopsy, and this is what it is. You hold the biopsy with your 2 fingers, but you move the needle with thumb and index finger. This is very crucial because it gives you better power, better control. So hold it like this and do like this. This is very important. How to choose a needle? Not necessarily bigger is better in this case. There are issues with bigger needle that it is bloody many a times. Smaller needles have problem of less blood, but they can also get less tissue. So you have to balance it out. And it all depends on what the indication is. If it is pancreas, then 25 gauge needle is what is recommended. I do use 22 gauge needle most of the times because if you need to do an IHC, then 25 gauge needle will not give you enough tissue. Lymph node 22 is good enough. If core biopsy, and I'm not going to go into detail because the previous speaker had already spoken in a length, is required, particularly in rhinitis plastica, lymphoma, autoimmune pancreatitis, or you want to take liver biopsy, you have to use core biopsy needles. While doing biopsy, you have to avoid anechoic necrotic area, which is in the center of the lesion. So you have to take biopsy from the periphery of the lesion, which is non-necrotic. you have to target the hardest part of the lesion. You have to target the lesion, that if there are many lymph nodes, you have to target the lymph node which you think is the most pathological. In my live case, I showed you that we took the lesion which probably was the most pathological. And you have to take biopsy from different part of the lesion. And that is done by either a fanning technique or a multiple pass technique. Both are almost same. In fanning technique, you put a needle and then put it in a different direction, but you don't really take out the needle out of the lesion. In multiple pass, you really take out the needle out of the lesion, and then you relocate the lesion in different differently. And that is done usually by pushing and pulling the scope, or by doing up and down of the big wheel, and also moving the shoulder, and lastly by doing the elevator thing. This is a classical fanning technique. This is again a porta node. This is a portal vein, lever, and this is how we do. I start my fanning from the right edge of the lesion, as you can see here, and then do 4 passes in one path, then change the trajectory of the needle, go to the second, the different area, then again change, and that's how I cover the entire lymph node or entire lesion. So from right to left, I cover entire region while remaining into the lesion. This is classical fanning technique. How many passes to be done while doing EUS and FNA? Usually 5, sometimes you have to go up to 7. More than 7 is useless. If you don't get it by 7, you have to change your needle, you have to change the tactic. While using FNA, do you use suction or not? Suction is useful when the tumor is too hard, you want to take a core biopsy, but otherwise suction can create bloody sample. Sometimes you don't use suction, you get less cell, less tissue. But most of the times now we don't use suction. If we at all use suction, we call it as a stellate suction. That's a slow withdrawal of the stellate, as you can see in this video. Sorry, the faces are coming in this video, but I was just in a hurry. As you can see, there is a slow pull of the needle stellate which is coming, and we keep on doing the FNA, as you can see over here. And you can see that only the index finger and the thumb is moving while taking biopsy. Almost always, if it is lymph node, we don't use suction. In pancreas, the first pass is without suction. If we don't get enough tissue, then we do use suction later on. What to do with stellate? Stellate comes with the needle. It prevents clogging of the needle due to gut wall tissue, but many times it is more time consuming and it doesn't really add on to anything. And that's why most of the times we don't use stellate nowadays. Stellate is required if you want to do fluid aspirate, or you want to do fiducial marker placement, or if the gut wall and the lesion distance is too much, then you do need a stellate. So it is absolutely mandatory. If there are multiple lesions, then which one to target? Like, you have to target the lesion which is the best, which will change the course of your treatment. Meaning that if you are suspecting a malignancy, there are 2 lesions, you have to target the lesion which will give you the highest stage of malignancy. In fact, this is the EUS we were doing, and you can see a bile duct over here. This is a diverticulum. Just above it, there is a lesion. It's a 12 millimeter lesion in the pancreas. We took FNA, but while coming out, this is what we saw in the liver. This is a left lobe of liver. There is a 5 millimeter lesion into the left lobe of liver. Had we known, probably we would have hit this lesion first. But we did not know that. So after doing this, we are doing FNA from this. But if you want to ask me which lesion is more important, probably this lesion is more important, because that makes the lesion inoperable, or if it is a neuroendocrine tumor, you have to do something else. So, and in this case, we had changed the needle. This was 22 gauge needle, this was 25 gauge needle. But if you are doing this first, then you can use the same needle for both the lesion. There are certain things which are required when you are aspirating a cyst fluid, or you are doing an FNA in cystic lesion. If it is too big, 19 gauge is better, because you can aspirate out even thick fluid. We have to aspirate out the fluid in one go. If certain ml of fluid is remaining and then it is not coming out, there is no point in poking the needle in different directions. Just leave that thing. It's okay. If it is a multiseptated cyst, then you have to take the most superficial big cyst, which you take it out. Don't touch other cyst. If there is a mass in the cystic lesion, take the biopsy from the mass and don't take fluid for aspirate. If the fluid which is, and of course sometimes somebody would recommend that you take biopsy even from the cyst wall. That's not recommended because that will cause bleeding. And suppose the cyst is too small and the fluid is too small, too less, then there is no point in sending for cytology, because I have never seen a single cytology coming positive. So you have to do a biochemistry on that fluid rather than doing a cytology. Sometimes the lesion is by a very moving organ like stomach, and that lesion is also very small, and that also is in retroperitoneum where it moves quite much. So what do? You can't do one jab, what we do it in EUS FNA. So what you do is you do two-step FNA. That is by placing the needle out of the bowel, wait, and then once the lesion comes with respiration, lesion would move. But when it comes near your needle, just put another second jab. That is called two-step FNA. That is especially important in perigastric, very mobile lesion. Sometimes the lesion is too hard, and even if you have used a new needle, you can't puncture. Or if you are doing it from a D1, your scope is bent and you can't just puncture it so well. So what do? When you can't do a puncture with even a new needle, you have to first plant the needle into the lesion out at the gut wall, let the needle be at the lesion wall, and then push the scope. Of course, you have to be careful. That will push the needle in, and then you can do it, especially for indurated hard lesion. This is the method we do. How to prepare slides is also important. As you can see here, you put the specimen and then in one go with gentle pressure, you have to apply pressure. You have to prepare the slide. This is very important. And always take the clot in formalin, as you can see over here, and to prepare cell block. And if you have put that thing in formalin, why it is important? Because you can then process it as a histopathology and you can do an IHC on that. Of course, I'm not going to talk on that rapid on-site evaluation, but it can change. If you have a pathologist, if you are lucky to have a pathologist, it's good. If it is not, at least you should know how to use a microscope to say whether you have a pathological tissue or not. That is enough. You don't have to make a diagnosis. And always talk to your pathologist, because pathologists are not aware of the history most of the time. They don't know what to do with the specimen. So if you do it, your chance of getting a better or positive cytology would be very high. And of course, if there is a problem, Rajesh just showed us the technology which can guide us to take a EUS FNA. That is what we should be doing. Certain do's and don'ts. Do is always look at the lesion, optimum needle, optimum position of the lesion, use the correct technique. On-site cytopathology may help you, but please don't compromise on the technique, needle, passes, or time. In the end, I would say quality is not an accident, it is the act of intelligent effort. Thank you very much.
Thank you, Nilay, for excellent talk and finishing well in time. Questions?
If you didn't have access to an on-site pathologist and your differential included either tumor or TB, like most of our patients, how would you handle the FNA sample?
No, they also, even if you have cytopathologists on site, they would not give you the final diagnosis. They would just say, one, that the tissue is adequate. Number two, that the tissue is representative of the pathology, and they would just give you a provisional diagnosis. They would take the slides back to their lab and give the final diagnosis afterwards.
I mean, would you send a core sample in saline and in formalin as well?
If it is a lymph node, we always take it in saline. We put it for gene expert and blood culture or AFB culture. But if it is not a lymph node, we do it always in formalin as well as the slides, and we fix it with cytofix.
Nile, a cystic lesion in the head of pancreas, if it's like you can go through the stomach as well as duodenum, what will be your preference? Should do it through the stomach only, or it can be done from
Yeah, I couldn't get you, like,
Yes.
The best
The approach.
window I get, I go from there. There is nothing like that. But I would prefer duodenum if it is there. If the step position, see, you have to have a better access, no vessels, and better stability. It hardly matters from where you go.
Maybe what he's asking is a needle track seedling, no?
For cystic lesion, you are not worried about it.
No, even if it's solid one. I think we should not worry about it, no, Nilay? Is it anything?
Yeah, seedling, first of all, is not common. But yes, if it is a pancreatic head mass, duodenum is better because it is going to go out with the surgery. I really don't know. Do you really do biopsies in HCC nowadays? No. Yeah, we don't do it now. Liver biopsy, I said liver biopsy. You want to do liver biopsy to know the etiology. I do also liver. So if you want to know that, no HCC. Unless it's an indeterminate dysplastic nodule and you waited enough and you don't know what to do with it, yes. No, anything is. If it is EUS, fine. Otherwise.
Thank you, Nilay.
There is a shuffling of talk. Next talk is by Vikram Bhatia. The next talk is by Vikram Bhatia, Mini Probe EUS.
Thank you, Chairperson, sir. And I'll be talking on So I'll be talking on probe sonography, and this is something which many of us may not do. So the learning objective of this talk was to explain the principles of mini probe sonography. My topic was whether it is practical or academic. Obviously, we should understand the principles of mini probe sonography, and then since the indications are not very well defined, after understanding the principles, we can decide where and when we want to use this technology. I think it's heavily underutilized. Most important in India is how to take care of the EUS probe unit, because our concern is that we might break the delicate probes and then it doesn't make economic sense to have one in our hospital. EUS mini probes, I feel, are always an adjunct. So what is the adjunctive use of mini probe during endoscopy? I have used the adjective adjunct right at the start, and adjunctive use of mini probe during ERCP. These are, in practical terms, hardly ever standalone investigations. You are doing an endoscopy and you use a mini probe. You are doing an ERCP, you do a mini probe. Sometimes, obviously, you go with the intention solely of doing a mini probe sonography. Now, I want a pointer if there is one. So, if you see, there is a plastic housing and then there is a single transducer. That's the little black thing which is at the tip, and there is a cable running along the length of the shaft which rotates this transducer. I will talk of the Olympus mini probes, with which I have the only experience. Fujinon also makes some. Most of us have not used these. Now, this casing is filled with oil, and this is a rotating transducer. Remember that a mechanically rotating transducer has a better lateral resolution against what you would intuitively ascribe to an electronic probe. So this has a higher resolution. Two, the second question is that since it has a limited depth of penetration, why don't we reduce the frequency? Why should there be 12 megahertz, 20 megahertz? Why not make it at 6 megahertz? That is because the size of the transducer is small, and once the size of the transducer is small, the area of focus and the divergence of the ultrasound beam in the far field becomes highly frequency dependent. So if you have a higher frequency, smaller probe, the area of focus where you have the maximum lateral resolution is wide, and two, the divergence of the beam in the far field is small. So although I am seeing say only 2 centimeter, but I am seeing this 2 centimeter very well. If I made my probe of say 6 megahertz, I would possibly see increasing depth, but I wouldn't see it well. So the compromise for lateral resolution is between the size of the transducer and the frequency. The smaller the transducer, the more frequency becomes important, and therefore, since the transducers are small, by default they have to be at higher frequency, and hence they can image close to the organ where you are inserting them. This is just an example of how a mini probe EUS sets up. This is our working cart. You have the standard ultrasound processor, the light source and the video processors, and this is what is called the probe drive unit. So you just can't plug it in. This is a probe drive unit which is connected to the EUM2 video processor, and the latest probe drive unit is MAG1720. And this is the probe drive unit which actually rotates the wire in the shaft of the probe in concert with the ultrasound processor. And this is the standard set of components which you give, which is the ultrasonic probe, a probe holder, and a water resistant cap which goes here. I'll just show you how. This is just an example to show you that when you have used or done with the ultrasound probe, you must know how to take care of it. So there is a cap in your kit. You put the cap here, there is a hole here, and you hang the probe with this hole. Then there is a probe holder which fits here, and then you don't let the probe dangle. You pass it through the probe holder and hang it like this. Now I'll show you how to store it later. The standard probes are UM2R and UM3R. Now these can go through a gastroscope with a 2.8 millimeter channel. My suggestion is, if possible, use a double channel scope so that in one channel you can instill water, but if it is not there, a standard gastroscope will do. These image at 12 megahertz and 20 megahertz of frequencies. You also have UM-DP12 and UM-DP20. What do they mean? The only difference is they can image dual plane imaging, which I will just show you what it means. This is the EUS probe, UM-DG20-31R. DG means dual plane, G means it goes over a guide wire, and then 3.1 millimeter diameter and 20 megahertz is the frequency. Now this part remains the same. Only thing is, see the tip. It has a monorail design with a guide wire port. Rest is the same. It's a mechanically rotating transducer with a oil fluid inside. So obviously you have to be very careful when you are passing it over a duodenoscope. You release the elevator and you start imaging on withdrawal, never on insertion. Now how do you prepare the probe? You look closely at the tip of the probe and confirm the absence of air bubbles. And how do you remove the air bubbles? You swing it. Olympus recommends that you swing it like this, but I find it practically not possible. So you either hang it for half an hour with the tip down, or what we do in my unit is to swing it like this. It looks slightly funny, but then the image is good. And before you insert it in the patient, put it in a water beaker to see that there are no artifacts. So you swing it so that the oil is completely there surrounding the transducer and the wire housing, so that only then you will get a good imaging. This is how you store the probe. It is hung with a hook, and then the probe is hung in a loose, non-kinged maneuver. So you must take care of your probes, and although people say they are supposed to last 20, 30 procedures, they last way, way beyond that if you use them carefully. Now, what is DPR? DPR is dual plane reconstruction. So what although you are acquiring radial images, you are acquiring a stack of it in a stroke of 15, 20, 30 or 40 millimeters. So what the processor has done, it has acquired multiple horizontal images and stacked them up, and then made a constructed virtually a linear image out of it. So in DPR probes, what you see on the screen is simultaneous radial as well as linear imaging without having a linear array probe in real time. That is DPR image. Why do you need it? You need it because it allows evaluation of both the penetration and the longitudinal borders. And therefore, if you are doing it, say, in a gastric carcinoma, it allows you a very good visualization as you pull the probe over it, or actually keep the probe over it. And this is a DPR. So this is a LST in the rectum. Just see that this is showing you the depth and also the longitudinal extent. The current generation of probes also allow you 3D imaging. And this is again a very excellent thing. You can do surface rendering, you can rotate it, you can do volumetry. Again, none of these are established indications. but they just show you the potential of probe sonography, and then sky is the limit. It depends on your imagination, how you want to use it clinically. So all I can offer you is some examples. Now, these are all original ideas. You may differ with me. This is where I personally find them useful. You may find them useful in different aspects in your practice. Now, if I do an endoscopy, I can use a mini probe in certain situations for rapid clarification. If it's a lipoma, you place a probe and the issue settles there and then without doing a formal EUS. Rectal nets, pancreatic rest, small mural cysts, very commonly seen in the esophagus, these tiny mural cysts, we keep picking them off and on. Also varices, when there is a lot of confusion, I shall just show you these cases. Why in rectal nets? Because we know that less than 10 millimeter size nets without invasion of muscularis propria, and all this can be defined very well with mini probe. Obviously, you can do it with the standard radial EUS probe, can be endoscopically removed by a duet band ligation, period. So EUS, sigmoidoscopy, mini probe, and a resection. GI lipomas, again, one, removing them is futile. Two, removing them is risky. Why is it risky? You try to snare them, it is fat. They conduct electricity very poorly. The tissue heats and just perforates. So not only are removal of lipomas unnecessary, they are also risky. So you pass a mini probe, see it's a lipoma, and then no further follow-up needed. At most, if you really are desperate to remove it, you just ligate and let go. You don't need a histology if it's a lipoma. Now, just to show you a case of esophageal carcinoma, again a treated esophageal carcinoma. My time is going very fast, I'll rush through. This is just to show you that the mini probe at 12 megahertz can define the borders, and a standard radial EUS can define the borders. So again, quite capable. What is important is to distinguish between T1A and T1B esophageal squamous cell carcinomas confined to the mucosa and the submucosa. And both of these are early cancers, but the lymph node metastasis in esophagus starts when it goes into the submucosa. It is difficult, very difficult to stage it accurately because there is thin esophageal wall, difficulty in water filling, middle esophagus is wider, there is things pulsating around you. So obviously this is more difficult than what it seems. But more question is, do you actually need to do it? Most Japanese endoscopists would tell you that in the current era with magnification, chromoendoscopy, it is optional. The only place where I would use it before resection is in protruded lesion, esophageal lesion, or even protruded gastric lesions, where the enhanced endoscopy becomes incapable or truly capable of defining the depth of invasion. That's where you should be using mini probes in today's era. Now, more commonly in our practice is non-traversable esophageal cancers. Can I pass a mini probe and get away with it? The answer in my mind is that EUS staging of non-traversable esophageal cancer, or for that matter, now there are enough studies in 2016 to tell you that if the patient has dysphagia, you don't need EUS to stage it. These are almost all advanced cancers. They go straight for neoadjuvant. So no mini probe, no standard EUS. Two, the depth of penetration obviously is inadequate to stage these bulky tumors, and there is no nodal staging. Now another good, can I take 2 more minutes maybe? Because I was told I had 20 minutes, so I'll just rush through. So a good example is a bleeding lesion. I wanted to show you an example of De La Foy, and there is a clip which is seen as a hyperechoic artifacts, and then there are certain vessels. On mini probe, normally we don't see vessels in the submucosa. If you do, they are usually abnormal. So we can, as we go on further, you can see a vessel here. And this patient, I was confident, has been adequately clipped. He was referred to me from outside, but the vessel was patent. I sent him back. He re-bled the same night and was then operated. So lesson learned, I got wiser. One thing which I find it very useful is for glue injection to see a complete obturation. My way of gluing in EUS guidance is to take the standard gastroscope, target it with a mini probe, remove the probe and inject it. So I don't do with the standard linear scopes. I find it much more useful and practical in that way. My gastroscope is already targeting the patent varix. I confirm patency, I inject, I confirm the obturation. And it's as simple as that. So this was a D3 varix showing you a complete obturation in a massively bleeding patient. Again, very difficult to decide if these varices are obturated. These have obviously been glued before, and as we go further, I made one more injection, and then again, It's reasonably simple. Through the same endoscope down the patient's stomach, you can confirm that it's been obturated. Again, just to share with you, a lady with esophageal pain, endoscopic study normal. I'll stop the the video very soon. Just look at this thick muscle. This is very thick muscularis propria. This was the cause of her dysmotility. Biopsy showed eosinophilic esophagitis. This is not a nutcracker. This is actually a jackhammer esophagus. Gave her steroids, followed her up. This is the kind of resolution. On mini probe EUS, you could see the difference in the muscularis propria with a resolution in histology and a complete resolution on manometry. So just to show you an example how mini probe can help you in your day-to-day practice, I'll have to skip EL-EUS, I think, because of the time. I'll only tell you that it's good for choledocholithiasis when you have done a cholangiogram and you don't see a stone which you wish to see.
Vikram, we'll have to wind up actually.
I'll run and I'll go through. In strictures, if ERCP is being done, we perform EUS during the same examination as an adjunct to cholangiography brushing biopsy. If ERCP is not needed for therapeutic intent, then EUS can be, the standard EUS may be much better. So if you're doing ERCP for a stricture, might as well add EUS. But if you're not doing ERCP for other reasons, then a standard EUS will give you the advantage. Obviously in portal biliopathy, it is great. These are the signs of malignancies. And I shall just, last slides. EUS has often been touted to distinguish the sphincter of Oddi. And the difference is that if the tumor is confined to the Oddi sphincter, it is 0% METs, while if it goes into the submucosa, it is 30% METs, and the staging is T1. This is D0 Japanese, this is D1 Japanese, and they often do a EUS to decide before a ampulectomy. My take is that I have tried this multiple times. It's very difficult. In practical terms, there is tangential imaging, very difficult to stabilize a mini probe at the ampulla. Very often these patients have had previously cut sphincters or a stent in situ. Again, it becomes very difficult. And there really is no true impact. 50 ml water. So the take-home points from my talk are, the point I want to make is mini probe sonography is an easy adjunct to endoscopic procedures. It has the potential to rapidly clarify the significance of what I call lumps and bumps, which you see on GI endoscopies there and then. It may be useful to guide endotherapy in bleeding lesions and to confirm the adequacy of treatment. Role of early cancer staging, which is often touted, is minimal in the era of enhanced endoscopy, in my opinion. EUS is very useful adjunct in resectable, potentially resectable cholangiocarcinomas and selective CA gallbladders arising from the neck. In unresectable tumors, it is not needed. EUS is a useful adjunct for biliary stricture evaluation when you are doing ERCP. EUS is also useful when you are done a cholangioscopy and you don't see the stone which you are looking for. And EUS is also useful to confirm the clearance of bile duct after, say, a mechanical lithotripsy or 2 or 3 sessions of basketing in the ducts to see whether the duct has been cleared. Thank you. Thank you, sir.
Thank you, Vikram. Actually, we are way behind schedule now, and Malay has a flight to catch. So I think we can't have the questions. Unfortunately, we'll share our questions with Vikram later on, maybe informally during the dinner session.
Okay.
And I think now the last talk of this session is by Dr. Saurabh Gupta, and after that, I think I request Saurabh to stick to time so that Malay can catch his flight. He's waiting very anxiously to come live here. Saurabh, so it's all yours.
Okay.
I promise to be very quick.
Some more water.
In fact, a lot of what I'll be talking about now was actually covered by Dr. Mehta very nicely, which is excellent because it makes my job a lot easier. So what are the factors we need to consider when choosing a needle? My topic is needle choice for different types of lesions for EUS-guided tissue or fluid acquisition. Well, I suppose the important things that we have to think about are both are multiple.
Section on.
We need to look at, obviously, availability. What needles do we have? We don't all have the same availability for needles. I've seen needles that I use that are not available here, and vice versa. In America, there'll be different needles. So it really depends what you have available to you. The access and the location of the lesion you're targeting is extremely important because needle flexibility plays a big part in that. Whether you're trying to get a 19 gauge needle through the scope in an angulated position from D2, D3, it's going to be very, very difficult. But you can easily get a 25 gauge needle through that same thing. And then the type of lesion as we spoke about. So pancreatic, whether it is solid mass of the pancreas, Dr. Mehta mentioned 25 gauge needle, and that's exactly what I use. Subepithelial lesions, you may not choose to do tissue acquisition with FNA because it's often poor yield, but if you do, there's certain techniques. And then whether there's histology required, what ancillary studies do we need to do? Do we need to do immunostains? Do we need to prove it's a GIST tumor? Are we looking at molecular markers for pancreas cancer? Are we doing genetic studies? We need to have all these questions in our mind before we choose the needle. Do we have rapid on-site evaluation or not? If we have rows, then really needle choice is moot because you can use whatever needle you want and the cytotech or the cytopathologist will tell you when you've got enough tissue or when you don't have enough tissue. So often needle choice will be dependent on, will be most important to those practitioners who don't have on-site evaluation. And then the cost of the needle plays a part, especially cognizant of the factors in India. So FNA needles, we have various choices of FNA needles. We've got the Expect needle from Boston Scientific, we've got the EcoTip needles from Cook, and we've got the Easy Shot needles from Olympus. I'm not sure whether more needles are available here, but there are more needles out there on the market in the States, which we don't have access to. And then the newer needles, the FNB needles, or the fine needle biopsy needles, also called the core needles. Again, there's a plethora of these needles to choose from. So we've got the first ones who came up with this were Cook Medical, and they've come up with a ProCore design, which has got a reverse bevel, or a reverse cutting bevel, that you can see on the tip of the needle. It's about 2.6 millimeters away from the tip, so it's very, very close to the tip of the needle. And now the newer one they've got is a forward bevel, forward cutting bevel, which is the ProCore 20. And that's, from my practice, become the default needle when I want histology. The other side hole needles that are available are from Olympus. We've got the Shark Core needle from Covidian, and more recently, which hopefully Sham will show you some cases, there's the Acquire needle from Boston Scientific, which is a modification or really a translation of the Francine design percutaneous needle that the radiologists use in EUS. So needle size, does it really matter? Well, this is just a meta-analysis that looked at a bunch of studies after 2013, but all of these employed rapid on-site evaluation. And if you look at the first study, there was 188 patients. They looked at 22 versus 25 gauge, similar diagnostic yield. If you look at a paired study of 56 patients in the pancreas, which is the middle, again, 22 versus a 25, similar diagnostic yield. If you look at a randomized controlled trial of 135 patients published in Scandinavian Journal in 2013, 22 versus 25, again, similar diagnostic yield. All of them will have some slight variation on this is better from in our hands, this is better in our hands. So really, I don't think the needle size for these particular things is relevant. No differences in summary in the accuracy, the number of passes or complications between a 22 and a 25 gauge FNA needle, but possibly the tissue acquisition and adequacy is marginally higher with a 25 gauge needle for pancreatic lesions. So hence my technique is 25 gauge in the pancreas. Notice that no one compares 19 gauge needles because where is the majority of our fine needle aspiration taken from? It's from the head of the pancreas. So we're not going to routinely choose a 19 gauge needle to target something through the duodenum purely for flexibility. Then the location of the lesion is really important. If you've got a straight scope, you're targeting lymph nodes in the mediastinum, you can use whatever needle you want. You've got no problems using a 25, you've got no problems using a 22, you've got no problems using a 19. So really it depends on other factors when you're looking at that location. If you're looking at in the pancreas from a transgastric approach, again, you potentially can use all caliber needles. Doesn't really make a difference. True cut needles, we don't have availability anymore. I think they're sort of being taken off the market because of the complication rates. But in the past, people tried true cut from the duodenum and it was impossible and the complication rates were too high. So if you're doing a transduodenal access, especially around the uncinate, you would prefer to use a 25 gauge needle. Then the flexibility comes into play, and this is a needle that's been around for a few years, the 19 gauge flex needle, which is made of nitinol from Boston Scientific. Again, because of the fact that it's made of nitinol, not stainless steel, like a lot of the other needles are, you've got expense related to that. It's a much more expensive needle. It's very good, and it may be a great needle to use in cystic lesions in the uncinate where you want to drain the lesions completely, especially mucinous needle lesions. But again, if you look, compared to a 25 gauge needle and the 19 flex, we've got no differences in the number of passes, the diagnostic yield, and the technical failure. But potentially, you're more likely to get a core with the 19 gauge needle, which is not surprising, but also you're going to get a bloodier sample with a 19 gauge needle, again, not surprising. Stylet, I won't go into this. There's lots of trials, and none of them have shown any difference in using the stylet or not using the stylet. So really at this stage there's insufficient evidence for use to advise use for or against. So really it's up to you, whatever you'd like to do, stylet or no stylet. The only difference, the important thing is if you're using the Procore needle, then you must use a stylet for the pass, because in the product information it says because of the bevel that's cut on the side, if you're passing the needle into a hard lesion, there's a technical, theoretical risk of breaking the tip off within the lesion if you don't use a stylet. But I don't think there's ever been a case of that happening. Suction, again, I won't go into suction, but suffice to say, you recommend using suction, whether it's half suction, full suction, capillary suction with the slow stylet withdrawal. We would recommend that for all solid lesions. And I preferably do use the capillary suction technique for solid lesions. For cystic lesions, I use full suction. And for lymph nodes, I tend not to use suction because you can cause increased bloodiness of the specimen for lymph nodes. Number of passes, again, only really relevant if you don't have on-site evaluation. If you've got on-site evaluation with one pass, they'll tell you have enough tissue. You do another pass for cell block, you might be done with 1 or 2 passes. With the Procore needle, if you don't have on-site evaluation, then perhaps 2 passes is enough. And there's been multiple studies showing you can get yields of over 90–95% with 2 passes with the Procore needle. For subepithelial lesions, and I think I've got this the wrong way around, unfortunately, FNB should be here and FNA should be here. If you look at the randomized trials published after 2013 for subepithelial lesions, you can see that FNA, which is actually the numbers on the right-hand side of the screen, show very, very poor yield for tissue, for diagnostic yield. And if you look at fine needle biopsy, you've got a significantly higher yield. So really, you would recommend using a fine needle biopsy, and these are all studies using the Ecotip Procore needle for subepithelial lesions if tissue acquisition via EUS is being undertaken. Safety, and this is a abstract from Sham looking at the complications in a meta-analysis of 19 gauge versus 22 and 25 gauge lesions. And he said that smaller needles are probably safer, and you can see from the numbers here, the numbers are small, but it hasn't reached a statistically significant p-value, but the trend is towards safety is with smaller needles rather than bigger needles. So just a couple more slides. I'll try to finish this off quickly. So FNA with rows, really the needle choice is not important. You can do whatever you are comfortable doing. You've got your cytopathologist on site who's telling you whether or not you have adequate tissue. Obviously, the indication is important still, because whether you want a histology sample or you just want cytology. And most of the on-site cytopathologists don't like blood on the smears. They like cells without blood. So you would tend to use a smaller needle to minimize the blood and maximize the cellularity for on-site evaluation. Similarly, if you don't have rows, we want as much tissue as possible because we're doing the passes and we're sending it to the lab and we're waiting for a result. So we want tissue. So do we really care if there's a lot of blood mixed with that tissue? No. We're happy to have blood, but to maximize the tissue, we may use an FNB needle rather than an FNA needle routinely, and if technically possible, a large gauge needle as well. So what I do for solid lesions, I use a 25 gauge Procore, and I know that's not routinely recommended for all cases. I've had pancreatic biopsies in over 400 consecutive cases using the Procore 25, and we've got yields of 98%. So with 1 to 3 passes, as an average, it was 2.5 passes, a maximum yield using a slow stylet withdrawal, and rows if it's all possible. If I'm using histology, then I do a technique called the direct histology method, which is generally with a 20 gauge Procore needle, but sometimes if it's not accessible, a 22 gauge Procore, 2 passes with full suction, 10 mils, and the specimen is rinsed directly into formalin solution and sent to the lab. So what do? We get this little worm core, which you can see if you put it onto a petri dish, and that's into a fixative solution, which is then prepared by the pathologist into a cassette. It's paraffin embedded, cut like a histopathology specimen. And so the slides are cut, and then basically the 1st, 5th, and 9th are looked at, and the rest are kept as charge slides if further stains need to be done or further things need to be done. And just finishing off here, quick histology. This is what you histopathologists can show you with a 22 gauge Procore and a 25 gauge Procore. Yes, you've got blood, you can see blood, but you've got so much tissue mixed in with the blood that you can get actual architecture of the lesion, and it doesn't matter how much blood is there, it's prepared like a histology specimen, so they can focus on the areas of interest. For a cystic lesion, 22 gauge needles I showed in the demonstration this morning using full suction, and if it's an uncinate lesion, may use a 19 flex needle. Just a quick interesting one, just to show a new, oh, hang on, what happened there? If we can get that up. Just as a very interesting case, which demonstrates another technique of getting tissue. Oh well, maybe we can't show that and we're out of time, so...
Can tell that, no?
So that was a cystic lesion that was an incidental finding. It was a 7 centimeter cystic lesion in an asymptomatic individual who had a minor motor vehicle accident and had a scan for that. It actually showed some very interesting, I don't know if you can get it up while we're talking, showed some very interesting mixed, predominantly cystic fluid-filled area with mobile rounded structures within it. And then there was a more heterogeneous but uniform area as well. We did an initial FNA, got fluid out, it was inflammatory, mixed lymphocytes, neutrophils, other things, wasn't diagnostic. And so then we went and did a biopsy of the cyst wall using the Moray microbiopsy forceps, which I'm not sure if available in India yet. So we did a puncture using the 19 gauge needle and passed the biopsy forceps through the needle and actually biopsied the cyst wall. And with that, we got some really nice, I'll just show the actual histology that we can get from those microscope. So there's a representative picture anyway of the cyst. We've got this more fluid-filled component. There's all these round circular, which were mobile within the collection, and then you've got a more heterogeneous large lesion there. We did an FNA, and actually this is the 19 gauge, and then passed the intraductal, the intraneedle biopsy forceps and biopsied the cyst wall. This is the forceps that's marketed by US Endoscopy. It's got a jaw diameter of 0.76 millimeters, and you can actually get really nice pieces of tissue here, and this turned out to be a mature teratoma or a dermoid cyst in this patient, and that can be left alone. So whereas the patient was heading for surgery for an undifferentiated cyst prior to that. So I'll just leave it at that. There's a quick algorithm, which if you've got time, this has been published in GIE by Komanduri, and what it shows is if you have a pancreatic mass versus a non-pancreatic mass, we go down the pancreatic pathway, cystic versus solid, cystic lesions, you often use a 19 or a 22 with suction, solid lesions, generally a 25 gauge needle with suction, and I use a slow capillary suction. If you have an on-site cytopathologist not available, 5 to 7 passes, and you should have adequate cellularity in specimen. If you do have a cytopathologist available and you need more stains or other tests done, then a fine needle biopsy would be the way to go. For non-pancreatic masses, if you need histology, then again, a fine needle biopsy. If you don't need immunohistochemistry, then you can use whichever needle you want, except don't use suction for lymph nodes because it increases the bloodiness of the specimen. I'd like to say that if you don't have on-site cytopathology available, really you should be considering using an FNB technique for non-pancreatic masses as well, for like the subepithelial lesions. And we'll just leave it there.
Thank you, Saurabh. Excellent talk. Actually, we are running behind schedule, and Dr. Malay has a flight to catch, so he's almost getting T-wave inversion now. So I think we might have to move to the live demonstrations.
So
thank you very much. I thank all the speakers and my co-chairpersons and for the audience for being such good listeners. Thank you.
Thank you, chairpersons. Now we go live, and I invite next set of chairperson, Dr. B.S. Ravindra, Umesh Mehta, Arvind Namdev, and Uday Patil. Please take the chair.
Hello.
Yes.
Yeah. Good afternoon, all, and welcome back to the live session here for the afternoon session. And we are starting with Dr. Malay Sharma's demonstration, and Shivag will brief you with the history of the patient.
We have 38-year-old lady with history of abdominal pain and intermittent melanoma for past 3 months. On evaluation, she was found to have a pancreatic mass with multiple liver metastasis, and she has got a splenic vein thrombosis with the collaterals in perisplenic and peripancreatic region and perigastric region. On endoscopy, we found the fundal varices. We are here to demonstrate EUS-guided coiling of fundal varices.
So these veins that we are seeing on endoscopy, am I on?
Yeah, Dr. Malay, you are on.
Yeah. So these veins we were, but first I would like to demonstrate what we are seeing, because I am in the stomach now. This is the liver I have rotated. These are the swell.
Endoscopy
image. This is the spleen. This is the ribs that we see through the liver. This is the pleura that we see through the liver. And this is the fundus of the stomach. And this is the stomach lumen. So I will unfreeze this now. And this is what we are going to see, because you will see that these are the structures. You see these are the swell in the liver. This is the wall. This is the pleura. And these are the ribs, which you can see rib 1 and rib 2. And these are the muscles, intercostal muscle in between the ribs, that you can see intercostal muscle. Okay, having demonstrated this, I will just start rotating, and I will show to you that in this case the spleen is coming close, and this is the spleen, and this is the fluid. This is the place where the tip of the left lobe of liver is touching the spleen, and this is the liver, this is the spleen, and this is the fluid in the space. And this is this ligament outside the spleen. I will rotate it further, and just rotate it, keep on rotating it further, and this is where when I find that there are some small vessels in the area between the wall of the stomach that is close to the spleen. I will rotate it further now and keep on rotating it further, and I will see if I can demonstrate more structures. So I have rotated it now to the aorta, and once I am rotated to the aorta, I am finding that this is the crux of diaphragm, and these are the varix, and this is the wall. So can we increase the distance, zoom? So this is what we said, aorta, crux of diaphragm, these are the varix, and these varix we will apply color, and we will locate that these varixes are present in the gastrophrenic ligament, that is that between stomach, and this is the diaphragm, crux of diaphragm. This is called gastrophrenic ligament. So these are the varices in the gastrophrenic ligament. So I have now rotated it, and I have shown that there are varices in the gastrophrenic ligament. But now we have to try and understand what is the relationship of these varices with the wall of the stomach, and whether these varices are causing any portal hypertension, and whether they are significant enough to undergo EUS guided coiling,
or EUS guided glue injection. Decrease the depth. So I have again changed the depth. We are now again seeing this is the lumen of the stomach, and these are the varix we are seeing. Now I am seeing this is coming close to the liver once more, and these are the varix that I am seeing again in the area between the stomach and the left lobe of the liver. This is the area of gastrohepatic ligament where I am seeing this varix, and we will again apply color Doppler to show what type of pattern. So these varices are there, but when I see these varices, I am also finding that these varices are coming close to this wall. So what we have to now do, so again I would like to emphasize, this is the stomach, this is the liver, this is the gastrohepatic ligament, this is the wall of the stomach, and by this curvature you should understand that this curvature is of the fundus of the stomach. Can we increase the depth once more? So now we increase the depth. Now we will have to try and understand what is the relationship of these varices, and as I rotate you will find that these varices are coiling and curving. So this is, generally people think that it is a bunch of varix. Generally it is not a bunch. We will apply color Doppler once more and find out that what we are seeing here, it actually one varix which is in continuation, and this is actually one which is going on like this. One varix going like this, like this, like this, like this, like this. And at one place, this varix will decide to come between the wall of the stomach and the muscularis mucosa of the stomach wall. So I have got 2 minutes more. So in 2 minutes I have to just show you that this varix at this particular place, this is the place, they are going through the muscular layer of the wall of the stomach, and this is the place where they are called perforator, and we will measure the diameter of this perforator, and if this diameter is less than about 3 millimeter, I will think 4 millimeter, we will leave it alone. So this is the place. So enter. So this is 4 millimeter, and not only that, so this varix does not have a large enough diameter, and the submucosal presence of this varix is not big, because you can see only one column, this is the one column, only one column coming here. So whatever it may appear endoscopically, I do not believe that this varix in this particular case, which is present entering only in the Wasbach require any glue injection. So my diagnosis, what I have shown is that this is a case of carcinoma, fundal varices are present, they are present in the gastrophrenic ligament, they are present in the gastrohepatic ligament, from the ligament they are coming to the wall, this is the place where they are coming into the wall of the stomach, they are going into the wall of the stomach, they are running in the wall of the stomach, but they are not creating any more trouble, so I will leave it alone. So thank you very much. Sorry for because I have a flight to catch. Dr. Amol, the job is done, I believe.
Thank you so much.
Okay, thank you.
Thank you, Dr. Malay. Dr. Rajesh, you are not audible.
Hello? Yeah. Are we audible?
Yeah,
Sir.
you are audible now.
Yeah. I think that I heard Dr. Thorat's voice, and I think, I don't know who all is there. Anyway, Tarun will present this case.
So here is a 32 years old male who has no addictions and has some 6 months history of dyspeptics and reflux symptoms. Upper GI scopy was done for the same symptoms, and we found incidental periampullary mass. Side wing scopy also and forward wing scopy also shows a periampullary mass, as we can see on the screen. And we are doing a EUS for assessment of the lesion as to which layer and what is the probable type of lesion, and maybe contrast enhancement to see if it is a possible NIT.
So I'm going to concentrate in this case. Mole has told me to show the contrast EUS. So as I discussed in my talk, you don't require the contrast EUS and elastography in all the cases where the diagnosis is in doubt. So here the purpose of demonstration is to demonstrate how the contrast EUS can be done. And if you look at the side wing, you can see a large mass with the inflamed mucosa. I think Amol has done the FNA 2 days before, and which shows the neuroendocrine tumor. And then the purpose of demonstration is to show how the lesion look like in contrast EUS. Can we close the light? So my scope is in the second part of the duodenum, and can we close the light?
Rajesh, can we put some water so that the lesion
Yes, we'll put the water. Somebody will give the water. So I think we can see a fairly large lesion at the ampulla with the duct. Put the water. So the best way to examine the ampullary pathology is you give the buscopan to the patient, paralyze the duodenum, put around 200 to 300 ml of the water, deaerated water. Put the water. Can we give the buscopan to the patient? Can you see the lesion?
Yeah, nicely seen.
This is the large lesion, and what I can appreciate, can you see the margins are very smooth?
Yeah, it's quite homogeneous in appearance.
Yes.
Actually, it's not very heterogeneous. And
can you show the muscularis propria any involvement or anything?
Yes, to show the muscularis propria, can we put a little bit more water? We have a water jet. Put the water. Can we give the buscopan to the patient? Put the water like this only, please. Put the water. Put a little bit more water. Can you put a little bit more
so
water?
it's important to notice
Now, can
what
you see the
Rajesh is
muscularis
doing.
propria? Can you see
now
the?
we can see.
Can you appreciate?
Now we
The important point which Dr. Ravindra, you was asking about the muscularis propria, that will come when you are planning to do the endoscopic ampulectomy. In this case, as this is a young man and we have diagnosed as a case of carcinoid, so in this situation the ideal treatment is surgical resection. So to knowing about the muscularis propria is not going to change the decision making in this. But you can see the muscularis propria. Can you see now?
Yeah, now we can see.
Can you see the muscularis propria?
Yeah.
Yeah, wonderfully seen over there.
You feel it is more of a duodenal ampullary, this thing not involving pancreas?
Yes, you can see the pancreatic parenchyma is normal.
Yeah.
And is mainly involving the ampulla. Now to show the contrast EUS, once you have focused the lesion, you use the contrast mode, which is on the, can somebody focus here? So you, on the contrast mode, once you get the contrast mode, you are getting the dual panel image. This is the B mode image, and this is the image for the low mechanical index, which has a mechanical index of 0.15. This is very important. You keep the mechanical index between 0.1 to 0.6, because if the mechanical index is low, you are not able to get the non-linear scatter. So I will focus the image on the B mode. Can I increase the image enhancement of the B mode? Yes. Now I will tell my assistant to inject the contrast agent. So here, this is the, we have already reconstituted the contrast agent, that is Sonoview, and around 4.5 to 5 ml of the contrast agent will be injected. This is important. How should you inject? Can you show it? Yeah, from the end. I told you not from here. Yes.
Can you focus on the hand, because this is the part which is very important.
Can you focus the hand? Just first release it like this. Inject the contrast agent. Inject the contrast agent. Yes. Yeah, inject the full. Inject. Now lock it.
So you can see
Flush
that
with the
you
saline.
inject along with the saline, just one after the other.
Now this is very important. If you look at here,
Yeah, now we are already seeing.
this is the normal pancreatic parenchyma here. Can you appreciate?
Yes, yes.
This is the normal pancreatic parenchyma on the B mode image. This is the lesion, and can you see the hypervascular lesion in comparison to the pancreatic parenchyma?
Yes, yes.
Yes.
And can you see the
Very
musculus
classically
propria in between?
Yes.
So this is very important. You should compare with the normal pancreatic parenchyma. Focus both the normal pancreatic parenchyma as well as lesion. Here the normal pancreatic parenchyma is here. This is the normal pancreatic parenchyma. This is the lesion which is hypervascular, and that corresponds the most likelihood of this lesion to be neuroendocrine tumor. So in this case, already the FNA has shown about the neuroendocrine tumor, and this patient should go for Whipple surgery. Anything you want to ask? Because
No, I think one more thing to show is involvement of bile duct, because it becomes
and can we show the elastography? Can we show the elastography? Can you take the single mode, make it above? Can you make it bigger? Yeah, adjust. Can you adjust?
Rajesh, can you show us the Doppler, the superficial Doppler
Yes.
network?
Can you remove the elastography? This is the Doppler. Can you see the Doppler?
Even on Doppler, it is quite hypervascular. You can see quite a few vessels on that, the lesion.
And the Sonoview generally disappear in 60 seconds. If we would have seen earlier, then it shows more enhancement. The only problem with the Doppler contrast enhancement, you will get the blooming and the motion artifacts.
Even roughly, this is giving an information that it's highly vascular.
Yeah, so it is a vascular tumor, so which means that there's a neuroendocrine tumors basically are hypervascular.
No, can you make it the area of interest little bit smaller? Little bit smaller, this one. Can you make it a little bit smaller? Yes, 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 that's okay, perfectly fine. Can you freeze it? Freeze? Yes. Can you see is a homogeneous blue pattern?
Yes, yes.
Can you appreciate the homogeneous blue pattern?
Yeah, yeah.
And for the strain ratio, we press the strain ratio, we select the area of interest. No. Can you relieve the? Yes. Can you defreeze it? Remove it. Yes. Focus again. Freeze it. Do it in the back. Yes. Let it remain. Yes. Just use the strain ratio. This is the strain ratio. This. You select the area. No. It's not coming. Defreeze it. Defreeze. Yes. Select. Completely round circle. Make the bigger. That's sufficient. Yes. Tap the again set. Take the red one area, red above one, above, yes, yes, small area, yes, take. That's all. Yes, that's sufficient. Now press again, set. Yes. Can you see here the strain ratio is around 300?
Yeah.
So you notice here the strain ratio is 300?
Yes.
So this is in favor of a neuroendocrine tumor on the basis of contrast and the
elastography.
elastography.
So I think, thank you very much, Rajesh. And any questions? Because otherwise, I think Rajesh has to also take a flight, and Malay is also waiting for him. So I would like to thank both of them for sparing their time and coming here, because they've got other meetings to attend. So thank you so much.
Thank you, Amol. Thank you for giving the opportunity.
Thank you. Okay. So till then, probably we can take a few questions over there, and we'll just start the next patient till then. So any questions from the audience over there about advanced imaging? Hello? Hello?
Hello. Amol.
Yeah, Ravindra?
Yeah.
I thought we had lost you.
No, we are there.
Okay.
Hello.
So.
Hello.
Hello. There is a question, Amol, from the audience.
Like Dr. Malay's case, the endoscopy picture, if you saw this gastric varices, we hardly would have, without EUS, would have made a decision to put any glue.
No, the question is, the first case, Malay's case, on endoscopy, the varices were small. That's why they were thinking, will it really matter for coiling? That was the question.
Yes. Even on endoscopic image.
Amol, you can take care of the questions. We have a flight to catch. Thank you.
Surely. See, basically, the reason why Malay chose not to coil those varices was basically because they were not in the submucosa, they were not very big, they were quite small, and predominantly, most important thing is, if the vessels are not, the varices are not in the submucosa, they are unlikely to be the cause of the bleeding. Although this patient had melena, it could be anything else, just gastritis or gastropathy, whatever else. But definitely unlikely to be from the varices. So that was the reason.
No, my question is different. Endoscopic image, if you see,
Yeah.
you find there are single channels
Yes.
seen. So you could not have made any decision even without EUS to do any endotherapy on that.
Yeah, that is the reason we chose to do an EUS. That is the reason we chose to do an EUS, because on endoscopy, these varices didn't, although there were varices, they were not convincing enough to say that these are the cause of the bleeding. You understand? And that is the time when EUS came to the rescue, because on EUS we can definitely say that these varices are unlikely to be the cause of the bleeding.
But then patient had melena 3 times.
Yes.
What was the cause for that?
No, now we need to evaluate that further. This patient has just come to us 2 days ago. So we will definitely need to evaluate that in subsequently. She's got a large mass, a neuroendocrine tumor, that too proved on FNA with liver mets, as well as these varices. So we need to evaluate the cause of GI bleeding in this patient.
I think because that fundal varix coiling was not done, Amol,
Yeah.
can you tell us, how do you, in your center, how do you decide on the size of the coil?
Okay.
That is one. And second thing is, how much ml of glue you will inject?
Okay. See, the technique that we use is slightly different from what has been described and what Malay has also shown. One thing is, I am not very sure about using glue after coiling, because to my thought process is that glue still remains the mainstay of therapy for fundal varices. It's only these patients who are refractory to glue and who have recurrent bleeding after glue injection whom we take up for coiling. In these patients, probably additional glue is, we are probably adding burden to these patients. So your first question was that how do you measure the size of the coil? See, the size of the coil should be slightly, maybe 1 or 2 millimeters wider than the diameter, the maximum diameter of the varix. Because otherwise, even these coils can migrate, they can cause embolism. In fact, we just reported recently a coil which embolized, fortunately without consequences. But yes, this can happen. So you need to measure the widest diameter of the varix and choose the coil accordingly. The second thing that you do to prevent embolization is, what we do is, we call it the anchoring technique. So when the last few millimeters of the coil are in the needle, at the tip of the needle, we gradually pull the needle back as the assistant is pushing the coil out from the stylet. With the stylet.
You pull back the scope, or?
No, we pull back the needle
as
the assistant is advancing the stylet with the coil inside. What happens is, the end of the coil, the distal end of the coil will get anchored to the wall of the varix or to the wall of the bowel in the muscle layer typically, because you are going from outside in, and that will help the coil to remain in the varix much more easily rather than that embolizing. So that is one thing that you can do. And typically, if you put 1 or 2 coils and if you wait for adequate amount of time, say about 5 to 7 minutes, you will on Doppler see that the flow has reduced and sometimes has also disappeared. So I normally would not inject glue right at that time, because majority of our patients have already received glue and they've bled despite of glue. So in that situation, sometimes adding glue adding glue to that varix doesn't really make much sense. Probably in a fresh case, possibly yes, you can put a coil and then add glue to the coil. That probably you should do.
Yeah, and second thing is transesophageal or transgastric, because there is this thing that transesophageal, if you puncture, the risk of bleed when we remove the scope, that's slightly less. What is your thought about that?
No, we typically will use the transesophageal approach. Very occasionally we've used the transgastric approach. Very occasionally. Very few. Probably I remember only 2 cases or 2 odd cases where we had to use the transgastric approach.
And then any things about the duodenal varix?
Duodenal varix, honestly, I don't have an experience of coiling in duodenal varices. Maybe we'll call up Malay and check, ask his experience on that, and maybe I'll give you an answer if I get him on phone. Otherwise, anybody else in the audience, if anybody has an experience, maybe they can share. Or Sandeep Sandeep is here. If Sandeep can come here, we can probably ask him if, I think, yes, Sandeep has reported a duodenal varix coiling or glue, one of the 2 things. So maybe we'll just check that out with them.
Any other questions from the audience?
With your exclusion criteria, how many % of fundic varices really need coil after glue?
I would say less than 10%. Less than 10%. Majority of them, as I said, are amenable to glue, but it's only those very large bunches of varices where you are sometimes concerned about the volume of glue. And in those situations, after 1 or 2 sessions, especially when the glue extrudes, that is a time, if the varix in the base of the varix, that vein is patent, then these patients can have torrential bleeding. Okay, I think we are ready in the next room, so we'll move there. I think Shyam is ready with a patient, a pseudocyst, and I think this patient also has something else. So let's go to room number 5.
Inflammatory, but it looks like malignant.
Shyam, you are audible.
All right.
Hello. Hello. We have Dr. Shyam here, and where he's going to demonstrate us about pseudocyst drainage. So Dr. Rahul is going to brief us the case.
Good afternoon all. He's a 75-year male patient presented with a non-productive cough. He has epigastric pain, nausea, and decreased appetite. We investigated that patient, and CT thorax and abdomen was done, which showed extensive retroperitoneal lymphadenopathy, and also there is a 9 into 6 and 8 centimeter cystic lesion in the lesser sac, very pseudopancreatic cyst. We did EUS of this patient 7 days back and take a FNA of this retropancreatic lymph node, which was suggestive of reactive lymphadenopathy. Now we did a EUS guided pancreatic pseudocyst procedure.
So, one of the, yeah.
Patient doesn't have a history of acute pancreatitis.
I mean, the question here is the patient does not have a history of pancreatitis. So, the thing is 1 in 70 patients with pancreatitis or pancreatic fluid collection will have a fluid collection secondary to a neoplasm. So, that is the number. So, now I'm in the second portion of the duodenum, and you can already see there are some huge lymph nodes. I just want to make sure that there is no cancer that is causing this collection. That's what you need to do. So there is a lymph node there. I'm going to pull back a little bit on the pancreas. Haven't seen anything in the pancreas. I'm just trying to rule out an underlying neoplasm. So here is the uncinate region of the pancreas. You can see the ducts coming out. I haven't seen a tumor. Usually if you want to see a tumor in a neoplasm, it's either proximal or distal to the fluid collection. So slowly pulling back, haven't seen anything there. There is the bile duct, come back a little bit more, and there is pancreas, and then you have to go back and forth. And what is that? See there? See this? Yeah, this. You have to start scratching your head and make sure that this is not a cancer that gave rise to a ductal obstruction, which in turn caused a pancreatic fluid collection. I don't see a well-defined mass, but there is some sort of a fullness here. See that? Yeah. This bothers me. See that?
Yes.
This very high chance that this is a cancer. See that? Yeah. So this is not a pancreatic pseudocyst. This is actually a pseudocyst caused by a pancreatic neoplasm. And that will explain, Sandeep was showing me these huge lymph nodes. Why do we have such big lymph nodes near the fluid collection? So if you turn around, see that there is nodes there, you come back here, and then you will find more nodes on either side. So this is a renal cyst, and then there is nothing else, and then you go back, you find this collection. The thing is, what do you want to do about it? Actually, we have done some cases with fluid collection in a pancreatic mass. You'll be very surprised. The surgeons told us, go ahead and drain it. They said in the presence of a fluid collection, we cannot go and operate on the mass and do a distal pancreatectomy or a Whipple. So what we will generally tend to do is to decompress the fluid collection, and after it is decompressed, we will do over surgery. That's what they told us. So what we did is, we went and drained them, and once the patient's fluid collection was drained, they had a scan, and afterwards they went and had a resection procedure. In this particular case, I think this is a neck collection. You can see it's clearly a clean collection. There's no solid material at all within it. But proximal to that mass, if you just look only at that fluid collection, it's not possible to diagnose that lesion. But when you do a pull-through maneuver, see that? There is pancreas, and then you come back, pull back, and then suddenly you see that fullness in the pancreatic head region, pancreatic neck region, and then you see the mass. So there are one of two options. Either we do nothing, and we can FNA the mass and wait for a tissue diagnosis, or probably do a combination of both. We can just drain the fluid collection and then get the FNA done now, or when the fluid collection has resolved, get a tissue diagnosis. What do you want? This
only aspirate the cyst right now?
Aspirate the cyst right now. It's too big a cyst. We'll be here for 3 years.
Put in a plastic stent and come out.
You want a plastic stent and come out? Okay.
Yeah, because we are not sure whether this is a...
Okay. How does placing a metallic stent change anything? Whether it is metal? It won't make much of a difference. Yeah.
Plastic stent, if it gets blocked, we're going to have trouble because it's a pretty large cyst.
Yeah. So if we drain it today, you will bring the patient back in maybe in a week or 10 days, get a CT scan and do a FNA. Okay, all right. Let's get a 19 gauge needle then. Because they are not going to operate on it no matter what. If there's such a huge fluid collection, they will not operate.
Any lymph nodes in the mediastinum, because CT showed some lymph nodes in the mediastinum as well.
Well, possible. There are some nodes in the mediastinum. I, to be honest, did not look for it when we came back. So this is a neck collection right there. So here is a collection. The thing is, it's exactly at 50 centimeters, just below the cardia. So we'll just go out and there is the needle. So the sheath is not adjusted. Pull back 2 centimeter, maybe a centimeter and a half. Okay. So can we get a fluoro shot to be sure that everything is in position? So you can see here I'm already into the collection. So let's aspirate some fluid.
What if it is a clear fluid?
Uh,
Chances are very high that it is a very clear, serous fluid. See?
Yeah, it's a clean fluid.
Yeah, so probably of cystic neoplasm rather than.
Yeah.
Because it's not
So
looking
do we
just
just aspirate and leave it and send for cytology and then just don't do anything to the cyst?
I don't. Is he symptomatic with this collection?
No.
He's having no
Absolutely
symptoms.
no symptoms.
Well, if the patient has got no symptoms from the fluid collection, then it probably.
Because his symptoms are all vague weight loss and anorexia and all.
So
this is not pseudocyst fluid. This is a.
All right.
cystic
This is not
neoplasm.
a straw colored fluid or anything. This is probably a clean cyst fluid.
So I think that we should not put a metal stent or any stent for that matter. Maybe drain some more fluid and take an FNA from that mass.
All right. Overwhelmingly defeated. This is a 19 gauge needle. Let's get this out. Apparently the patient is not symptomatic from the collection. Yeah, we'll just find the mass and probably we'll just sample it. You can. All right. So here is the lesion that I would sample right there. It's very ill-defined. I don't care. Any needle is good. Thank you. Let's get the needle. And do you have a 25 gauge needle?
Yeah, 25 gauge. Yeah,
25 is better. Yeah, because 25. Yeah. See, sometimes it's difficult to find this lesion. It's not easy. The only way you can find it is to do a pull through. And then you see the mass transiently and then it just disappears. So here is all pancreatitis changes. You pull, see that? That's where the mass is. So it's very hard to keep it in view. Right there.
Can someone hold the scope?
I think once we fix the needle, it should be pretty easy. Right there. So I'm using a 25 gauge needle just because it gives more flexibility. And this is neck mass. You see there's a vessel on top. If it's a 25, it's easier to sample these lesions. See, there is is a small needle, small mass. Sorry. See, there are vessels on top of that lesion. So we have to be turning back and forth. There. Can you hold it right there? It's a very ill-defined mass. I won't be surprised if there is a sampling error on this lesion. So, see that? I have now moved the needle. This is the reason I wanted a 25. See how tangential that mass, the needle is? I think it's clearly in the mass now. I'm going to move myself back right there. And then I'm going to go a little further in. Okay, style it out. Yeah, the thing is I'm just worried about, take it off. Yeah. I'm just worried about sampling error. Because it's not a well-defined lesion. See that? It's very, very ill-defined. Unless you have a pathologist in the room willing to look at the slide, you can have a sampling error. See that? You can't see it.
What is
And there
the
is a
black structure which is moving? Is it a vessel or just
What is that?
Yeah, duodenal wall.
I don't hear you.
No, the black structure, the linear structure, when you just puncturing, is it?
There's an ill-defined. See that? There is a very ill-defined lesion. You can't see. You can't appreciate it very well. That's what we are puncturing. It's an hypoechoic mass. There is no. I'll do the sampling and then I'll show you what I'm puncturing. All right. This is not going to be an easy puncture because there's a very high chance that you see that you have to perform at least 2 or 3 passes before we get a tissue diagnosis on this one. It's so ill-defined. Right there. See?
Yes, yes.
Now you see it a little better. This is a good examination of a case to say why we have to be careful about sampling. All that we see is not necessarily a pseudocyst.
Yeah.
Right? It can be related to something else.
Definitely.
And unfortunately, because of the size of the fluid collection, very often cross-sectional imaging will not identify the mass. It's such a small lesion that it is missed. But the clue is generally the mass is proximal or distal to the lesion. So here is the big cyst. You turn around a little bit, turn, and then it's either adjacent more proximally or more distally, causing a ductal obstruction, which in turn gives rise to a cyst neoplasm. That's what it is.
So even the history, I think, is very important.
Yeah, the lack of history of pancreatitis.
I think we should have used contrast here.
Contrast.
The question is from the audience. Contrast EUS in this case.
No, I'll be very honest with you. Contrast. I mean, people are. If you don't know what you're doing, you shouldn't say anything. I don't use contrast. The thing is, how will contrast change management? Say, for example, there is a high uptake or a low uptake. What difference would it make? Are you not going to operate on this patient because contrast is negative? No, you're going to do a resection. If contrast is positive, what does it tell us? Means nothing. I think the role of contrast will be, if contrast can tell you this is where you have to put your needle to get a tissue diagnosis, then it will make a lot of sense that it is very useful. On the other hand, it's just a nice decorative technology that appears very fanciful and colorful. And then beyond that, with that information, still tissue is the issue. Right there. Was there anything on the slide?
Yeah, why not to take a lymph node biopsy?
We have some material.
Yeah, Shyam.
Yes?
Why not to take a lymph node biopsy? Because
not in pancreatic cancer, in esophageal cancer, gastric cancer, all luminal cancers, your lymph nodes are always positive. On the other hand, with pancreatic cancer, our pathologists are not very good in giving us a positive diagnosis. We can, there were some lymph nodes that were positive. If you look under the microscope and all these samples are negative, sure, we can get a biopsy on a node and do some immunostaining and so forth. But preference is usually in pancreatic biliary cancer to go for the primary tumor and to the lymph node only if it is the primary FNA is negative. Because the yield is low in lymph nodes in pancreatic. This node, I agree with you. See, that looks very pathological,
Yes,
right?
yes. We can take a.
Yeah, we'll do a sample on this lymph node. I agree. This looks very, very pathologically abnormal. So we will sample this lymph node and send it to the lab as well. Sure, why not? Pankaj is asking, do you want to use the same needle or a different needle? We can use the same 19 that we opened. We don't have to waste. Yeah, just give me that same needle. We'll use the needle that we use for the cyst puncture. If this node is positive, then this node is right next to the liver. It's a hepatic lymph node. Then it becomes metastatic cancer actually, right? Then it becomes inoperable because this is way away from the tumor mass. So if this is positive, then it's a metastatic cancer. Then it means the patient is not an operable candidate. So this is a 19 gauge needle. The problem with the 19 gauge needle in lymph nodes is that it makes the specimen very bloody, but it should be easy there. There it is. So you don't use suction for lymph node sampling because it makes the specimen very, very bloody. So you go back and forth. And you can see constantly you just move the needle and you move your dial, you use your elevator to change the direction of your sampling. See that? You come up, you retract the scope a little bit. You shouldn't fall out like I did, but you have to go through different borders of the mass to get a good tissue. So, no, thank you, no suction. So see, this is the fanning technique. Going through, when you don't see the needle, just move your shoulder back and forth. That's it.
That is very important.
You always have to see the needle at all times.
Yeah.
So this is another pass. So we did a pass on the mass and then one on the lymph node. Okay, move on.
Yeah, thank you, Dr. Shyam.
No,
Yeah.
thank you.
maybe we'll come back with the cytopathology report.
That not, I don't care much about the cyst, but you have to have a diagnosis on this, right? On the mass, either the lymph node or both are negative, we need to get more tissue, right? Do you want to just sample the mass one more time? I think so, right? Let's get the 25 gauge needle again. Yeah, 25 needle again. Just worried that we will miss the diagnosis. Can TB cause pancreatitis? Unlikely, huh? TB can cause, huh? No, don't open. The same needle broken up, huh? Okay. Okay.
Shyam, one more question is, this patient had mediastinal nodes, intra-abdominal nodes. The lymph nodes also are a bit hypoechoic, hyperechoic. Tuberculosis is one question.
Are they transmitting here? No. Are you transmitting still from this room? Are you transmitting?
Yes.
Oh, yeah. What's going on? What's your question? I'm sorry. I thought we are not transmitting.
See, as per the history, mediastinum lymph nodes are there, lot of nodes, perihepatic, which are very unlikely in a CA pancreas.
Agree.
That's why whether it's a different etiology altogether for the lymph
Yeah,
nodes.
possible. I mean, I did not know. I was just asking Pankaj if pancreatitis, tuberculosis causes pancreatitis, and he tells me it does cause pancreatitis. And the thing is always to exclude a cancer, isn't it? That is the most important question is, we don't want to miss a malignancy. So I'm sure the lymph node sampling with a 19 gauge needle gave enough tissue. This mass is a little ill-defined. See that? This is all pancreas, and then you keep tracing, and the patient has got some ascites. Did you see that? There's a little bit of free fluid in the abdomen. See? A little bit of free fluid in the abdomen. This is nothing but ascites, and then you pull back, and then you've got these pancreatitis changes. You pull closely, and then you pull back, and then you turn, and then you see this fullness in this area. This is what I sampled a while back. See? You can say this is not a mass, but just lots of lobulation that mimics the appearance of a mass. Possible. But the important thing is to make sure there is no cancer. If it is not a cancer, then everything else becomes so much easier after that.
Dr. Shyam?
Yes?
Doing an elastography for this mass and lymph nodes will make any difference?
No, it won't make no difference. Tissue is the issue, right? What difference would it make? I don't think so. There. That's exactly the spot where I FNA'd before. So I just need to go back, at least do 2 or 3 passes. We already had a lymph node sampling. Yeah, take it off, please. Thank you. We already have a lymph node sampling. So if this comes out to be benign, then we just need to check the lymph nodes and make sure there is no TB and so on. But no matter what, I think it looks like the patient is asymptomatic with regards to the fluid collection.
Shyam?
Yes?
I think we need to shift to the other room.
Sure. Please go.
Okay. Yeah.
Hello? Yeah. So Sandeep is ready over here with a patient with a large mass in the pancreatic head and uncinate process, and he's already done an FNA, and Chantal has already confirmed that it is a adenocarcinoma, and the plan is that this patient has pain, so we're planning a celiac plexus neurolysis. Sandeep, maybe you can show them the mass. Till then, probably we'll.
I thank the chairpersons, and we now move on to.
Hi, good afternoon, everybody. At the outset, I would like to thank Amol and his entire team for a fantastic organization of this conference and the workshop. It's an amazing place.
We'll move on to the
Very busy, but very organized.
Thank you, Sandeep.
So what I have done is, in this patient, which has she has
would now like to invite
cancer
Dr.
head of pancreas
Rajesh
suspected on CT with pain abdomen.
Rajesh Gupta,
So I have
Dr.
passed
Sunil
my.
Jain, Dr. Nitin Pai, and Dr. Rohit Gupta to chair the session.
Okay, I'll wait till.
Yeah, I think they're changing the chairperson.
Okay.
Dr. Rajesh Gupta, Dr. Sunil Jain, Dr. Nitin Pai, and Dr. Rohit Gupta to kindly chair the session.
So that's the. If I can continue.
Yeah, please continue.
This is the abdominal aorta, and it's bifurcating into the iliac arteries. These are iliac vessels. So I am at D2, D3 junction. Little talk here will give me the IVC. So that's the IVC, and in between that is the spine. So these are the vertebral columns, intervertebral space here. So I have learned from Malay all these things, nitty-gritties. He showed the ribs, I thought at least let me show the spines at least. So as I pull back, looking at the medial wall of the duodenum, we see the pancreatic head projecting here, and this looks very heterogeneous.
Help him with the cursor.
That's okay, I can handle that. So as I am gradually pulling back, turning my scope from left to right, very minimal movement. This is a very heterogeneous mass. So this is entire mass. If I can have the margins of it, this is a node here. The mass is approximately here till maybe this angle, and if I can remove the endoscopic view, then you have the measurements. This is the approximate measurement of 20 by 27 millimeters, but as I torque more, I see it's a bigger mass.
Yeah, it's a bigger mass
This is
over
much
there.
bigger mass
Yeah.
in the inferior part of the head, going further back towards the uncinate process. I
Yes.
call it inferior part because this is inferior to the ampulla of Vater. Uncinate, actually technically speaking, is behind the SMA, and this, if I can point with the SMA, the uncinate would be somewhere here. So this is the head mass, papilla is somewhere here. This is infrapapillary head of the pancreatic mass.
Right.
And as I
Wonderfully
pull back,
demonstrated. Yeah.
I can see this is the PD, this is the normal pancreas, and this entire thing is the mass.
Yeah, now we can see the mass in its totality.
So we just did an FNA before I came on the screen to save time, and fortunately that FNA came as positive, I was told.
Sandeep, can you show us the superior mesenteric vessels?
Okay. The vessels will be here. This
Yeah,
part, if I can.
that is
hold-
that is
I'll
probably
just take
the
the
SMA or SMV probably.
In fact, there's hardly any flow there.
Yeah, so it seems
that
to
would
be
actually
involved.
give us a hint that these vessels may be involved. I
Yes.
can also see it from the top as I come back from the stomach side and
Right.
trace the SMA downwards. And now on the right side of the screen, you can see the vessels coming up. Although they're not, now it's enhancing.
Now this
so
is
that's the
enhancing.
top one is SMV,
Yeah, we can-
and
but
the
you can
bottom one is SMA.
Yeah, and you can see that the vessels are entering the mass, so it's
SMV,
practically SMV,
SMA.
encased. It's completely encased by the mass.
This is quite merging with the edge of the
Yes.
tumor.
Right. So this looks inoperable, and this patient has pain. So we're planning to do a celiac plexus neurolysis. I think Sandeep, would you agree with this?
Yes.
With that?
Now you see the
philosophy?
SMV is involved. I have just pulled back a little bit, and because the patient is breathing a little fast, on the arrow, this area looks to be involved. When SMV comes here, this area looks to be involved by the
That is
tumor.
right. Okay. So I think maybe we can go to the celiac trunk, and you can show the technique. Are they ready with the slides? No. Okay. They're still not ready with
So
the
I
slides.
have withdrawn the scope back in the stomach, almost at the G junction now, and I'll get the aorta in frame. There you can see the aorta with a nice looking vessel originating from it. Whether it's SMA or celiac is what we need to define. It looks more like SMA.
SMA, yes. Looks
Yeah,
like,
okay,
yeah, that is the celiac. That's the
only.
celiac because you can see the
so
SMA
celiac,
underneath.
So celiac is coming end on, whereas SMA is coming little to the right.
So quite a big artery in this case.
I'm sorry?
Quite a big celiac
Yeah,
artery.
quite a big and a straight celiac artery.
Yeah.
So what also I'm trying to do is look for any celiac ganglion. Sometimes you can see those small black hypoechoic structures. There are a few peeping here.
Yeah.
Or these could be reticulate network of this celiac plexus.
So what is your policy, Sandeep?
If I
Inject
see-
in the ganglion or inject
Yeah.
in the
So
region?
if I see the ganglion, I always inject in the ganglion, but if I don't, then I inject in that entire area.
Okay. And what kind of a technique do you use? The bilateral technique or the central technique to inject?
I use the central technique. and
Okay.
I use something called a sandwich technique.
Okay.
You don't eat the sandwich. So I am taking a 22 gauge regular FNA needle, which has to be primed with saline. Keep the syringe at the end, and I have to give long-acting anesthetic agent, Sensoricane, and along with that alcohol. So first I will give 5 cc of the long-acting anesthetic agent, followed by 10 cc of alcohol, and again in the end put Sensoricane. The purpose is that once you inject alcohol and come out of the gastric wall, if there is any spillage of the alcohol in the gastric wall, there is always a pain. And also technically it can lead to some kind of a necrosis there. So give the alcohol only where it's needed and not at other places.
Yeah, that's very good.
Sometimes patient also can wince with pain even when they're sedated.
Sandeep, Pankaj is asking whether you should give 10 cc or 20 cc, because there are some recommendations about 20
yeah,
ml.
People have to give 20 and 30
20
also,
ml.
but I am little conservative.
Yeah. Yeah, because occasionally these patients can have.
I think as you gray your hairs, I think conservatism comes in your practice and you lose adventurism.
I agree.
So all these gray hairs is because of this, not because of radiation from EUS. Otherwise, I am quite handsome and young.
Of course. Okay.
No, this helps in the practice too.
Yeah. Patients treat you with more respect. Gray hair.
Only the young girls call you uncle at times. That's disappointing. So what I am trying to do is look for and just magnify a little bit more. And this, you see the left gastric artery is also coming from that area. And that's a little cause of concern at the moment.
Yeah.
So this is the left gastric artery, which is a small twig. This is a small twig which it comes there. And okay. So I have crossed the stomach wall. I am in one of the network of the ganglia which is originating from the celiac artery base. Just aspirate first.
Aspirate. Yeah. Now this is a very important step.
Okay.
Your assistant aspirates the needle on the needle is already.
It's primed with saline. So I have whole the needle has now saline in it. The next is now Sensoricane. Bupivacaine. The same thing.
5 ml of bupivacaine.
I can give it myself, but I would request him to hold it here.
Sandeep, are you using a 19 gauge needle?
I am using a 22 gauge needle. Another important thing I would like the audience to see at the handle of over here is to cover your the hub of the needle, because sometimes there can be accidental spillage of alcohol, and people who are not wearing spectacles can have the damage to the cornea. So now you can inject a little bit.
So another advantage of aging.
Yes, stop.
Spectacles are important, and they provide safety.
Little bit more, 1 cc.
Yeah.
Okay. Now you can remove it, please.
Now you can see how Sandeep is holding the needle in place, and
so I injected about 2 cc of the long-acting anesthetic agent, and now I am starting alcohol. So पकड़ के रखना. चश्मा पहना ना, हाँ, स्मार्ट लग रहा है. Yes, please inject. So the moment alcohol comes, it becomes white out there. So then my vision would actually go down.
Yeah.
Inject, inject.
Injecting.
Inject. Is it going easily? जा रहा है? कितना गया? डालो डालो. 3 cc gone. Okay, please inject. Is it alcohol only? We should start getting that. The snowstorm appearance is not coming.
Still very clear.
Otherwise, vision just gets hampered. Okay, okay. I'll just change my direction then.
Sandeep, once you inject alcohol, do you expect any hemodynamic changes in the patient?
Yes, so the patient, that's a good question. I think the patient has to be on saline infusion prior to the procedure and intra-procedure too, and this should be carried on after the procedure as well, because there is a risk of postural hypotension. Please inject. I've just changed little direction. Now it's becoming white at this part. This is okay. Inject, inject, keep injecting. Keep injecting. पूरा डाल दो. हो गया? 10 cc. Easy जा रहा है? No resistance. Good. Okay. Then again the next part, next butter, next bread. So the one bread gone, the butter has gone in, and now other butter.
And now a little bit of hyperechogenicity you can see.
This is sensory chem.
But sometimes I've seen this, Sandeep, that sometimes you get a very nice snowstorm, but sometimes you don't, and that's the time when you.
So does alcohol have an expiry life?
Unless someone in your department is diluting it over a period of time.
I thought alcohol improves with age. This is one thing which is have an expiry shelf life.
But this even we've seen at times. Sometimes you don't get that kind of a classic appearance. Sometimes, most of the times you do get.
Inject, please inject. डाल दे पूरा 10 cc डाल दो.
So my co-chairman Sunil is not commenting about absolute alcohol.
Sunil?
Yeah, Amol.
Okay.
Yeah. I think it's been diluted. That's why there's no snowstorm actually.
I'm a little surprised, yes, because I didn't see any snowstorm.
Yeah, sometimes you don't get a snowstorm. That is what happens. So, but excellent demonstration, Sandeep. I think
nothing happened there.
Nothing.
So I am actually doubting this alcohol because of two reasons. One, I didn't see a snowstorm, and second, the patient did not wince. Anesthetized patient will also wake up and kind of jump and have a groaning sound, which means that your job is quite well done. But here nothing happened. So either he is quite deeply sedated or the alcohol has expired.
I give extra shot of propofol to the patient.
Okay. Yeah, Sujit gave an extra shot of propofol.
Because of the workshop, I think. Or he didn't have. Yes, please.
In such a patient where you have a big mass, vascular invasion, and if you want to save on the cost, you can do the block first and do the FNA with the same needle. Is that possible?
It's possible. It's possible. I think we can do that, save the cost. And alcohol will actually sterilize the lumen of the needle as well. That's why risk of infection is much lesser after celiac plexus neurolysis if you use alcohol, because alcohol per se sterilizes everything.
Sterilizes everything. That's true. The only thing that can happen is sometimes you can have necrotizing retroperitoneal fasciitis kind of a thing.
So those things happen. There's one case report of somebody in Europe was doing 13 times celiac plexus neurolysis in a alcoholic chronic pancreatitis, and he burst the aorta.
Oh my God.
That's crazy.
That's crazy. But 13 times, I don't think I would do a CPN 13 times in one patient.
Time, I think
it will be very difficult. Anyway, thank you. I think AJ is ready in the other room with the case.
Okay.
Thank you very much, Sandeep.
Thank you.
Yes. Are we audible? Are we audible from room number 3?
What is next case?
Are we audible from room number 3?
Yes. We can hear you. Yeah.
Okay. I'll summarize the case. She is a 27-year-old female who has been symptomatic for since last 1.5 years. She has epigastric abdominal pain and on imaging never had any definite history of acute pancreatitis. And on imaging there was a cystic collection that we aspirated, that was not suggestive of any pseudopancreatic cyst. Cytology was negative and CA and amylase was normal. We have been following this patient since regularly, and the cyst has now slightly reduced in size from 5.5 centimeter to 4.4 centimeter. Now we'll doing EUS for further characterization of the cyst and what could be the probable nature of the cyst. Over to Dr. AJ, please.
Hello, good afternoon. a few minutes before I had a look at the lesion in the pancreas. So what I'm going to do is I'm going to start the demonstration from the stomach, where I can see the body of the pancreas, and the first thing to look for is the size of the pancreatic duct. So if you have a head lesion, and generally if the size of the pancreatic duct is normal, then that is typical of what you find when you think of cystic neoplasms. That's typical of what you find in serous cystic neoplasm. Because the other, even if the duct actually runs very close, or sometimes even it looks like it's running through the cyst, the duct never gets dilated in a serous cystic neoplasm. She doesn't have a history of pancreatitis, but with a cyst in the head, we need to look for changes of chronic pancreatitis here. So here the pancreas looks lovely, beautiful, no, not like the normal Indian pancreas that Lawrence described in the morning. No, it really looks nice. So that's going towards the tail of the pancreas, and now I'm moving back towards the head of the pancreas. You can see the pancreatic duct kind of falling away from the probe, away from the transducer, just when we cross the portal vein, the superior mesenteric vein and the splenic vein confluence, where it forms the portal vein. I'm going to just decrease the depth of imaging, or actually decrease the magnification, so that we can see deeper structures. Okay, so what we are seeing here is in the head, and actually posterior, deeper than the superior mesenteric vein, is this quite a large cystic lesion. What's a couple of things obvious from here? It's a single lesion, it's not a polycystic lesion. 2, the wall is not really well defined. It's got an irregular, fuzzy kind of wall. And 3, it's got a significant amount of solid component. So this, I know this cyst has already been aspirated and the amylase and lipase levels were normal. So straight away that kind of rules out pseudocyst. But actually, if I just saw the picture like this, I might think of pseudocyst as the first differential here. History-wise, there's no evidence of any previous episode of pancreatitis. Quite an interesting lesion. So what is it? Let's try and go deeper so that we get images from the duodenum. So I'm just past the pylorus into D1. So here you are seeing the same lesion again. Almost I would say about 70% of it is liquid and about 30% of it is solid. We were actually having a discussion here on what were the possible etiology of such a lesion. So the 2 differentials that we considered were, 1, a neuroendocrine tumor, a non-functioning neuroendocrine tumor with cystic degeneration, and 2, in a young lady with asymptomatic large lesion, was a pseudopapillary pancreatic epithelial neoplasm, or a SPEN. A SPEN, usually you don't see so much of a liquid component in SPEN, even though it is described in the subheading of cystic neoplasms in the pancreas. So we've already aspirated the cyst earlier. This time what we're going to do is we'll concentrate on getting some solid material from the wall of the cyst. So I'm going to do the FNA from here. Before that, we'll just quickly have a look in D2 in the short scope position, pull back, and I'm not really able to identify the pancreatic duct here. See if we can see the ducts in the short loop position. Do you have any questions or suggestions as to what this lesion could be?
So would you take FNA or would you take FNB?
I would take an FNA. I think the lesion will be quite cellular. I don't think it's. We're going.
We were talking about contrast, but we don't have that available. That would be a nice case. Would it help differentiate
I don't really have enough experience. Would you like to comment on it? Tarun, do we have another mic?
We were talking about the option of using.
Is it on?
Contrast. We were talking about the option of contrast and whether
You're
that
not
would
audible.
help you
Not audible.
decide
You're
on
not
the
audible.
etiology, or
No, just hang on. I don't think they can hear you yet. Okay, this is the same lesion. While I'm withdrawing the scope is straightened out in D2.
Hello.
Hello. You can see on just
Hello.
to the top
Hello.
left, northwest of the screen, you can see the ducts and the relationship of the cyst to the papilla. So even though it's very close to the ducts, it's not really, the ducts are winding around the cyst but not really producing a significant compression. There's no upstream dilatation. Saurabh, you want to?
we just raised the possibility of using contrast to help us, well, A, evaluate the lesion. Will it help us with the diagnosis? We're not so sure, but if the contrast shows a typical pattern of bright early arterial enhancement within the solid component of the tissue, then you might be more certain it's a neuroendocrine lesion. I don't know if anyone's looked at pseudopapillary, solid pseudopapillary lesions with contrast and what they would show. Professor? No. That's right. So you just get the papillary structures on the biopsy, but you don't see a lot of vessels. But will it change what we do? If you ask the question of will it stop us doing an FNA of the solid component, I don't think it would change the need for an FNA. So I think we still would need to do FNA. So then you might argue, why do the contrast in the first place? And I think that's reasonable to go straight for FNA.
Okay, so I'm going to go ahead and put a needle in, 22 gauge needle into the solid component of the cyst.
So will you be traversing through the pancreas?
Yes.
So there would be a theoretical chance of pancreatitis.
Not, this is only an FNA-C, if it's not an FNA-B.
What rate of pancreatitis do you quote your patients when they're getting FNA-C for the risks of the procedure?
I think it's really negligible. I mean, I don't discuss pancreatitis when I do an FNA-C.
Yeah.
I discuss things like bleeding and pain.
So I think some studies might show about 1 in 800 risk of pancreatitis, but that may be just some mild abdominal pain and elevated amylase and lipase post-procedure, but clinically significant pancreatitis rates are much lower than that as well. Would anyone in the audience not do an FNA? And if so, would some suggest surgical management up front?
I think I might have to go back to D1 and do it from there. This is the short scope position, okay. Take out the stylet. Yeah, it was quite close to the vessel. That's why I decided not to make too many passes out there. I'll go back and do it from D1. I think a long loop position is.
And so the importance for going for the solid component as opposed to the cystic component is if you drain the cystic component up front, then because this lesion is predominantly isoechoic, it's not well defined, as the cyst wall collapses, it may become difficult to appreciate where the solid components of the wall are. So it's really important, if you're going to FNA a mural nodule, then you go for the nodule first before, you may choose to aspirate some fluid as well, but we should always go for the mural nodule first.
Ma'am, she's moving a bit. Ma'am, she's moving a bit. Yeah, I think I've gone through a little bit of probably one of the okay. Okay, this is a more stable position. Okay, the Doppler window now is in the path of the needle. There is one tiny vessel there, which I'll try and avoid. Okay, can you just hold the scope here? Okay, again you see the needle there. Okay. You take out the stellate. It's moving a bit away from my needle as I'm puncturing, so I'm not very sure whether I'm in the wall or whether I've gone into the solid component. Can we take off the Doppler? Yeah. Okay, I may still be in the wall because you can see an indentation. Not really gone inside. Okay, just one quick jab.
It's indenting the wall.
Yeah, it is. It has not really gone inside the place I've. Okay, can you hold it here?
Yes.
Okay.
Looks like it's in there.
Yeah. Just moving in and out a bit. Thanks. Get the suction so that we can take some cell block if required.
What do you think this is?
My guess is it's a SPEN,
Okay.
but the other differential we consider was a cystic neuroendocrine, non-functioning neuroendocrine tumor.
I don't know whether this was mentioned, but probably I'll give you a later report of what we've done in this patient. She came to me almost a year ago with this cyst. We aspirated. That time there was no solid component. We aspirated that. CA was normal, amylase was normal. She was okay. And over the last 1 year, it's again come back. And now she's got solid component. So that's something that we need to. Probably this was not mentioned in the history because we always like to keep some suspense in the end. That kind of thing.
So how do you interpret that history? I mean, is it?
No, I think this is some kind of a cystic lesion which has a neoplastic process inside. I don't think this is just a pseudocyst or a simple cyst. That's definitely for sure. SPEN is definitely a possibility. Yes. What about you, Lawrence?
Yeah, I was just talking to them that I think SPEN usually has more solid than liquid component, almost 80% solid. So I think knowing now your history, the new history that this started with dominant cyst until it started puncturing and then it grew solid. So I think, this sort of thing we have to rethink whether this could be another one of those benign kind of cysts, which I think is more likely to be benign cysts. I think sometimes you can't tell even the serious cyst adenoma whether this is something. The solid also doesn't look very malignant to me. And the size hasn't altered, the same size. And she's asymptomatic. So I think we will just basically take the solid part as a last check. And then knowing that your fluid is all benign, from what you say CA is normal, everything is normal. Sounded more like serous. And amylase is negative as well. So unlikely to suddenly change different things. Just I think those solid component also doesn't look too troublesome. So I think we'll just wait for this.
It didn't feel hard at all. It was very soft. It was very soft.
Yeah.
Only the wall was a little thick, so it kind of was moving away as I was trying to puncture.
So it could still be a SCN in a young lady.
Uniloculated.
Yeah, possible.
Okay.
Not a macrocystic type.
Okay, I'm done here. Unless you want to have a look at something else.
This white thing is blood, I think, because of the tumor bleed, because of the FNA.
Is it a bleed? No, I think
the thing in the lower part.
Yeah, there is some solid component. A partially organized hematoma can look like this. After a few weeks, you can have some solid component on one side and liquid on the other side. But she had an intervention about a year ago, so I mean, unless there was a history of sudden onset pain a month ago, it just doesn't fit in with the hematoma that's getting organized.
No, the small white area on the lower part could be related to the present because it's not seen earlier. Very small amount of bleed on the right.
On the right?
Yeah, this.
No, that was there earlier. That part was there earlier.
So this could be another indication for using the biopsy forceps. You could, if you're not getting a diagnostic yield, we know there's a thick wall here. Presumably the pathology will be within the wall of the lesion as well. So one could use a confocal to assess whether it's a papillary, whether it's a lesion like a neuroendocrine, but also I think a biopsy of the wall would be useful if we're not getting a good diagnosis with the FNA of the solid component.
It's 4.5 across. It's quite.
Both ends.
Yeah.
Oh. And pretty normal.
Yeah. A spen, the ones I've seen have been located in the body and the tail. I've not seen a spen in the head of the pancreas. I think that's a typical description of the location of a spen. So, I think we'll have to wait for, I don't think we can make a definite endoscopic EUS morphological diagnosis here. We'll have to wait for the pathologist.
Hello, AJ.
Mic is on this side, it is falling down.
I think Vikram.
ये वाला गया कान.
Hello.
What do you want? The mic is falling.
Are you still with me, or have you gone to another room?
No, we've gone to room number 5. Vikram is ready with the case. Rajendra, maybe you can take over from that room.
They can hear me. I'm on.
Hello, Vikram.
Hello. Is my voice clear?
Yeah.
Okay, so I was waiting for Abby to finish, so I had a brief look. I thought you got the history. This is a lady with chronic calcific pancreatitis. Now, that is what is known. The reason of doing a EUS is that she has had a prior endotherapy, and now she has worsening symptoms. And worsening symptoms in a patient of chronic pancreatitis should alert us to the possibility of two things. One, her diabetes or exocrine function is worsening. Her endocrine function is worsening. Two, her exocrine functioning may be worsening, so we have to look for nutritional deficiencies. And third, obviously, this is a pre-malignant condition, and as endosonographers, we look for any malignancy which has supervened. So that can happen even in young people, and it can be very difficult to pick up. So I am in D3 now. Normally that's not my practice. I begin in in the stomach and clear off this. Look at the upstream pancreatic duct and other structures. So from D3, as Sandeep just showed you, we see the aortic bifurcation. We see the IVC and we see the spine behind. Rotating to the right, we see the superior mesenteric vein and the superior mesenteric artery with the vein closer than the artery. We withdraw, trying to be very careful not to fall down, and what we have here is the pancreas appearing. So this is the pancreas. Can I have a little bit light down, please? Light down a little bit, please. I'm sorry. The screen is too far away from my head, so I am having to stand to see. So this is the inferior pancreatico-duodenal angle, and this is the inferior part of the head of the pancreas. And this case highlights the difficulty in scanning a pancreas riddled with stones. So these are all stones here, full of stones with distal acoustic extinction. So this is chronic calcific pancreatitis, and we have to look very carefully that we are not missing a malignancy somewhere here. So we see here, look at my arrow is at this point on the pancreatic parenchyma in the inferior head, and I am looking as I talk to you. So in case some of you pick up things which I haven't seen, kindly let me know. So I have enlarged the image further, and I look at the inferior pancreatic head. What I am looking for is areas that are devoid of any stones, which would suggest that here is a tumor which has pushed apart the stones. These are all multiple stones.
Yeah.
All multiple stones. I don't see any obvious tumor here. You see ectatically dilated side ducts, and this is a classical tropical pancreatitis, if I might. Large bulky stones, millimeter by millimeter withdraw. Again the head of the pancreas. This is possibly the line of the pancreatic duct, but you don't see the duct as duct. We only presume that this part from here to here would
Could
be
be
the duct.
pancreatic duct.
Would be the duct, but that's a presumption. I cannot be sure. These are all ectatically dilated side ducts. So this is the Indian version of pancreatitis, and now we keep rotating slightly, looking whether this looks like a tumor, whether this looks like a tumor, whether I see something, any complications supervening. Thus far, nothing conclusive. So I fall back with some elegance into the stomach, and as I fall into the stomach, my scope is straight, and I reach the aorta. Now you push down on the aorta, and you see the mesenteric vein, and you see the mesenteric artery, and you see the pancreas here. So this is the superior mesenteric vein, which is patent. You withdraw, you withdraw, you withdraw, and you pass over the confluence and the portal vein. So that's the confluence, and this is the pancreas. So what all I am doing is gently rotating over the pancreas to see whether there is any area of ductal cutoff, any tumor. The entire pancreas is riddled with stones, possibly not amenable to endotherapy. I rotate, I rotate, I rotate, rotate over the pancreas. This is possibly the pancreatic duct here. This one here, we see a little bit of pancreatic duct here. This is the duct, and if I freeze it with for you and measure, this is around 2.5 millimeters, so not that big as it seems. It's possibly the pancreas itself which is atrophic, so one must be very careful to objectify the visual impression, because in an atrophic pancreas the duct looks spuriously large, and that's not an indication for endotherapy. We also continue to rotate, 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 and pass over the kidney and rotate over to the spleen, and that's the splenic hyla, big wheel down, and the scope rotated to the right to complete evaluation of the tail, back,
Tail seems to be atrophic.
adrenal. Sorry?
The tail seems to be atrophic.
The entire pancreas is atrophic, so
And
this, yes, you are right. So maybe we don't see much of a tail here. I agree, this is where the area of tail is.
Right.
We pass over the kidney, the adrenal, one rotation back, last image into the liver and a bulbus. This is the liver, the left lobe, segment 2 and 3. This part is the diaphragm, and this hyperechoic area is possibly either the ligamentum teres, which is which is being cut in cross section, or a small hemangioma. We can define that later. This is possibly an oblique image, likely the ligamentum teres, because the diaphragm is seen as a very thick hair. Obviously, we have to be careful that we are not looking at a loculated pleural effusion above the diaphragm, but that's not the clinical question here. This may either be a hemangioma or a very big rounded end of the ligamentum teres as it goes out to the falciform. If you look at the liver ecotexture, this is slightly inhomogeneous, and that's the tip of the heart. Any question from the audience, please? Hello? Hello?
None whatsoever just now.
Thank you. And I'll just enter the duodenal bulb. So that's the pylorus, and we enter the bulbus, we stop, we inflate, and we image the head of the pancreas. So we see the gallbladder, and you see floating microlithiasis inside the gallbladder. Can you see those?
Yes.
Little starry sky.
Yeah.
So these are microlithiasis. That's the starry sky appearance. I have rotated or dropped my hand in the bulbus to the left, so that my probe is rotated above to the gallbladder, and that's the segment 4 which you see beneath it. And you see these little artifacts, those are the starry sky. To better define, I can switch on the tissue harmonic images, which images at multiples of the fundamental frequency. So I am in tissue harmonic imaging P. I also have in the Olympus EUM2 the option of tissue harmonic R, but my personal preference is P. So this takes off the artifacts from the returning echos and shows you the contents in an anechoic structure better. So now you better define these floating microlithiasis. These are microlithiasis. Mind you, this is not sludge, these are small stones which can be demonstrated now directly by EUS. Previously we used to see crystals on polarizing microscopy and infer that they were used to define small stones and microlithiasis, but now we can actually see them. When they become larger, we call them conventional stones. These are just the same thing and different from sludge. In this case, likely not of any pathological significance. I turn right in the bulbus to complete the evaluation of the head of the pancreas.
Dr. Bhatia, one question.
Please.
This of course patient is post endotherapy, but if patient comes for an endotherapy,
yes,
and CT doesn't show any mass, would you go for a EUS before going for an endotherapy, or we do endotherapy and see the response?
No, I am biased, but I think I have science to support me and some experience that in such patients where you have a pancreas like this, a EUS should always precede ERCP and any attempt at endotherapy for 2 or 3 reasons. One, you define any tumor which exists, which explain the symptoms.
Okay.
2, you actually what we call as mapping the pancreas. You define the entire pancreatic ductal anatomy. You don't thrash around in these dilated side ducts, because when you practically do a ERCP in this case, your wire will go here, there, coil, you will injure the side ducts. So now you know that you have to inject a little bit of contrast and guide your way up. 3, you know that in this case any attempt at further stenting or endotherapy is futile. This is a burnt out pancreas with extensive stones in the side ducts. You cannot remove them by endotherapy. There is nothing obstructing the pancreatic duct. So to my mind, at least endoscopic therapy for pain relief is not indicated. We are also now looking at any biliary obstruction, that's the bile duct, which you see just below the transducer. I'm sorry, I'm having to turn. So that's the GDA and gastroduodenal artery, and that's the bile duct, which you now see. That's the bile duct. And there is no biliary obstruction, which should also be looked for in the head of the pancreas, which can either be inflammatory, compressive, or a tumoral obstruction. You see the pancreatic duct here. I'll take this off the flow, and we can better define the pancreatic duct in the head. That's the portal vein which is coming in, and that's the superior mesenteric artery which we see from here. And that's the splenoportal confluence, that's the splenic vein, that's the inferior mesenteric, and that's the pancreatic duct which we see here. And if you see above a vessel, this is the gastroduodenal artery which defines the anterior part of the head of the pancreas.
Yes.
A little bit of rotation and you will see the CBD. This defines the posterior part of the head of the pancreas, and that's the gastroduodenal artery. If I trace back the gastroduodenal artery, we see the splitting of the common hepatic into the proper hepatic and GDA.
Yes.
So I think Amol, we have mapped the pancreas. We have seen that he's having some liver fibrosis, a burnt out pancreatitis, atrophy, stones, non-dilated ducts, no evident tumor, no splenic vein SMV thrombosis, no fluid collection, no active inflammation.
That was excellent demonstration.
And I think this is the information we need.
Excellent demonstration.
Thank you. Thank you.
Okay, so I think we are moving to the room 4, where Dr. Rajesh Gupta is ready with the next case.
Yeah. Hi, good afternoon.
Good afternoon.
Yeah, and it's not that late in the evening, although you are seeing the room dark.
Yes.
So, Rajesh, what do you have over here?
Yeah.
This is a patient, Shiva, you can give the history.
He is 30-year-old male with history of pain in abdomen, epigastric region radiating to back, suggestive of pancreatitis. So on evaluation, he was found to have pancreatitis. So what only thing is we are not sure whether it is acute pancreatitis or acute and chronic pancreatitis. There was a strong family history of chronic pancreatitis. So EUS is done to evaluate the pancreas and then see what is the status of the pancreas.
So you have heard this story. Is a young man who has come with a short history of pancreatitis, in a background that the patient has a strong family history of pancreatitis. So our job is to evaluate the patient has whether acute pancreatitis indeed, or it's a recurrence or exacerbation of underlying chronic pancreatitis. So as usual, for the want of time, I have already into the stomach, and you can see the liver, and these are the hepatic veins, and I think these have been since morning we are seeing these are the hepatic veins, and you can see the IVC also here, and the veins are converging there. So the first base station, we are supposed to evaluate the pancreas in entirety. So how to evaluate? First thing is I have to do one maneuver, that is aorta. If I torque my scope from the liver side, you see the aorta. You can see appreciate the aorta. And once you see the aorta, you do a clockwise rotation, and then you see, you have to see with the spleen and the left kidney. Can you appreciate?
Yes.
So this is spleen and this is left kidney, and in between the spleen and kidney you will see the splenic vein, and this is the tail of the pancreas. That looks okay. There is no collection, no mass as such. So the tail appears to be okay as such. In this particular area there is no collection, no peripancreatic fluid, and everything appears to be okay here. But now we have to go enter little counterclockwise rotation, and you see towards the body area. Now you see there is a distinct change. So what you observe here is I am seeing the body of pancreas. Can you appreciate?
Yes.
Who is on the dais, please?
I am Rohit and Sunil.
Oh, so Rohit boss. So you can see that, Dr. Rohit, you see that I am seeing the body of pancreas. Can you appreciate that?
Yeah, yeah.
And the duct is grossly dilated. Pancreatic duct is dilated and is full of sludge-like material and few of the dense calcification. So it is a chronic pancreatitis, obviously. So because of two reasons: one, the ducts are dilated and there are echogenic stones and some sludge like or floating material. And here you see the portal vein down there, which is entering into the hilum of the liver. So this is what it is. And so if you do a clockwise rotation, you go towards the tail of the pancreas. If you do counterclockwise, you go toward the body and head area. So this is the way, and now you see the whole body. You can see the duct is grossly dilated. There are few echogenic foci, floating stones. And if we go towards tail, this is spleen, this is splenic vein, and this is adrenal, left adrenal, and the crus of the diaphragm.
So there are no changes in the tail region.
There are no changes. That's important. So when we do pancreatic examination in the background to see whether the patient has two things, Vikram has already told, those patients who have long-standing chronic pancreatitis, our aim is to rule out any malignancy. Here my job is little different. My job is to find out whether the patient has first attack of acute pancreatitis or any changes of chronicity are there. So here I am clearly seeing the changes of chronicity, and you can appreciate the whole body is showing the ductal changes as well as the calculi. So is that clear?
Yes.
So okay. So you can see the vessels here also. You can see the splenoportal confluence, where just above the splenoportal confluence you can see the neck of the pancreas. Dr. Rohit?
Yeah, yeah.
You agree?
Yeah.
Okay. So the whole duct there, and the vessels are patent minded, because another important thing while we are evaluating the pancreas, we need to see, because these patients are sometimes associated with portal venous thrombosis or sometimes splenic vein thrombosis, which is not there in this case. So the vessels are patent so far. I don't see any masses as there. The pancreatic parenchyma is fairly well preserved, but ducts are dilated. So the other important thing is, I am told that there is a history of, strong family history of chronic pancreatitis. We have to be mindful of the fact, because these patients sometimes have hereditary pancreatitis, and there is a very high risk of development of malignancy in these patients. So we have to keep in mind all these things when we are evaluating and exploring the pancreas. So now we are going toward the head of the pancreas. So there are two ways, and below that, and you can see this is the splenoportal confluence clearly, and one side it is going to the splenic vein, the other side is splenomesenteric, below is the portal vein. Is it clear?
Yes.
Dr. Rohit, can
Yes,
you appreciate that?
Yeah. So you're in the duodenum or just?
No, I am into the body of the stomach still. I am not in the duodenum right now. I am exploring from the duodenum. Okay?
Yeah.
So now I'll go into the duodenal bulb. From bulb, let us see how it looks like. You see, So here the story is totally different. The head of pancreas is showing obstructing calculus. This is the portal vein, splenoportal confluence, the angle, and you see in the head area above is the bile duct, which appears to be okay, and now you see the PD is more dilated than the bile duct itself, right?
Yeah.
This is CBD where the cursor is there, arrowhead, and the below is the pancreatic duct, and it is showing lot of calcifications.
Can you measure the PD here?
Yeah, can you measure? Yeah. Nachiket, can you measure it? Yes. I think it is more than, so it looks 5.1, but visually, because it's maybe 6, 7, and you see that there's it is causing calcular block. So this gentleman must be having pain for a long time, but it got exacerbated, and there is a clear-cut obstruction in the pancreatic duct. So you see the big stone with a shadow.
Large calculus.
Yeah, it's a large calculus, and it's in the head area. In addition to that, what I would like to show one more thing is, there is edema also. So this patient, little duodenal deformity is also there because of the acute attack of pancreas. So, sorry, yes, yeah. Yes. So now what we are seeing, this maneuver has been done many a times today, because we have seen aorta and IVC, and then we have to see this edema. Yeah. Dr. Rohit, can you see in the so there is lot of edema is there. Wall. So in duodenal, I am in D2 right now, and pulling back on the scope, slowly you can see the PD dilated, and above is this is the uncinate area, and the duct is grossly dilated, and this is you see I am pulling back on the scope slowly, and you see there is lot of edema also. So there is an acute exacerbation of underlying chronic pancreatitis in this particular patient, and that's the reason he has a fresh attack of pancreatitis, and that's the reason he started getting pain, and the pain, otherwise it's not an acute disease, it's a clearly chronic disease.
Yes.
Okay, and this is the gallbladder. Now I've fallen back again into the stomach. This is the gallbladder, it appears to be clean. So you see the duct is, there is a large stone which is obstructing the pancreatic duct here. So this patient is definitely going to be benefited by endotherapy, because this is an obstructive pathology here, and if you take care of this stone, the patient is likely to benefit. Otherwise he will continue to have again the similar kind of pain attacks.
Right, sir. So I think
any questions?
Any questions? Welcome from the audience.
The liver is fatty liver?
Liver appears to definitely fatty. It is fatty liver. I didn't comment because I was focusing on that area only. But here you see that there is very dense calcification already, and it's possible that it might be a hereditary part of hereditary pancreatitis, because these young patients, they tend to have very dense calcification from first decade onward itself, and there is a very high risk of malignancy, and we need to keep this patient under surveillance for malignancy also.
Yeah. So I think that has been an excellent demonstration by Dr. Gupta sir, and I think the next room is ready. So thank you, Dr. Gupta.
Thank you. Thank you,
we'll just
thank you, Amol.
Move to the next room.
Okay. Yeah, so I think we are ready with the cytopathology for all the three FNAs that were done, and Chantal will speak about those. So they're just getting the images ready. Are they ready? Okay. So they're just getting the images ready. Till then, any questions? To Rajesh is also here, so yeah. Any more questions on chronic pancreatitis? Hello?
So in this case, you will do a lithotripsy of the large stone first and then do an endotherapy?
Yeah, probably. If the stone is radio opaque, then we would do a lithotripsy. If it's,
Yeah, clearly Rohit, that's absolutely right, because there is a large obstructing stone in the upstream dilatation of the pancreatic duct, and here we can do ESWL and fragment this, pulverize this stone, and then we decompress the pancreatic duct. This is going to give him good pain relief. Absolutely, I agree.
right, and we can see that the slides are ready now. So over to you, Chantal. I think we'll have the histopathology, cytopathology session.
Okay, sure. Okay.
Ivan, if
Yes.
you can shift.
Can you hear me? Can you hear me? Hello? Okay. All right. Okay. So let's start with the first case. This is the
Dr. Maggie, we
pancreatic
can't hear you.
lesion that had the lymph node as well. So as we can see here, you have numerous, you have a few groups of benign acinar cells. We know these are acinar cells because they form nice round ball-like architecture, and you can see the nuclei are peripherally located. Typically, the benign pancreas has 95% acinar cells. So if you see abundant acinar cells, it means that either you're looking at a benign lesion or there's sampling error. In this case, I believe they were in the right location, but it happens to be benign. Yeah.
Can you tell us which case was it?
Okay. So just so I can repeat, okay. So now if I repeat, here you have several groups of acinar cells. How do we know these are acinar cells? They're nice and round and the nuclei are peripherally located. Typically, the benign pancreas is 95% acinar cells. So when you have abundant acinar cells on the smear, either you're looking at a benign lesion or it's secondary to sampling error. In this case, I believe they were in the correct location, so it happens to be a benign pancreatic tissue. In addition, this patient also had their lymph node sampled, and you can see abundant lymphocytes. They are scattered lymphohistiocytic aggregates, meaning that we have macrophages which happen to have benign lymph nodes surrounding them. This is a feature that you would normally see in a reactive lymph node. So there's no malignancy here, there are no granulomas. This is a benign reactive lymph node.
This was Shyam's case?
Yes.
Okay.
Now, the most recent case that we looked at, which had both a cystic and solid component that was present in the head of the pancreas, you can see here that it's a very cellular aspirate. And there happen to be these groups of cells that have almost an elongated type architecture, looking like nice papillary elongated fronds. In pathology, when things have elongated finger-like projections, we use the word papilla. So this happens to be a spin. This is a solid pseudopapillary tumor. You can see that there are monotonous appearing cells surrounding fibrovascular cores, and there happen to be single cells also in the background. If you only had the single cells and you didn't have these nice elongated papillary core, your differential would include neuroendocrine tumor versus a solid pseudopapillary. But the architecture is overwhelming in keeping with a solid pseudopapillary tumor. And finally, the last case we're going to show. Here you can see on the image, if you were looking at the, does this burn up? Does the mouse work? Oh. Okay. So here you can see you have a nice benign group of ductal cells. The nuclei are nice and round, they're evenly spaced, and they're about the same size of background red blood cells. Now, if we were to compare this nice benign ductal group to this group here, you would see that the nuclei have lost their polarity. They are no longer evenly spaced, there's overlapping. The nuclei are also considerably larger, so you have a high nuclear cytoplasmic ratio, and you also have irregular nuclear contour. This is overwhelmingly positive for adenocarcinoma. You can also see that there happens to be a little bit of fibrosis in the background, so there may be a component of desmoplastic stroma in this patient. Okay, I think I've covered all three of the cases that we looked at this afternoon. Any questions?
This was the Sandeep's case?
Yes.
So what was the final diagnosis in the first case? The cystic lesion, the mass in pancreas, multiple lymph nodes. We still haven't got to the diagnosis of that case.
Okay, so the case that we're currently showing, this is adenocarcinoma. Okay?
Yeah.
So Sandeep's case is adenocarcinoma. Sham's case was benign pancreatic tissue and a reactive lymph node, and the case that had the cystic and solid component happened to be a solid pseudopapillary tumor, also known as SPIN.
Any questions?
Okay, yeah. So, any questions on that?
Nothing from the
Otherwise, we'll move to, the room number 3. We've got Dr. Saurabh Gupta with a case. He's just starting that.
Go ahead, Amol. Yeah.
Till then, probably I think they're still getting ready, so we can have some discussion, and we'll just, if there are any questions, we can take those for pathology as well as.
Dr. Maggie, if you aspirate only necrotic material, then say in tuberculosis we often get necrotic material, and there's no tissue. So you have to repeat it or use a larger needle, or what to do? What should be the?
So depending upon the location, if you have necrotic material, let's say we're talking about the pancreas, we know you can have tumors that can have degeneration and have a huge necrotic component. If you're suspicious or you have a high index of suspicion for malignancy, I would suggest going around the periphery of the lesion, which happens oftentimes if there's a tumor, the center of the tumor will actually degrade and have a necrotic component. So if you have a larger lesion, I would say try to procure tissue from the the side or periphery of the lesion. Now, in regards when it comes to lymph nodes and you're concerned about tuberculosis, if it's necrotic, unfortunately, necrotic material is non-diagnostic if we do not have any viable cells. Sometimes you can actually take the necrotic tissue and, possibly try to do stains on it and see if you can see any degenerated cells. However, I would behoove a pathologist not to do that because it can lead to an erroneous diagnosis. So yes, I would say either you need to try to find a different node, a different location, or either try to go to the periphery of the lesion, or in some cases, you may have to try to use a different needle. Not necessarily a larger needle, but sometimes a smaller lesion can actually help discern diagnostic material from necrotic material, particularly if you try to stay towards the periphery. Larger lesion or larger needles sometimes collect too much material, and most of the material that you're going to procure if the lesion is necrotic happens to be the necrotic tissue, because that is the part that actually is degraded, so it's easier for the needle to pick that up. So therefore, I would say try to stay towards the periphery. If the lesion continues to be necrotic, I would suggest that try going to a different location or a different station if you're evaluating lymph nodes.
And what I gathered from your lecture is the way forward. When the needles are cheaper, biopsy is going to be the answer?
Well, when the needles are cheaper, I would suggest doing more passes. I think biopsy is the answer when you do not have any tissue. So say, for example, you've done 7 passes, no material has been procured. It may be, I would suggest doing a biopsy needle, or using a biopsy needle, because they are meant to actually take and cut dense fibrous tissue. In addition, the only time I would also suggest using a biopsy needle if you need to have retained architecture. But the only times you actually need that is typically for lymphoma, liver parenchymal diseases, and for gastric signet ring type adenocarcinoma. But usually we don't really need architecture in order to make a diagnosis. We just need sufficient material. And you can use standard FNA needles, which are more cost efficient, in order to procure enough material. If you use larger needles, so you can use a 19 gauge or 22 gauge needle and do multiple passes, somewhere between 5 and 7 passes. And I think for the most part, you should get diagnostic material 95% of the time.
I think we are ready there.
Thank you.
Yeah, Rohit, I think Saurabh is ready in the next room. So let's move to room number 3.
Hello. So we are ready here with Dr. Saurabh Gupta and Dr.
I'll summarize this case. 50 years old gentleman has presented with the obstructive jaundice of 3 months duration, both on clinical and lab features. Imaging was done CT scan abdomen, which has showed dilated CBD with IHBR and narrowing in the distal CBD. So here we are assessing a case of obstructive jaundice with some distal biliary pathology. So over to our presenter.
Thank you. So what we can see here is I've just introduced the scope, and I was just looking at the body of the pancreas here. And the first thing to notice is you've got a pancreatic duct that is completely normal caliber. So when we look at that, we say immediately that obviously we don't have a double duct sign, so we only have biliary dilatation. We don't have pancreatic duct dilatation. So to me that can mean two things in someone with obstructive jaundice. One is that it's either going to be a lesion within the distal common bile duct, or it's going to be a lesion in the uncinate process of the pancreas, and that often can result in a normal caliber pancreatic duct. So already by examining the pancreas, I can tell that what I'm expecting to find when I go into the duodenum. So I'll just drop this, rotate the scope from the body of the pancreas by 180 degrees, and we get to the left lobe of the liver, segment 2, segment 3. And immediately we can see that there's too many anechoic tubular structures here. So we're not seeing just the intrahepatic portal vein segments like we should normally see. We're seeing tram tracking, which is even without the benefit of Doppler. If you don't have Doppler, here you can see quite nicely that you're seeing two structures, anechoic structures, next to each other. And so one of them will be the portal vein branch, and one of them will be bile duct branches. So we can say that there's already intrahepatic duct dilatation just without even putting Doppler on. But if we want to confirm, we put our Doppler on, and we can see significant intrahepatic dilatation here of the intrahepatic segments. So I've already scanned the liver. I always like to try to upstage the patient. So I've scanned the liver, at least from the stomach here, looking for any evidence of metastases.
Saurabh, can you point out the segments?
And I didn't find anything there. So what I'll do is I'll head on back down to the duodenal bulb now, and we'll try to look at the... Oh, before I do that, again, like I mentioned earlier, we can often see the bile duct and the pancreatic duct from the stomach, in thin patients especially. So here we've got the genu of the pancreas just there with the splenoportal confluence, and we see the pancreatic duct, and deep to that you can see a big dilated anechoic structure. That's going to be your bile duct that's dilated. So if we put our Doppler flow on, we can see there's the bile duct. So already we know that the bile duct right here is grossly dilated. But generally I'm not going to spend time looking for pathology of why it's dilated here, because I know I'm going to go down to the duodenum and look from there. So we'll take the cursor off. Yeah. So we'll just advance the scope into the duodenum. And here we are in the duodenal bulb. So once again, I'm trying to identify my structures. So there's my portal vein, and then between the portal vein, which is the first structure I saw there's the portal vein. Then I'm rotating around and I'm seeing this big anechoic dilated structure, which is going to be my common bile duct. Yeah. And we can quite clearly see that it is, even just without measuring it, we can say it's going to be grossly dilated, because deep to that we're seeing vessels, and we're seeing portal vein there, and so the portal vein diameter is going to be 8 or 10 millimeters, and we're seeing that the bile duct is 1.5 times the size of that. So we can say that the bile duct is going to be at least 15 millimeters, but if we want to freeze it and we can measure, we can look at what the bile duct is distally, and we've got 16.7 millimeters. So we can say that there's obviously significant extrahepatic duct dilatation. So now we want to follow the bile duct. We know if the bile duct is dilated, the pathology is going to be distally. So we're going to rotate the scope clockwise and try to withdraw the scope a little tiny bit to follow it down towards the ampulla. But sometimes we can't see that nicely without falling out back into the stomach. or without advancing into the duodenum, into the second part of the duodenum. So what I'll do is I'll actually pass the scope into the second part of the duodenum, and we'll try to examine. So here we're seeing the mesenteric vessels beneath the transducer, and I'll just zoom in there. And so we slowly withdraw, and our pancreas is coming into view there where the cursor is. And then we'll just rotate around until we see initially we'll see the ampullary complex, and then, so we're not seeing ampullary structure very well, but we're seeing a very thin pancreatic duct, which is just there, below the bile duct. And we're just seeing it come in and out as the patient breathes. And we're seeing a grossly dilated CBD. So then I'll try to trace it to the ampulla. And I'm not really seeing an intrinsic mass lesion within the distal CBD.
Is this patient symptomatic?
Are you going to use a water irrigation for the ampullary anatomy?
No. So what we need to do is we need to actually visualize the ampulla itself to try to make sure that we don't have an ampullary lesion. So with the Olympus echo endoscopes, we can really quite nicely see the ampulla just with endoscopic view. We don't need to generally use a duodenoscope.
Right.
But otherwise, if we have the Pentax system, sometimes we use a duodenoscope first and then examine. So we can see a big bulge of the distal common bile duct, the intraduodenal portion of the distal.
View also shows a dominant.
Yeah. And then, is there a lesion on the ampulla? Probably not, but hard to say for certain whether there's a lesion on the ampulla there. But I would have expected, if it's an ampullary lesion, that we'd have a double duct sign and a dilated pancreatic duct as well as the bile duct. So we're not seeing a definite ampullary lesion, but we still are not seeing a mural lesion arising from the CBD as well. So what we'll do is we'll just zoom in a little bit more. And so there's our distal, there's a tapering of the, so it tapers quite abruptly, and we've probably got a small lesion just there.
Looks a bit irregular.
Yeah, so just there we're seeing a very small, irregular, shelf-like lesion in the distal CBD. So, if we take the cursor off. So just here, now we can see that we're seeing this shouldering of the ducts, and it gets pinched off right here. And in this area, we're seeing probably a small mass involving either the ampullary structures and growing into the distal CBD, or involving the just arising from the actual CBD itself.
Very, very subtle.
Can you put some water?
So if we try to measure it, I'm not sure, because it's so subtle, we don't know where our borders are, but we're looking at a 1 centimeter, 12 millimeter lesion at the most. So it's not a big lesion.
Is it a distal cholangio?
Sorry?
Is it a distal cholangio?
That's what I'm thinking. It looks more like a distal cholangio than it does an ampullary, and it doesn't look like a pancreatic ductal adenocarcinoma.
Right.
So I'd be thinking cholangiocarcinoma would be most likely for this gentleman.
Can you instill some
then
water?
The question comes, what are we going to do? This patient is deeply jaundiced. He's got complete obstruction at the level of, or just above the level of the ampulla, and he's not drained. So then we've got to think, well, what are the risks and benefits of doing an ERCP? An FNA. Firstly, the question is, do we need to do an FNA? Will it change what we do? And secondly, is there a better way of getting a tissue if we're talking about a distal cholangio versus a pancreatic ductal brushings or biopsies? In my practice, I would normally do same sitting. This patient would have an EUS, and then would have a ERCP,
and brushing.
and then we would do brushings, intraductal biopsy, and put in a stent. But looking at it with a small lesion, no obvious lymphadenopathy in the peripancreatic region, no portal lymphadenopathy, no liver metastases, celiac nodes clear. If this patient's had adequate staging with a CT scan, then one might consider this patient going directly to surgery as well, without needing drainage. Again, my surgeons generally, if the patient's bilirubin is significantly elevated, yeah, and if they're nutritionally compromised, so this patient's been jaundiced for 3 months, he's quite thin and cachectic, we might look at draining him, trying to optimize his nutrition before we think about a Whipple operation. So then the question arises, what would everyone like me to do here? The risks of doing an FNA here in patient with undrained biliary tree is obviously cholangitis. That's the biggest concern. So we might introduce infection. We haven't drained this patient, so then we could run into trouble with cholangitis.
Can I add something? I mean, what we would do in a case like this is do an ERCP, do a sphincterotomy.
Yes,
so
and do biopsies.
So the sphincterotomy will open out that area that's narrow.
Yes.
And take biopsies from there.
Yes. And sometimes you may need to do, you may not need to put a stent in. If it's very distal, sometimes the sphincterotomy itself may open up the bile duct, and you create a little fistula between the distal bile duct and the duodenum, and you may not need to do a stent.
I'm just wondering whether it could be some post-inflammatory fibrosis. The mass is, if there is a mass, it's really tiny.
Yeah.
It's, you would say 10 millimeter at the ampulla.
Yeah.
Is almost normal.
Yeah, I think it's true. I think it's a possibility that it could be a fibrotic stricture. So then I'm not sure if he's had a cholecystectomy. I didn't see the gallbladder to see if there's a history of stones, because we've got to think, well, if he does have fibrosis, why does he have fibrosis?
There are no gallstones.
So there's no gallstones. No. So we look for the gallbladder, and there's no gallstones, and this patient hasn't had a history of recurrent biliary colic, then it makes it less likely it's going to be fibrosis from passage of microlithiasis, and more likely it's going to be a malignant process. So my own personal preference would be not to do FNA, but again, I've been told that he will get a drainage procedure done within the next 24 hours, and obviously urgently if he develops anything more clinically concerning. So I think it's not unreasonable in that instance to then consider doing an FNA, and here we're looking at it from the duodenal, from the bulb, and again maybe we're seeing a small lesion, just there. So we can see a rounded lesion just there at the distal, if you want to point at it with the cursor, yep.
But I'm not sure. This is the duodenal lumen side, right?
No, so this is going down towards the duodenal lumen. So this is our lesion here, because we're in the bulb now, and we're going towards the duodenal lumen that way, and so that's the lesion just there. So there we go. That's probably a better view. We didn't get that view first time I looked at it, and so I'm more confident that we're dealing with a distal cholangio there rather than a benign biliary stricture. So would everyone be happy if we went ahead and did a FNA? And again, you can see, there we go, we're seeing quite nicely that there's that shouldering of the duct there, or quite abrupt cutoff of the duct with that lesion, and there's an irregular mass within the distal CBD. So we're seeing that quite nicely here. So again, we could use elastography to help define that, but I don't think there's any need for anything more than elastography just to help us, and then we can do an FNA. So we can do an FNA here. I'll get do we have the 25 echo tip? Yep.
Dr. Saurabh?
Yeah.
Can you show us the relationship of the IVC in this from the D1?
So before doing an FNA like we do, we always just like to check for any intervening vascularity. And so there's small vessels. I'm not too worried about those small vessels. I'm more worried about big vascular structures in the path of the needle. These small vessels, obviously that's a slightly more significant blood vessel there, but smaller vessels we don't really worry too much about.
Saurabh, are you targeting through the first part of duodenum?
Yeah, through the first part of the duodenum.
Right. Can you show us the relationship
So
of the
ideally
IVC?
antibiotics to minimize the risk of cholangitis, so yes, that'll be good.
Yeah, the questions from the audience, please.
Dr. Saurabh?
So it's a very difficult, there we go, there's the position that I'd probably want to maintain there to target that small lesion. And as you can see with respiration, the lesion's going to move.
Yes, go ahead, yeah.
Dr. Saurabh, can you hear me?
What is the question, I think?
I would like to see where the IVC comes. Sometimes there's a portocaval node when you have lesions here. And
no, IVC is seen from the D2. He's in D1.
I know that but sometimes from D2 or D1, how to target a portocaval node. That's what I wanted to know. If you can show, it'd be nice.
So that's the lesion we want to target just there.
Yes. A small tiny vessel is coming.
Yeah. So as I said, the small vessels I'm not too worried about.
Yeah, with 25 needle.
The 25 needle, it's not going to respiration, and then be comfortable and confident when I'm doing my needle pass that I'm in the right, that I'm going to hit the right spot. And the key is here to take your time, because this is where you'll get the complications, is with your FNA, so there's no need to rush. You'd rather take a little bit of time and make sure
yeah, that's spot on.
that you're targeting the lesion that you want. So hopefully we've got exactly the lesion, so we'll just do the slow withdrawal. So I'm going to do the slow stylet withdrawal here, and we'll get that, yeah. And you can see the needle tip trying to move within the lesion there.
Yeah.
And I'm using the capillary suction.
This case also is a good example of why we should always do an EUS before doing an ERCP. Because if this patient had come in and we had done the ERCP, let's say the patient came in cholangitis,
yes,
and then you're never going to find this lesion.
That's right, exactly.
There'll be a delay of another 3 months before we make the diagnosis.
Or if the patient has a stent without some brushings or biopsies done, then that will also make it difficult to make the diagnosis.
Okay, Saurabh, we are moving to another room.
Perfect.
That was a very nice demonstration. So we'll be back after getting a pathology report.
Great.
Live demonstrations will continue. We have 2 interesting cases lined up, and lectures. There will be 2 lectures at the end of the live.
I know. I normally just do the biopsies and ERCP and biopsy, and I don't normally like. Patient has to be drained. Yeah.
Hello.
Yes.
Hello, Dr. Datte, can you hear us?
Yes, we can hear you, yeah.
Okay.
hear you.
So we have the next case. So Rahul, just give the history so that we can start.
Hello everyone. Good evening all. This is a 75-year female patient with a diagnosed case of this advanced pancreatic head malignancy with D1, D2 infiltration. She had past history of gastric outlet obstruction, for which she had underwent gastrojejunostomy. Now she was came with history of itching all over the body and deep-seated jaundice. So we are posted today for EUS guided hepatic gastroscopy. Thank you.
Hello. It's very nice to join as one of the faculty to this wonderful meeting. Before starting my case, I think it is important to know the whole the morphology and the lesion first. Now I am in the stoma, in the mid-body posterior side. I'm looking at the pancreas here. We can appreciate the main pancreatic duct here, but the dimension is dilated. If I measure the dimension of main pancreatic duct, it is around 4.3, so a little bit dilated. This is body area. If I rotate my scope to clockwise, then we can reach to the tail area of the pancreas. Now I am tracing the pancreatic duct little by little. If you see this kind of, you can see the margin of the pancreatic duct is a little bit irregular. And also you can, I think you can appreciate, cursor, this whitish line, and also a little bit of irregularity and dilation. This kind of feature is, I think, is quite suggestive of distal part obstruction by mass. This is obstructive pancreatopathy, so-called. And if I rotate a little bit further, and this dilation actually continues. This is splenic vessel. And here we can see the left kidney here, and the pancreatic parenchyma. But this is old lady. But even though it is old lady, I think the pancreatic parenchyma shows a little bit of atrophic changes. Now I try to rotate my scope counterclockwise to go to the body and neck area of the pancreas. We can see, can you help me? The pancreatic duct is getting a little bit, showing irregular margin, and the dilation continues. Yes. And I'm rotating a little bit further. Then we can see marked dilation here. Now I am reaching to the neck area, genu area of the pancreas. From here, pancreatic duct shows much prominent dilation here. It is tortuous and dilated. And down here, I think there must be some lesion, but the distance is too far. But anyway, this duct is irregularly dilated. Another point is now I'm trying to trace the splenic vessel. If you use Doppler here, then you can appreciate two vascular structures. One is splenic artery, the smaller one, larger one is splenic vessel, splenic vein. I will try to trace the splenic vein, and for this I probably need to better penetration, like this. And then if I trace it, it will show the convergence, so-called portal confluence, forming main portal vein here. If I trace the portal vein, then we can reach hepatic hilum here. Liver, we are looking at the liver right now. Doppler off. To see the liver, we probably need better penetration. The 6 is not big enough, so I'm going to, now I am using 6 megahertz. The selection of the frequency is also important. Whether you want to see a bigger structure, then you need to lower down the frequency. If you want to see detailed image in a small scale, then you may use a higher frequency. Now I am using 6 megahertz, and the depth is almost 8.5 cm. We can see the dilated duct and the portal vascular structure here. Inside the liver, if you see dilated bile duct, it is definitely abnormal. And you can see this is a left lateral segment. Segment 2-3 is visible here. We can appreciate the dilated intrahepatic duct. So pancreatic duct is dilated, and also intrahepatic duct, and down here, extrahepatic bile duct here is much bigger than the portal vein dimension. I think this is dilated extrahepatic bile duct. I'm not using EU ME2 in our hospital, so I'm not used to. The dimension is how big is it? Yeah, 2.3 cm. It is really big, hugely dilated extrahepatic bile duct. So this case definitely shows double duct sign, P duct dilation and extrahepatic bile duct dilation, suggesting periampullary mass in the downstream. So now I'm going to go to the duodenal side. Endoscopy. To reach as presented before, this patient actually have gastric outlet obstruction. So we need to be a little bit careful. If we the anatomy is not well delineated. Yeah. You can, I think you can appreciate some big structure is coming into view, and this is obstructed part. We can see some blood oozing, but now here we can. I think we cannot go further from this point, so we are going to use EUS image from here. Yeah, we can see dilated or cystic structure and the right kidney here, and also right side of the liver here. This is right kidney. This is right liver. Maybe gallbladder or dilated extrahepatic bile duct here. We can also appreciate some dilated right intrahepatic duct. If the liver segment is attached to the right kidney, this segment is generally segment 6, right posterior segment. From here, I think we can use Doppler to see whether there is any, and also we don't need to this scale to see the extrahepatic bile duct. Yeah. Okay. Here. I think down here we can see the portal vein flow, maybe, and the dilated structure here also. As I mentioned before, extrahepatic bile duct is markedly dilated. Yeah. And this structure, sometimes it is markedly dilated and it may look like gallbladder. But gallbladder does not have any connection with the intrahepatic duct. If I can trace this structure up to the liver, and if I can trace the intrahepatic duct, then we can be sure that this is dilated extrahepatic duct, not a gallbladder. Although it may look like gallbladder, this is hugely dilated extrahepatic bile duct. And this is, yes, this duct is actually connected to the intrahepatic duct. This is extrahepatic portion, and this is intrahepatic duct, and some vascular structure, portal hilar area. So if this patient requires any kind of drainage, I think extrahepatic, so-called EUS guided choledochoric duodenostomy is the first one we can consider.
They just wanted to shift there for 1 minute.
Yes, okay.
Yeah, we'll just shift to the other room for 1 minute. In the meantime, we'll prepare for the puncture here.
Hello?
Yes.
Are we audible?
Yeah, you are. Yes.
Okay.
Hi. So, this is a patient with
Amol, we cannot hear you. Amol, we cannot hear you.
Am I audible now?
No, yes, now you are.
Okay. So this is a patient with, she presented with CBD stones and cholangitis, and an ERCP was attempted elsewhere 4 days ago. A pre-cut was attempted but failed to cannulate, and then she was put on antibiotic, and she has a history of some ulcer surgery, but we didn't, there's no gastrojejunostomy inside, but there is probably some duodenal deformity. And that's the reason we've kept this patient for a rendezvous, EUS guided rendezvous. So I've put the scope inside, and you can see that the bile duct is dilated. Let me put Doppler over here. So you can see that the bile duct is dilated, and there's not much of stone, but maybe a sludge ball out here. And her LFTs are high, her counts are high, so she probably definitely needs drainage. So what we are going to do is we'll do a EUS guided rendezvous. I'll put the needle in, we'll take a cholangiogram, and then I'll ask Sambaji to help me to get the wire down. Now a few tips which not necessarily help you in this procedure, because rendezvous can sometimes get tricky, because if your wire keeps going into the proximal tree, but sometimes you need to angle the wire, the needle sometimes towards the lower bile duct. Having said that, that's not always possible, because in the long loop it's not always possible. Do you have the fluoro image?
No. No.
Okay,
Yeah,
we'll just give you the fluoro image.
Yeah, we can see now.
Yeah. So the needle is still pointing upwards. So what I'm going to do is I'm going to use my elevator. But when I use my elevator, there's this gastroduodenal artery which is coming in the view. So it's kind of an obstacle race. We're going to have to maneuver across many structures. Let's see if we can get in. And since we are planning to do a rendezvous, it's not that mandatory also that we, you can try and slip by the side of the gastroduodenal artery sometimes. That can help. Okay, so hold the scope here.
So, Amol, your scope is pointing towards the hilum, the needle.
Yes, what I'm going to do is I'm now going to use my elevator and try and point it down. It's still not pointing too much downwards, but that's probably the best position that I'm going to get. So I'll use the 19 gauge needle and I'll puncture this. Now, important thing is I've primed the needle with contrast, because otherwise I remove the stylet, because that gives my needle more flexibility. Okay, so now I am in a little bit overshot, no worry, but let's see. Yeah, okay, the needle is inside.
Yep.
So what I'm going to do is I'm going to inject a little bit of contrast now. Let's see. You can move the fluoro a little bit on this side.
Could you increase the fluoro?
Yeah,
Yes,
fine,
that's
fine.
good.
She's got small floating stones. We checked on EUS a little while ago. So they are moving up and down probably. So I think that much of cholangiogram is enough. What I'm going to do is we'll flush the needle with saline. I'll take off the Doppler because it gives too much of artifacts. And now we use a Terumo wire. Can you shift on the hand of Sambaji's hands? Focus on Sambaji's hands. If we can probably, yes. And maybe you can take off the EUS image for the moment, because currently we don't need the EUS image. The EUS is only for access. Rest everything is, because they need to see the fluoro and hand image both together. Ivan, see if that is possible. Because the tricky thing is to try and get the wire down, because otherwise, things can be difficult. Rendezvous is easier done in a malignancy because you have a fallback option of a choledochoduodenostomy in case you fail to get the wire down. But in a benign condition, it can get trickier because you necessarily need to get the wire down.
Better.
Yes, yes, yes. Okay,
Yeah.
Okay. Sometimes your wire can get stuck, in which case you may need to, just repeat the puncture all over again. That also can happen. Okay. Push.
Is the wire stuck?
Yeah, the wire looks a little bit stuck. So one of the tricks to do that is push the wire in and then again try and get it back. That sometimes helps. If that doesn't help, sometimes you can go in with a catheter, but that is not something that we really like, because we don't want to dilate that tract too much. Too much of wire inside. In that case, I may just withdraw the needle and go in again. I may just do another puncture. Where is it? Okay. I'm just going to take the needle out and we'll try once more. If that doesn't work, then we'll probably use a dilator over the terumo wire after pushing it inside. So that's how it is.
Come to the mic. Amol, Sandeep is saying that why don't you try long loop position so that the wire...
I am in a long loop actually. We are at about Amol, 80 centimeters.
Amol, can you try a short position now? Your CBD is dilated, so the wire and the needle will be directed down towards amp.
Yeah, probably. Only thing is, Sandeep, sometimes that position is very unstable.
So once your wire goes in, then that solves
the
job.
I'll try and withdraw the scope a little bit and see if I can still maintain the position. If I can do that.
Before the next puncture, just see if it's amenable, then you can
Let's
go
see,
ahead with that.
fluoro. I think Dongwan is ready there. So probably we'll go there and we'll come back over here.
Okay.
Till we make another attempt. Okay, fluoro.
Hello.
Okay.
I also enjoyed Dr. Amol's procedure. In the meantime, we inserted the 19 gauge needle. Now we are just before puncturing this. But before puncture, it's better to check EUS view and also fluoroscopic view. Fluoro, please.
Can we have the fluoro on the screen?
Yeah. Can you see the fluoro image now?
No fluoro is here.
Can you
fluoro
show the
is
fluoro?
important.
Yeah, okay. Now we can see it.
Yeah. You are the yes.
No, that is the other room's fluoro.
Oh, I think that is PIP from other room actually.
Yeah. Fluoro from here, this
no,
room?
No, we cannot see that.
Yeah.
Yeah, okay.
Can you see the fluoro?
Now we can see it, yeah.
Yeah. This is the position for choledochor duodenostomy. Guide wire goes upward to the intrahepatic duct and the stent can be inserted like this. If you want to do Rendezvous procedure, then just tip up a little bit and push the scope a little bit more, then toward the echo endoscope can go toward the second part of the duodenum, the bile duct direction. That's what I usually prefer. But this is for colorectal duodenostomy, so I'm going to puncture here. I'm going to puncture the dilated bile duct here. One quick jab is generally enough. Now the needle is inside, just aspirate a little bit. If it is bile, then inject contrast. Yeah, I can see the bile is coming.
Can you see the bile there? Can you show them the external image?
Can you see it? The camera image, yes.
Okay.
And the inject contrast for the procedure.
We go back on the fluoro now. Fluoro on.
Fluoro, yes. Yeah.
Increase the fluoro.
Yes. You can see the dilated extrahepatic bile. I think this is good enough.
Okay.
And before guide wire manipulation, some saline injection is better because contrast actually creates some viscosity. So push the contrast out from the needle and then insert guide wire. Here, my assistant is...
Which guide wire are we using?
This is Terumo guide wire. Yes, excellent. So, upward. Here, he is trying to manipulate the guide wire tip. This cooperation is very important to do successful procedure.
But can we have fluoro little above?
Fluoro above.
Fluoro on.
To see the guide wire tip. Is above? Yes.
Yeah,
okay. Is it deep enough?
Yeah, it
yes,
is looped there.
yes.
It is looped inside.
Yeah. Okay. Then I'm going to remove the needle and try to dilate the puncture site using dilator, catheter dilator. Yeah. Guide wire inside. And during this period, the maintaining the tip of echo endoscope is very important. It is actually critical. So not just guide wire manipulation, we need to keep the echo endoscope tip in a stable position. Yeah. Okay. Okay.
So
and
this
then
is a short guide wire exchange.
Yes, yes. Because the guide wire length is short, they are injecting saline now. Okay. Now we are going to insert catheter dilator. In our hospital, we use either a 543 catheter or microknife. Yeah, but in this case, this case, catheter, I think catheter is okay.
So what dilator are you using in this presentation?
What is the diameter of the dilator?
6
here?
French.
This is 6 French fluoro.
Is it Surendra dilator?
Yeah, it is a specially designed. Can you show them the tip of the dilator? Their dilator tip has been tapered and made very sharp. It is a Sohendra dilator with a little modification.
Yeah. Before starting this procedure, it is important to discuss with your nursing team what kind of device are we going to use and review the sequence of the procedure. Thereby, we can shorten the procedure time. If once puncture is done, fluoro,
please.
a guide wire is important. Now the catheter is coming out. Yeah. Guide wire, full guide wire. Guide wire is inside. Not come out. Just a moment. Just a moment. Do you think guide wire is going inside? No. I think it would be better to remove
Coming
it.
out. The guide wire is coming out. Guide wire is coming out.
Okay. Short guide wire. Yeah. I'm used
It
to
has
you
come out, it has
coming.
come. It's
Okay,
okay, yeah.
okay. Fluoro. Yes. Yeah. Oh, just a moment. Now I want to see the catheter. Yeah. Yeah. Pull the guide wire a little bit back to get the strength. I think scope tip is here. Now I'm trying to use the EUS view to dilate the track. If this catheter does not go easily, then I'm going to change this to cystotome. Yeah. Pull the guide wire back while I am pushing it. Yeah. I think better to use cystotome because the guide wire is not strong enough here. Yeah. Okay. Yeah.
Yeah, so we are exchanging it for a cystotome.
Yeah.
Fluoro wire has come out.
Fluoro.
Oh my God.
Oh my God.
Yeah,
Already?
it is out, sir.
Okay. Then we can use another puncture, and it's better to use busy glide long guide wire.
Busy glide wire.
Yeah, this step is, I think.
Okay, so we'll just shift there in the meantime.
Mm-hmm.
So we are we
could
still
have
on?
done this at the first go by a VisiGlide.
Yeah, we are going to use long guide wire because short guide wire there is a little bit tricky
Termo should be
portion.
used only when you need a manipulation. You need to manipulate.
Manipulation is easy, but when we are trying to insert the dilator or other device, the length is small, so it is quite tricky. Now I'm going to make another puncture here. Yeah, okay. Then I think
Again
we
we
are
aspirate.
already. Yeah, already.
Yeah.
And just insert. Yeah. No.
VisiGlide.
VisiGlide. Mm-hmm. After saline, we can inject VisiGlide. Yeah. Insert VisiGlide guide wire.
So for Rendezvous, I think Terumo wire is better
Yeah.
because we have to negotiate it through the papilla down.
Mm-hmm.
For doing a CDS, we need a stiff wire.
Yeah.
So VisiGlide should be good enough for that.
Okay, fluoro.
Yeah.
Can we have the fluoro enlarged?
Yeah, we can see it here.
Big fluoro.
It is
is
passed,
inside.
Okay, yeah, okay. That's it.
How
It's
did?
gone. It's
How
gone.
did? Okay.
It's gone.
And from here, yes. This coordinated movement is important. Yeah, push. Now the guide wires went deep inside to the left intrahepatic duct. Yes. Yeah. Sorry, I think previously I made a mistake. I was used to my speed in our hospital, but the speed here of removing guide wire, inserting guide wire is a little different, regional difference, I think. Yeah, now we are going to use cystotome. Yeah.
So you want to do it fast now.
So these procedures require a lot of patience. What do you say, sir?
Yes. And
of
also,
patience, lot of coordination.
yeah, coordination. The teamwork is very important, I think. Yeah, this is guide wire. We can see it through the EUS view. And the fluoro, we need to check intermittently. Yes. This is cystotome 6 French? Yeah. Yes.
Yeah, we are using a 6 French cystotome.
Is the setting is okay, cystotome? Yeah. I think the cystosome is out now. Yeah, you can see it. Yeah. And again, this is important. While pulling the guide wire out, I'm trying to push the cystosome inside. Yeah. Cauterize. Start. Which one? Which one? Setting. Not there.
Is it cut? Coagulation. Yellow is cut.
Cut. Yeah.
What लगा? लगा? सर 70 कर. बस. ठीक है.
I don't know the setting of cystosome. Yeah. Is it ready?
Yeah, maybe.
Okay. I will try to push it. Pull the guide wire back. Yeah.
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 Got it.
Then, but just to ensure, push the guide wire. In my case, I remove the cystosome one time and push it again to secure. Yes, okay.
Okay, that's
now
a
I
very
am satisfied. Yes.
That is a very good
Now we are going to
technique which you
insert
showed, yes.
hurricane balloon, 4 millimeter.
Fluoron.
Fluoron.
Yeah, just keep checking the wire.
Yes. Okay. After hurricane balloon dilation, we are going to insert stent.
You are using a 4 mm Helicon balloon or
Yeah,
a 6?
I think a 4 mm is good enough for the insertion of metal stent.
Right.
Yes. 4 millimeter means 12 French, so.
Yeah.
But after puncture, as if we do long procedure, there is leakage of little by little by leak into the retroperitoneal space. So after puncture, it's better to shorten the procedure time.
That's right. You prefer to use long stents or do you prefer to use a short
long enough not to migrate.
Right. Because
Migration is important.
That you use as long a stent as possible.
Yes, I think this is fluoroscopic. Okay. Hurricane balloon dilation. Yeah, I will try.
Can you see the balloon? The marker has gone inside.
Yes.
And the second marker is just by the side
about
of the
to
scope.
release.
Yeah.
Yes. Dilation. It is dilated.
Yeah.
We are using contrast, but here it is water. Is contrast?
No.
This is saline.
This is only saline, just to save the balloon.
Yes, to use repeatedly. Okay. I think it is.
See on the fluoro. On the EUS view.
Yeah, EUS. This is. Yeah, dilated balloon. Okay.
Yeah.
Really. Okay. Deflate the balloon. Deflate.
You have dilated it up to 4 mm.
Just a moment.
Fluoroscopy, please.
Fluoro. I think I'm worried whether we just indented it. Deflated. Okay.
The only first marker has gone inside.
Okay, now I think we are we inflate again. Yeah.
Here?
Now it is.
Now the whole balloon is inside probably.
This whole balloon is inside. Okay. One more balloon dilation, just in case.
Yeah. Now you can see both the lines on the
line.
Can we enlarge the EUS view?
Can you show it?
Yeah, I'll show. Can you enlarge the EUS view?
Yes. Balloon is inflated.
This is the inflated balloon, and this is the waist here.
Yes. Okay.
Okay.
I
Again,
think,
make the
deflate.
CM big now.
And stent ready?
Yeah. Which stent you want?
I think. What do you think the what is the length?
We can use a 6 centimeter.
6 is good enough, I think. Yeah.
She's a short lady, I think.
Yeah. Everybody agrees 6 French is good. 6 cm length is good enough.
We always use a fully covered stent.
Yeah. Yes. Or just the tip part can be partially covered, yeah. In Korea, we have a specially designed stent for this kind of drainage, AL stent. during my talk, I will just briefly show it. Or American groups are using the axial stent for this kind of purposes, but here we are going to use Boston.
Yeah.
Boston, yes.
It's a wall flex Boston stent, fully covered.
It has a flared end. Because of the flare, I think it can prevent the migration a little bit.
Yeah.
Yeah.
The only issue sometimes we face is this is a short exchange system.
Okay. Now I'm going to try to insert stent. Yes, stent distal part went inside.
Yeah.
We need to see the proximal, I think from here.
It will still come.
Yeah. From here, I want to release the proximal part little by little. Fluoro picture, please. Do you keep?
Is on.
Oh, it's different. Huh? In Korea, we save the picture. And then release the distal part slowly. Slowly, fluoro on. Yeah, slowly. Yes. Now the distal part is releasing. Stop here. And then, yeah. Yes, I think release more. Yeah. Yes, release more. Just stop here. I think from this point, it is very important. Just release a little bit more. Now, this.
Can we have the endoscopy picture?
Yeah, release. Yeah. Just a moment. Endoscopy. As you see here, as time goes, there is a little by little leakage. So.
It's on, lamp is on. Lamp on.
Endoscopic view is not. Then just use fluoro.
Just give a moment.
Then I think I'd rather use the EUS and fluoro. Okay?
The machine has stopped working for a reason.
Yes, just the fluoro and the EUS is good. We need to release. We don't need to spend much time. Fluoro, big fluoro. Yes. I'm going to release a little bit more. Yes. Release a little bit more. Just a moment. Yes. I'm adjusting it now, like this. Yes, release.
You are releasing entirely under endoscope.
Yes. This is push.
Endovision is not seen.
Push. Huh? It's fully.
Yeah, it is deployed.
Fully deployed now. Yes.
Stuck and see the.
Yeah. Yeah. Fluoro. I'm going to remove the fluoro. Yes. Now, I want to see the endoscopic view, but EUS endoscopic view is not working now. Yes. I think the fluoro, stent is deployed. Yes.
On endosono, we can see the stent.
Yes, and also
the
contrast is coming down.
From into the bowel. Yeah.
Yes. Thank you.
This is excellent. Under adverse circumstances, the endoscopy picture has just gone down. We are not seeing the endo view, but still, excellent demonstration, sir.
Thank you very much. Yes.
Now it has come. You want to see?
Yes, Amol, you are on. Yeah.
Okay, so in the meantime, we tried a couple of times with the CPD and from the duodenal position, but we were still going into the proximal tree. So what I thought was we'll shift to the transhepatic route from the G junction. So you can see the left lobe with the dilated intrahepatic ducts And I'm going to puncture one of these now. And then we'll see if we can get the wire down. Doppler gun. Air बाहर जाती है इधर. There's too much of air going inside. Because I think I may need to use a dilator in this situation. Without that, I will not be able to, traverse the duct, because the angle was very acute, and that's not something which I like. If I have to use the dilator, I prefer the hepatic approach, because the liver parenchyma gives you that cushion that even if you have dilated the tract, then it's not going to actually affect much. I'm going to put in a little bit of more contrast and saline, and then there's too much of air going in for some reason, I don't know why. Okay, so now let's try. खाली पापेलरनं बाहेर काढायचं. ती खाली जाऊन वरती येणार आहे. Yeah, segment 2 duct. मागे जाते मी मागे घेऊ थोडीशी. Okay, so the wire is gone down now. Let's see if we can get it out of the papilla. Papilla bahar kadayche. Otherwise, what we'll do is we'll pass a dilator now. Yeah. Now keep your hand on give the image of Vilas's hand, because this is the short wire exchange that is very important. We are keeping the fluoro intermittently on. I am holding the wire with the elevator, but the EUS scope elevator is never that strong, so you still have a possibility of a wire slippage. You need to monitor this very carefully. Make sure that that loop in the distal bile duct doesn't open up slowly. You need to keep the needle very straight. Okay, and you need to hold this wire over here like this as soon as your needle comes out. So I am continuously holding on to the wire. Now I use the other suction button on the biopsy forceps channel, so that there is no spillage of contents. And now we are passing this ultra taper 6 French dilator over the wire, because the dilator gives you the advantage that you can get it into the bile duct and then you can maneuver your wire in a better way. It acts like a cannula. Now, one trick about advancing your dilator is keep your EUS in vision. You keep the wire under vision and EUS, and then advance the dilator in gentle maneuvers. Keep your up knob very tightly pressed and gently with small increments push the wire, get the dilator inside. Okay, so the dilator is deep down there. And now let's try and get the wire out. Using the dilator, the advantage is now you don't have the fear of your wire shearing, which you have with your needle. So
Gone. It's gone.
नहीं, not yet. It has not come out. फार मोठं केलंय का?
This is in the duodenum, I think.
It has gone inside, Amol.
Okay, I'm advancing.
Dilator, yeah.
Okay. Now that's just the angle probably. नहीं तो मागे क्यों ना तो सरळ जायला लागेल. Yeah.
Yeah, it is inside the duodenum. Yeah.
There.
Yeah.
So now that's gone into the duodenum. Okay. So push your wire deep inside now. नहीं मागे घेऊन पुढे जा ना. माझा ॲडव्हान्स झाला पुढे. Maybe.
Short wire, right?
Okay, this is passed. So now my dilator has gone beyond the papilla into the duodenum. Is anyone still there?
Yeah, everybody is here.
Okay. Because I wasn't getting any response from that side.
Are you going to change the wire now?
Yeah, we'll change the wire. We may actually. Do we want to change the wire or do we do a? Okay, so we'll change the wire since we've got a dilator inside.
Yeah.
Contrast टाकायचं का थोडं duodenum confirm करायचं. We'll just confirm with contrast that the dilator is in the duodenum. Yeah, there.
Fine.
Because that will make my exchange easier. However, if I am using only the needle and if my wire comes down with the needle, in that situation I will not exchange for a longer wire. In that case we will go ahead with the short wire exchange. Okay, so that's deep inside. एवढं पुरे स्कोप काढायचं बदलायचं आहे. ते वायर ती डीप नाही जाते. ती लूप होती. तिथेच लूप होती. Yeah. Yes. Yeah, I'm pulling it, but thing is that loop is not opening up. So I just want that wire to go straight into the duodenum because that will make things a little bit easier. Okay, now that is really nice and deep. Okay. So now what I'm going to do is I'm going to, one of the possibilities with Rendezvous is that your dilator, there can be a leak. So let's leave the dilator inside. Let us leave the dilator inside and we pass the scope by that side of the dilator. Because otherwise you'll have a leak of contrast from the liver parenchyma. You don't want that to happen. ते कट करून टाक ना ते कट कर म्हणजे मग we can leave that. Yeah, go to that room and come back. Till then I'll take the scope out and we'll pass in a side wing scope. No, we'll use a catheter to push.
Oh, okay.
We'll use a pusher.
So I think there was 2 pieces in between.
Yeah. Okay. Okay. I think we are on now, are we?
Yeah, we are.
Okay, I think the purpose of this particular examination, I think you heard the story, have you?
Yeah, no.
Okay, let's hear the story first.
Okay, I'll summarize this patient. Is a 78 years old female who has diabetes since 10 years, and recently since last 3-4 months she has epigastric dilating pain and significant weight loss and loss of appetite. For that, CT scan abdomen was done, which has shown a large pancreatic mass in the region of body and tail, and that has been infiltrating into surrounding structures. So the purpose of this EUS examination is to assess the vascular, to assess whether what is the extent of the lesion, what is the vascular invasion, and further on what new findings we can get there.
Okay, thanks. I think with me is Dr. Gupta. He's going to also help me with the description as well. So I think the usual thing, we are now in the stomach. The purpose of this examination as well as the learning issue is to examine the tumor relation with the different vascular structures. So I think the usual thing, we use our landmark as a descending aorta. First bifurcation obviously is where the ciliac axis is coming off, which is over here. Okay, so nice ciliac axis. So as you trace in, the stomach is a bit distorted because the tumor mass, which I'm going to show you later on, is very massive. Okay, so I think you trace the vascular structure, ciliac axis, and its relation to this mass which is here. Okay, you can see that this ciliac axis bifurcate into two different vessels. Okay, so one is a splenic artery which is going up this way, and the second one is a common hepatic. So in this particular case, I think clearly there's a tumor which is encasing both these arteries, the splenic artery as well as the common hepatic. At the same time, it's also the ciliac artery is involved. And the mass is, I think we have to kind of scrutinize the mass a bit further. And if you look at over here, and as we turn around clockwise now, you can see that the mass is actually quite massive. It's very big. Okay, so it's very big, and with the PD which is going in, we can check using the flow. I think right in the middle is probably the PD. I think the cursor can go to the PD. There's no vascular thing going in. And then below here, I think suspect this is probably going down a bit. Probably is beyond our scan thing. Yeah. So I think it's probably either a necrotic part or cystic structure in this particular big mass. So it's rather big. And we measure, I think it's in excess. We probably will try to measure this mass, which is huge. I think here is probably about 5 to 5 cm or so. Okay, we'll unfreeze it. And I think important is now we have some information about the vascular relationship to this mass. And we want to see the whole extent of the mass. And then I'm just going to turn anti-clockwise. And you can see that there's also a sort of a mass within the mass structure just over there. And it seems that I think this is probably the dot with the echo shadow below, posterior to it. Almost looks like a calcification.
Some lymph nodes.
And also there's some lymph nodes. Yeah, change of lymph nodes, peripancreatic lymph nodes. So I think we're just going to turn around here, going back to where we saw the relationship between the hepatic, the relation between this mass and the vascular structure. So I'm going to pull across here. You can see the whole extent of this particular lesion here. I think we probably will also be able to see the relation with the splenic vessels as well. Because, okay, so you can see the, I think Dr. Gupta just pointed, I think below that, this one is a SMA, which just skirted down. Just skirted down. So you can see that just below here is a SMA, which probably is spare. And then to the left of this thing, we believe that, I think to the left, which is up there, is probably the splenic vein, which is going up here. So I think the tumor has certainly involved quite a number of vessels in this patient. Okay. And obviously, I think with this sort of tumor with multiple vascular invasion, we also like to look at the particular the liver as well. So I think we will have a quick look at the liver. So this is where the liver is. I think we'll. Oh, no problem.
Okay. I think
We will do a FNA now. Yeah.
I think they're going to. I think they're going to change to the other room. So while they're doing that, we'll do an FNA and come back.
Are we online or are we on?
Okay.
Okay, great.
So I've got my the duodenoscope down, and you can see the wire coming out of the papilla. And normally I will try and alongside with the wire cannulation technique. And only if that fails, then I will try and retrieve the wire using a snare, because it saves time and also the wire very often. So what I'm going to do is I'm just going to go by the side of the wire and bend a little bit. Let us see if we can go in. No, okay, no, wait, wire. We just carefully observe where it's coming out from, and then just cannulate by the side. And usually you'll be able to get in. Bend a little bit, both the sphincter tone, bend. Okay, try. No? Okay. Okay, now try. I'm going in somewhere. Wait a minute. Okay. Okay, now see, थोड़ा bend करूँगा, bend. थोड़ा सा bend कर लें. Slipped out. वायर नहीं है. Bend कर. Okay, see. Is it in? Yeah. Or is it the pancreatic duct? No, that thing is. Yeah, it is gone in. So that's in. So now, once you are inside, then you can just pull out this wire from the mouth. You can just pull this out, and now we can just complete the ERCP in a standard way. So I think this is a course of for EUS and not for ERCP. So we can move on to Lawrence over there. Okay.
We just did one puncture. We're going to demonstrate the second puncture, but before that, I thought it may be good to just show a bit of elastography as well, even though I think sometimes, okay, just over here. So we're just going to show some elastography just to demonstrate that this mass is actually a normal mass with the stiffness. So we're just going to, once we capture the thing, we'll just freeze it and look at this thing, because it comes intermittently. And we can narrow down the thing. We can narrow down the, yeah, probably narrow down this thing. Okay. So I think you can look at it. You see that the majority of the mass is actually blue in color. and maybe a softer part up there, which is the red and the green. So I think majority is actually the blue. I think Rajesh Puri gave a talk on that. So just going to go through the motion of showing you the strain ratio to demonstrate that the cutoff number of 6.2, the magic number, is actually correct here. So we're just going to measure it. If you look at my cursor, we just do this kind of dot. Once you put a strain ratio, there's this dot here, and then you set it the place you want to. And then generally I set it just an arbitrary circle, big enough so as to reduce the sample error, and then you set again, and then you go to the next area as a way of control. And generally I tend to actually set the same diameter. So you just set it over here, okay? So I think you have two reference points, and you set it there. And then over there you can see that the bottom thing, he spoke about strain ratio. So I think in this case, I think 6.2 was this magic number. So clearly this mass is 20.38. So I think it's considered to be abnormal. It's considered to be highly likely to be malignant, according to studies anyway. So I think we don't need this to prove. Tissue is the issue still. So we still have to do the second puncture.
So we'll be shortly starting the lectures.
Sorry?
We'll be starting the lecture soon, actually.
Okay. Yeah, we'll do the thing offline then. We already puncture once. Okay, you can do go ahead and do the lecture if you need to. Yeah, we'll do a FNA one more time, although we already punctured it once.
Thank you, sir. Thank you for chairing this session.
Hello.
Thank you.
Dr. Date. Dr. Ho is going to do an FNA pass, and then you can probably start.
Yes, yes.
Yeah.
Okay, so very quick, we already have one pass, so I'm going to do the second pass, probably without stylet. It's okay. With no stylet, the second pass. There's no difference between whether you put stylet or not. I think the first one generally, because the stylet is already there, that's why we just put it in. But the second pass has no necessity to put the stylet. Okay? So I think then we just get the shift out first around here. I think once we feel that the shift is there, we'll just lock it there. And then after that, I'll release the needle from the thing. So I think the position is actually a bit more tangential. So I'm going to push back to the left side of the screen. And sometimes it's still not possible. So what I do is I give a bit of elevator here and just go in. Okay? So it's very quick step in. And then we try to avoid the necrotic area as possible. Okay? So I think we just put it here, and then after that, my assistant here is going to just do the slow pull, which is the simple part. Okay? We can just do the slow pull, and just going about 5 strokes in every position, and then I change the trajectory a bit here, and then again, I think with the change in the trajectory, we again go in another 5 strokes, and then after that, I pull almost out, and then change again, so that we get samples from as many trajectories as possible. Okay? So I think in this way, hopefully, we have a very good yield from this particular mass. Okay? So I think we're going to finish here so that I think you can go on with the lecture. Is that okay? Okay, great.
Sounds good.
I think we finish.
Okay, Dr. Date, you can switch over to the audience for the lecture.
Okay, great. Thank you.
We are starting the last 2 lectures by Dr. Sandeep Laktatia and Dr. Amit Maidev.
Thank you.
I'd like to call upon the chairpersons for the session.
Yeah.
Dr. Rajesh Dharamsi, Dr. Parimal Lavate,
Yeah, I think so.
Pravir Rai,
Yeah.
and Dr. Krishnaveni Janardhanan.
Let me switch this one off.
I would like to call upon the chairpersons for the session, Dr. Rajesh Dharamsi, Dr. Pravir Rai, Dr. Kakrani,
So good evening, everybody. We now go on to these lectures. We'll have two of them. The first one is by Sandeep Laktakia from AIG, and it is Practical Approach to Cystic Pancreatic Lesions. When you see this, there is always a dilemma as to what should be done. So he'll try and clarify whether we should aspirate or drain or just observe them. Sandeep, yeah.
Thank you, sir. Good evening, everybody. After an exciting day at Pune, we come to the last part of this first day. We had wonderful cases and talks and demonstration and discussion. I'll be touching upon pancreatic cystic lesion, whether to aspirate, drain, or leave alone. I'll quickly run through the slides because most of the things have been discussed live. Actually, some of the cases were there. We often see these kind of cysts in pancreas on incidental imaging, and such lesions or incidentalomas are often in asymptomatic patients, which were accidentally detected by imaging done for some other reason. And these kind of lesions will keep increasing because the number of cross-sectional imaging, the health checkups for a variety of reasons is going up and up. And majority of these lesions are asymptomatic, and patient never gets it for the reason that it is there, but for some other reason it is picked up. But why do we need to worry about these lesions? The foremost question is it malignant? Both in the patient's mind as well as in the doctor's mind. So there's fear and anxiety which leads to one thing from the other, and that adds to the cost for imaging, further investigations, follow-up, repeated evaluations. And the second important question associated with this topic is that if it is not malignant now, can it become malignant later on? Having said that, we need to know what are the pancreatic lesions which can appear like that. The commonest is pseudocyst. The pancreatic lesions per se from the parenchyma without any past history of pancreatitis would be either serous cystadenoma, mucinous, or IPMN. Some of the malignant solid lesions can also have a cystic appearance like neuroendocrine tumors or adenocarcinomas, and rarely lymphatic cysts or inclusion cysts can also have this kind of presentation. But this list is a textbook list. We don't have the diagnosis and then we go backwards. We have a cyst in hand and we need to find out what we are dealing with. So the first and foremost thing is that we need to find some of the features, whether it is malignant or potentially malignant, is look at whether the cyst has any solid component on any imaging that you have, be it CT, MR, or EUS ultrasound. Duct, that is pancreatic duct in relation to the cyst, whether it's dilated upstream to it. Does the patient have any other obstructive features like obstructive jaundice, if the cyst is present in the head or neck, any presence of nodules, and if you have done a FNA, is the cytology suspicious or suggestive of cancer? If any of these features are present, then the risk of malignancy is high and such patients should undergo surgery. But if none of these are present, which is often so, then the negative predictive value of such a scenario is 100%. That means there is no malignancy at that moment in time. Future is different. So some of these lesions on the left side of the panel, like serous cystadenoma, pseudocyst, lymphopithelial retention, all these things do not become malignant. Whereas pre-malignant and malignant lesions are IPMNs, mucinous cystic neoplasm, solid papillary neoplasm, we saw one today, metastatic lesions, and adenocarcinomas and NETs which can go into cystic degeneration. Having said that, there are few salient features pertaining to each kind of cystic lesions. Serous cystadenomas almost always are benign. There are only case reports of malignancy which are also doubtful. Solid pseudopapillary neoplasms are pre-malignant if they're not malignant at that time and should always be resected. MCNs can be invasive in course of time. Main duct IPM carry in high malignant potential, and risk of cancer in such lesions, that is SPN, MCN, and main duct IPMs actually increase with passage of time. So how should we approach these lesions? The first step is, since pseudocyst is the commonest, we should differentiate pseudocyst from the classical cystic neoplasms. And a pseudocyst will always have a history of pancreatitis, either recent or remote. Second, we need to determine whether cyst has that malignant potential, and there also the history comes into picture. Patient has weight loss, some imaging, either ultrasound, CT or MR, EUS evaluation and cyst fluid analysis. I will be touching about briefly one by one on these things. Imaging first. All imagings, we need to look at the pancreatic parenchyma also away from the cyst. Sometimes you have chronic pancreatitis with a cyst and patient never had a pancreatitis in the past. You will have changes of calcification elsewhere away from the cyst, duct dilatation or irregularity on MR. Size and location, multifocality of the lesion, presence of septa within the cyst, calcification, a very important feature. If the calcification is present within the cyst, then it suggests serous cystadenoma, a sine qua non of serous cystadenoma. So you need not follow up these patients further. You just reassure yourself and the patient and give him positive vibes. But if there is a peripheral calcification or rim calcification, that is a feature suggestive of mucinous cystic neoplasm. Not seen in all, but about 10 to 15% may have this kind of a feature. If it's present, then you should be alarmed about it and also make the patient aware that if not malignant now, there's a potential of becoming malignant later on. Obviously, cysts and polyps, solid or polyps can also suggest malignant transformation. Depending on the location also you can suggest. Pseudocyst can be anywhere, serous cystadenoma can be anywhere in head, body or tail, but IPMNs generally are in the head, but side branch can be there in the body and tail as well. But look at MCN, it's generally in the body and tail. Also, the sex of the patient. If you have a cyst in a female in a body or tail, its possibility of a MCN is high. But if a male patient has a cyst, then it cannot be a mucinous cystic neoplasm. This is a very important point which I want to kind of push across, that males do not have mucinous cystic neoplasm. The histology of MCN has struma ovarii, and which is an ovarian kind of a tissue, and males will not have ovarian tissue. If it's positive, then you start checking the sex of the patient, whether it's actually a male or a female then. Location, I said earlier, body tail more likely to be MCNs. So imaging can be in form of MDCT or MRI, but the radiology consensus say that MRI is superior to CT, although both have their pluses and minuses, but overall MRI is superior and there is no extra advantage of a contrast MRI. A regular MRI with MRCP would give you enough information from the radiological perspective. Coming to EUS, which is another radiological imaging done by us, it gives high resolution imaging, real time, so you get both external as well as internal evaluation done. And I said earlier, some of the classical features I have just enumerated here. If you see microcysts, I'll show some of the images next. These are multiple tiny cysts less than 3 millimeters together in a compartment that's suggestive of a cystic neoplasm, serous cystadenoma. If you have a central stellate calcification, I said earlier, if calcification is there in the center of a cyst, it's sine qua non of serous cystadenoma. Also, some of the cysts can have a solid appearance. They will be blighting up on CT scan, and this will have a honeycomb kind of appearance. Although this is also called a solid variety of the serous cystadenoma. So all these three features, if you see, they are features very strongly suggestive of serous cystadenoma, and you need not FNA them also. Pseudocysts will have a history, and they are a very classical appearance. They will have a well-defined wall if mature enough, with fluid and fluid with solid component inside. So this is one of the cystic lesions in the head of the pancreas, large, looks debatable or looks maybe malignant, maybe IPMN type of thing, but if you see it on EUS, it has very thin septa, very well defined outline of wall, and it has a solid component and a liquid part also. If you see the solid part carefully, this is not that solid mural nodule, this is the microcystic variety of serous. So one cyst can have both the large